investigations, they give you same diagnostic accuracy, and so you can decide. And in general, we clinicians seem to be most comfortable with MRI. Good morning, everyone. I'm extremely
morning, everyone. Can you hear? On behalf of Yashoda Hospitals and Organizing Committee, I welcome you all for the second day of IBD Update 2022. So we got an exciting program lined up and speakers ranging from India, UK and USA and also from Australia. So I hope you will have an enjoyable session today. So this morning session we have 4 talks. For these 4 talks we have 2 chairpersons, Dr. Srinivas Murthy, from a senior gastroenterologist from Kakinada. Please come over to chairman position, sir. And we have actually Dr. Chanchal Ghosh, a senior gastroenterologist from Bangladesh, but I think he's got some issues logging in. He'll join whenever he can. First topic is management of fistulizing Crohn's, which is often quite challenging for many gastroenterologists. So to deliver this talk, we have one of the top IBD specialists from India, Professor Vineet Ahuja, who doesn't need any introduction to any of the gastroenterologists. He's senior professor at All India Institute of Medical Sciences. So we'll be playing his recorded version, then he will be joining us for Q&A. So to moderate this session, I request Dr. Rakesh Adi, who is senior gastroenterologist at Yashoda Hospital Secunderabad, and Dr. Gopal Krishna, concerned gastroenterologist, gastrocare, and to moderate this session.
Good morning, everyone. I'm extremely grateful to Dr. Kiran Peddy and the entire team at Yashoda for inviting me to give this talk. I'll be talking about fistulizing Crohn's disease, essentially perianal Crohn's disease. I put across out here 7 or 8 issues which I feel are very relevant for managing a patient with perianal Crohn's disease. If you are aware of these issues, if you have clarity in your mind how you're going to solve these issues, you can take care of most cases of perianal Crohn's disease. The first thing which any treating physician would like to know and should be aware of in a case with perianal Crohn's disease is what is the anatomy. We know that there are external anal sphincter, there is internal anal sphincter, and then there is the puborectalis muscle. We should be aware of the alignment of these sphincters and puborectalis muscle. Then comes the next thing, whether it is a simple fistula or a complex fistula. It should be clear right from day one because that is going to decide how you are going to manage the case. Is it difficult to make that differentiation? No. Simple fistula have a low origin below the dentate line. They would have a single external orifice. They are not associated with perianal abscess. Rectovaginal fistula or anorectal stenosis are not seen in simple fistula. Simple fistula are very easy to treat. Complex fistula, they would have a high origin above the dentate line. They may have multiple external orifices. They may have an associated perianal abscess or rectovaginal fistula, anal stenosis may be seen. Another classification is Parkes classification, which you really don't know, but you should be aware of the terms because when the radiologist or the surgeon talked about it, it is helpful to know about the terms. Let me put it this way. Most important is simple versus complex. Subsequently is, okay, whether it's an intersphincteric fistula, it's a transsphincteric fistula, it's an extrasphincteric fistula, or it's a suprasphincteric fistula. The point to be noted out here is, apart from superficial fistulae, rest all of these fistulae are going to be complex fistulae. So once I'm aware of the anatomy, how do I decide that in my patient?
यूट्यूब का शेयर करो जूम में लाइव लिंक आशीष आशीष दीनी लाइव आरिफ इसको लाइव करो, जूम इसमें इसको लाइव करो जूम में. అప్పుడు వినిపిస్తుంది సార్ connection. डन स्टार्ट करो. కొంచెం చేంజ్ చేస్తాను. ఏదైనా సెట్టింగ్స్ రాకపోతే దాని దాంట్లో యూట్యూబ్ లింక్ మేము డైరెక్ట్గా షేర్ చేస్తాం. దే కెన్ సీ, దే కెన్ లిసన్.
Very grateful to Dr. Kiran Peddy and the entire team at Yashoda for inviting me to give this talk. I'll be talking about visualizing Crohn's disease, essentially perianal Crohn's disease. I put across out here 7 or 8 issues which I feel are very relevant for managing a patient with perianal Crohn's disease. If you are aware of these issues, if you have clarity in your mind how you're going to solve these issues, you can take care of most cases of perianal Crohn's disease. The first thing which any treating physician would like to know and should be aware of in a case with perianal Crohn's disease is what is the anatomy. We know that there are external anal sphincter, there is internal anal sphincter, and then there is the puborectalis muscle. We should be aware of the alignment of these sphincters and puborectalis muscle. Then comes the next thing, whether it is a simple fistula or a complex fistula. It should be clear right from day one because that is going to decide how you are going to manage the case. Is it difficult to make that differentiation? No. Simple fistula have a low origin below the dentate line. They would have a single external orifice. They are not associated with perianal abscess. Rectovaginal fistula or anorectal stenosis are not seen in simple fistula. Simple fistula are very easy to treat. Complex fistula, they would have a high origin above the dentate line. They may have multiple external orifices. They may have an associated perianal abscess or rectovaginal fistula, anal stenosis may be seen. Another classification is Parkes classification, which you really don't know, but you should be aware of the terms because when the radiologist or the surgeon talked about it, it is helpful to know about the terms. Let me put it this way. Most important is simple versus complex. Subsequently is, okay, whether it's an intersphincteric fistula, it's a transsphincteric fistula, it's an extrasphincteric fistula, or it's a suprasphincteric fistula. The point to be noted out here is apart from superficial fistulae, rest all of these fistulae are going to be complex fistulae. So once I'm aware of the anatomy, how do I decide that in my patient it's a simple fistula or a complex fistula, or how do I decipher the anatomy out there? There are 3 modalities: MRI pelvis, Dr. Kiran Peddy and the entire team at Yashoda for inviting me to give this talk. I'll be talking about visualizing Crohn's disease, essentially perianal Crohn's disease. I put across out here 7 or 8 issues which I feel are very relevant for managing a patient with perianal Crohn's disease. If you are aware of these issues, if you have clarity in your mind how you're going to solve these issues, you can take care of most cases of perianal Crohn's disease. The first thing which any treating physician would like to know and should be aware of Hello.
You can share your screen, sir.
Okay.
Start like
I'll share my screen. Okay. Thank you, Kiran. So, sorry everyone. Sorry for the delay. I'll just share my screen. And are you able to see my screen, Kiran? Hello.
Yes, sir, it is visible.
Okay.
Visible.
Okay. Thank you, Kiran, and grateful to you and the whole team at Yashoda for giving me the chance to speak and for organizing what promises to be a very, very interesting meeting. I'll be talking about fistulizing Crohn's. Essentially, I'll be talking about perianal fistulizing Crohn's. Now, I put up out here 7 or 8 points. These points, I think, are the basics which every treating physician should know when they come across a case of perianal fistulizing Crohn's. And if you know these points, I think majority of the cases you can treat very easily. First thing you have to be aware of, what is the anatomy? If you don't know the anatomy, you'll never be able to treat well. So let me go through all these queries. When we talk about anatomy, you know that we have an internal anal sphincter, you have the external anal sphincter, and you have the puborectalis muscles. These are the three major landmarks. Out here, initially only, you have to make a distinction between a simple fistula and a complex fistula. Is it difficult to do? No, it's not that difficult. A simple fistula is something which has a low origin below the dentate line. It has a single external orifice. It does not have a perianal abscess. It is not associated with a rectovaginal fistula or something like that. Whereas a complex fistula has a high origin above the dentate line. It may have multiple external orifices. It may have a perianal abscess along with that and may or may not be associated with anorectal stenosis or rectovaginal fistula. Why is it very important to make this distinction right at the start? Because simple fistula is very easy to treat, whereas the natural history of complex fistula is, as the name suggests, very complex. They are difficult to treat. So initially only if you can segregate, okay, it's a simple fistula, this is a complex fistula, you are clear in your mind how you're going to treat this. Then there's what is known as Parkes classification. You may not know about this, but I'll still go through this because your radiologist would be talking about it, your surgeon would be talking about it, so also you would also like to appear somewhat knowledgeable. So essentially it says that the fistula can be intersphincteric between the two sphincters, suprasphincteric, extrasphincteric, transsphincteric, or superficial. But here, as you see, majority of these are complex fistula. It's only a superficial fistula, which may be a simple fistula. So essentially, again, what is more important is to decide whether it's a simple fistula or a complex fistula. So how do I see that in my patient? Whether a patient has a simple fistula or a complex fistula, there are three modalities available: MRI pelvis, examination under anesthesia, endoscopic ultrasound. All three of them have similar accuracy in terms of diagnosing perianal fistula, whether it is MRI pelvis or examination under anesthesia or a US. It just depends upon what kind of expertise is available at your center or nearby. Second thing is, okay, if the patient cannot afford much, so obviously it will be very difficult to keep on doing MRI. So their examination under anesthesia may be easier. But for a treating physician, somehow they're most comfortable with getting an MRI done because why? Because you have a baseline with which you can compare when serial MRIs are done over a period of time in a patient with fistulizing Crohn's disease. But overall, all three have equal accuracy. You can get any one of them. Third thing which you have to decide right now is, does the patient really have Crohn's disease or is it something else? Because obviously your treatment is going to depend upon that. So the first differential you should be aware of is idiopathic cryptoglandular fistula, or the commonest cause of perianal fistula. This is the kind of fistulas which are seen generally in surgery. These are the kind of fistulas which used to be seen 2-3 decades back before Crohn's up in large quantities. So one should be aware of idiopathic cryptoglandular fistula. How do you decide whether it is Crohn's or it is a idiopathic typical garden variety fistula? You have to do a MR or a CT enterography in every patient, as well as a ileocolonoscopy. If you do these two investigations, the cross-sectional imaging, ileocolonoscopy, you'll know any part of small intestine, large intestine, if it is involved. If it is involved, then this fistula is probably Crohn's disease. If that is not involved at all, then this fistula may not be related to Crohn's disease. Second differential you have to be aware of is hidradenitis suppurativa. That is inflammation of the sebaceous gland, which can become quite marked, leading to perianal sinuses, pilonidal sinuses, sinuses in the axillary region. This is also seen occasionally and is very confusing with Crohn's disease fistulae, but the only thing out here is that here fistulae generally do not form, and it is sinuses which are seen in such a setting. Surprisingly, the treatment for this condition as well as Crohn's, both of them, the treatment of choice is a biological or anti-TNF inhibitor. Third differential is tuberculosis. We are in a tuberculosis endemic country, so intestinal TB can present as perianal fistulae. But remember that of all cases of intestinal TB, only 1% present as perianal fistulae, whereas of all cases of Crohn's disease, roughly 10 to 20% of them present as perianal fistulae. How do you make the distinction? If you have any doubt, do a biopsy. The biopsy should show you caseating granulomas or AFB in a case of tuberculosis causing perianal fistula. Fourth thing, whom all do I involve in care? Is it like I am the sole treating doctor? I want to be the sole treating doctor. The patient should be seen only by me, and I think I can manage the entire scenario. Well, that doesn't seem to be true out here. You need a multidisciplinary team. If you do not have an MDD team, at least consult a colorectal surgeon. Radiologist has to be somebody who has to be keyed on with the case. You would also need a dietitian subsequently. How do I treat them? First, obviously, the patient comes to the physician. Like, how do I treat? Once I've made the diagnosis, it's a Crohn's disease perianal fistula. You have to treat two concepts. You have to treat infection. You have to treat inflammation. This is a very important slide. This slide, I believe, is the keystone of the whole presentation. And if you can understand the slide, you can treat majority of cases of perianal fistula very easily. What does this slide tell us? That there are two components, infection and inflammation. Infection drives inflammation, inflammation drives infection, and that is what happens in perianal fistula. So you have to treat infection. How do you treat that? With antibiotics, drain perianal abscess, ceton thread. That's a very cost-effective method of treating infection. How do you take care of inflammation? There is no doubt that in such a setting, top-down therapy should be the approach. So you should start with biologics, and you have to add azathioprine. Now, what is the next error which many of us often make? That is, we think, okay, we can treat infection, we can treat inflammation, or we need not treat both of them simultaneously. You need to treat all of them very, very much together, simultaneously, if you really want to achieve a good response. Patient of complex perianal fistula should have antibiotics. If an abscess is there, should be drained. A ceton thread is a must. Biologicals are necessary. Azathioprine should be added. These are the key components of successful treatment for perianal fistula, and this is the be-all and end-all of the story for perianal fistula. Which biological or small molecule would you like to use? There are many available today. As I've already discussed, azathioprine is kind of mandatory, I would say, for most of the cases. Amongst the biologicals, infliximab and adalimumab have the maximum experience available and also the highest chances of efficacy. Tofacitinib is not useful in Crohn's disease, so should not be used. Filgotinib, which is another JAK inhibitor, is coming up, still not available in India. That would have some use in fistulizing Crohn's disease, perhaps. But tofacitinib, no, do not use it. Vedolizumab data is emerging. Enterprise trial came up, but I still feel the data as such is not very wholesome in terms of advising vedolizumab either as a first-line therapy or even as a second-line therapy. You may use it only if you do not have any choices. The best second-line therapy if infliximab and adalimumab fail would be ustekinumab, which, however, I would say is yet not available in our country. Certain issues about biologics and perianal fistula are that longer therapy duration should be considered before you consider them to be ineffective. Generally, we feel that if you're given a biologicals for 8 to 12 weeks, that is sufficient before you call them off as a primary non-response. Like, okay, induction therapy given, no response, fine, call it off. However, in such a setting, I think that 12 to 14 weeks duration should be given before you call them off. Higher trough levels are required, so you would like to possibly give biologicals at 4 weekly intervals if you're not getting a response. And remember that you can stop biologicals even in perianal fistulizing Crohn's disease, but this is one subset where there would be highest chances of relapse. So you may continue them for a longer period. We said that we have to go to a colorectal surgeon. So what else can the surgeon do for us? If it is a low fistula, clearly surgeon can help us with fistulotomy, which really has very gratifying results. If it is a complex fistula, we have decided that a ceton should be put. What sit-on should be put? Should it be just a draining sit-on, a loose sit-on, or it should be a cutting sit-on? In general, most surgeons would advocate that cutting sit-on should not be used in a patient with complex perianal fistula, and a loose sit-on should be put. It helps us by decreasing the infection rate, and as I told you, I would consider putting it in almost every case. In cases where sit-on therapy and top-down therapy in the form of biologicals does not help, then surgeons can go on, like at our center, they do video-assisted anal fistula therapy. The results are okay, good, but the results are not that gratifying, I would say. Similarly, ligation intersphincteric fistula tract is done, but again here the results are okay, fine. But these these kind of techniques can be used, but in general, most patients would not require these techniques. What options do I have in refractory cases? I've given TNF inhibitors, I've given antibiotics, I've put in a acetone thread, I've added azathioprine, still the patient is not responding. As I told you, in our multidisciplinary team, we need to have a dietitian, and a dietitian always plays a very important role in such difficult to treat cases. Exclusive enteral nutrition has been found to be useful in patients with complicated Crohn's disease as an adjunct as well as the only treatment. In fact, what we have seen, the 2/3 of patients, they experience clinical response. Oligomeric as well as polymeric diets can be used. And people feel that, okay, enteral nutrition is going to be expensive. Well, it is, but not that expensive. In general, the daily cost would be somewhere around 600 to 700 rupees a day. So the month's cost would be as much as one shot of biological therapy. So it is expensive, but not that much. Second is that hyperbaric oxygen therapy is really useful in such cases in terms of decreasing inflammation. We have used that in stricturing Crohn's disease as well as in enteric fistula and found gratifying responses. In perianal fistulae also, it can be used particularly in difficult to treat cases. Here, generally the regime is you give 1 hour of session, hyperbaric oxygen therapy session. There are generally no side effects, and 10 to 20 such sessions, hourly sessions, are given spread over 1 or 2 weeks. There has been a very nice meta-analysis which has been done by Vishal and his team from PGI Chandigarh, which looked at hyperbaric oxygen therapy in IBD and found that particularly in fistulizing Crohn's disease, this meta-analysis showed that the responses were very good, 47%, partial healing in 34%. So if these chambers are available, they are generally available in many government hospitals, they would be very useful for such patients. Still the patient is not responding, go back to the surgeon, go in for a fecal diversion. Fecal diversion, everybody feels, okay, finally should be the panacea, but no. Remember that the response is only there. Initially, there would be a response, the response peters down. After 1 or 2 years, the response is only seen in 2/3 of the cases. But something which is more challenging than that is that you're not able to restore continuity in a large number of cases. This you should be aware of. We have mesenchymal stem cell injections which are available. They have already been FDA approved in Europe. We are running a clinical trial right now, and I have found some nice results. We have done 9 patients till now. I'm showing results of 6 patients, whereby you find that clinical response at 6% was 100% in 3 patients and 50% in 2 patients. And remember, all these patients were the ones which were very difficult to treat patients, which had exhausted most therapies. There was a radiological response to stem cell therapy, which we saw before stem cell injection and after stem cell injection. And there was also a clinical response to stem cell therapy. So it is running as part of clinical trials, but I'm sure in a year or so, it should be available on the market. Another special issue with perianal fistula is there is a risk of malignancy. Of the 112 cases which we have seen of fistula, we have found 3 cases which developed malignancy, obviously because there's so much of inflammation going out, which is continuous out there. So over a period of time, they seem to be predisposed to malignancy. So if there's a refractory case, be aware of it, that these patients can develop malignancy and go back in and do a biopsy, repeat a biopsy. Finally, like what options do I have if I'm treating a patient who really cannot afford anything? What do I do in such a kind of setting? Is there anything I can do? The patient cannot afford biological. He doesn't have those kind of below poverty line cards whereby that can be availed of in some hospitals. So what to do in such a setting? So there's a nice piece of data which has been put up by Sudhir. Sudhir is from Andhra Pradesh only. He's a very bright boy. He's done his MD from PGI Chandigarh and DM from AIMS. And subsequently, he did an IBD fellowship at AIMS. And now he's going to Canada to do a good fellowship out there. So Sudhir put up out here a cohort of perianal fistulizing Crohn's disease at our center. And the interesting part out here was that the patients who were only on azathioprine, some of the patients, they could not afford biological, so they could not be stepped down. What was seen was the patient who was only on azathioprine or methotrexate, 44% maintained a clinical response for a median follow-up of 4 years. That's a reasonably large period of time. So clearly suggesting that a subset of patients with perianal Crohn's disease respond well to immunomodulators. So please do not forget azathioprine. Please do not forget methotrexate. It works in some patients for sure. Tacrolimus obviously is a choice, but azathioprine is something which we are all very conversant with and very easy for us to deal with. One or two slides about enteric fistula. These patients can have intracutaneous fistula, ileovesical fistula, rectovaginal fistula, and all. So what are the principles of treatment out here? The principles of treatment out here is essentially these are very progressive cases. You need a top-down therapy, multidisciplinary care. You have to treat inflammation, infection. In addition, you have to treat malabsorption, malnutrition, and fibrosis. Here, the goal is intestinal preservation. You need not jump in for surgery. Why you don't jump in for surgery? Because you really want to limit your intestinal resection. So it's always best to control the infection with IV antibiotics, put in drains for percutaneous for the abscess drainages, and thereafter convert the urgent surgery to an elective surgery that limits the intestinal resection. And obviously you do add top-down medical therapy once you feel infection has been taken care of. In these enteric fistula Crohn's disease, a question is often asked by the IBD physician as well as a surgeon. Straight away, do we take up the patient for surgery, or should we give the patient anti-TNF therapy first and downgrade the inflammation? What do we do once the infection has been taken care of? So again, this is a nice piece of data which has been put up by Sudhir, and this is a multi-center thing in the sense that Dr. Desai's group from Hinduja also put in their data together. So this did answer this question well, that in patients in India, when infection was controlled, when they were either put on surgery or they were put on anti-TNF therapy, they have behaved similarly. In other words, you can straight away, should not be hesitant in putting even enteric fistula patients straight away on anti-TNF therapy, because initially the people would ask the question, there is a high risk of infection, what happens? No. What you see overall, that long-term treatment responses were equal in both these groups, surgery first or anti-TNF therapy first. So finally concluding, perianal fistula is not a very complex topic. It is management can be very simplified. If you are aware of the principles, you can treat every case of perianal fistula very well, provided you go through the steps carefully. The steps are first decide it's a simple fistula or a complex fistula. A complex fistula is one which has a high opening internally, multiple external openings, may have a perianal abscess along with that, may have plus or minus rectovaginal fistula and anal stenosis. How do you diagnose it? You can do either an MRI or EUS or examination under anesthesia. All three have equal accuracy. If it is a simple fistula, it's easy to treat. Complex fistula, difficult to treat. Simple fistula, you start with antibiotics. Thereafter, you can put in a ceton. You can, in such a setting, you can even put a cutting ceton, and or you do a fistulotomy. In a complex fistula, you have to put a ceton, a loose ceton, draining ceton, add antibiotics for sure, add TNF therapy, add azathioprine, all four. Continue maintenance therapy. And ceton can be taken off after 8 to 12 weeks or at best 6 months or something. Thereafter, you can keep on following the patients. Be not very enthusiastic in terms of stopping anti-TNF therapy in such circumstances. And finally, if the patient is not responding, either the patient goes in for some clinical trials like your IL-23, IL-19 clinical trials going on, or the stem cell therapy clinical trials going on, or you send the patient to the surgeon in terms of if they can't do anything, at least going for a diverting stoma. With this, I end my presentation. Thank you so much for your attention, please.
Thanks a lot, Professor Ahuja. It was an excellent talk and you made it really simplified. Any questions and comments from chairpersons and moderators to start with? We've got 5 minutes.
Hello.
For those on Zoom, there is a link being posted where you can watch the moderators and chairpersons as well.
Sir, good morning, sir. Dr. Murthy here, sir. Hello?
Can you hear the moderators, Professor Ahuja? You want to come here?
Hello, sir. Good morning, sir. Dr. Murthy here. Sir, nice talk, sir. And the problem is actually, you are suggesting most of the people cannot afford the biologicals. But in our cohort, at our place, most of them, even the complex fistulas, respond very well to the azathioprine, sir. With cetan, by antibiotics and azathioprine, they are doing very well. But we have started in the last almost 3-4 years, we have started only 3 patients on biologicals. They are doing very well.
Yeah.
They are doing very well with azathioprine if they tolerate it very well.
I fully agree with you, Murthy. That is why I showed you that paper by Sudhir, which showed that 44% of patients, they did well on azathioprine or methotrexate, and the response was maintained for 4 years. So there is no doubt about that if biologicals are not available, you should go. Azathioprine also does seem to help in this group of patients. And however, if biologicals are available, then it may be preferable in such a kind of scenario to put them on biologicals.
Yeah, that's true. And of the biologicals, which is most preferable, sir? Because we have seen...
Infliximab or adalimumab.
Yes.
Vedolizumab will not be very helpful in such a situation.
Is there any comparative study, sir, which is more preferable, or infliximab or adalimumab or anything like that?
So either one of the infliximab or adalimumab you can give. The most experience is available for infliximab. For vedolizumab, we have very limited experience which is available. Ustekinumab, again, they have experience which is available, but in general, ustekinumab, overall, I would say subsequently should show to be a very strong second line drug. So I would say that you can start with either infliximab or adalimumab.
Thank you, sir. Thank you.
Okay, thank you, Murthy.
Morning, sir. This is Dr. Rakesh Kumar, sir. That was an excellent talk, probably as usual for an expert of IBD. Sir, I just wanted to ask you 2 questions, sir. The first one is that when we are starting biologicals in a real-time scenario, what are the predictors you look at the patient which might make you think that this guy might not be responding well to the biologicals? I mean, are there any negative predictive factors there when you start off the biologicals?
So negative predictive factors, if we talk about perianal fistulizing disease, then the most important negative predictive factor is the presence of infection. If you start biologicals without taking care of the infection well, then the biologicals are not going to act, particularly if the fistula tract is active and very, very much in the sense that you have not drained it properly with the help of a ceton thread. Second important, most important factor is serum albumin. Serum albumin, if it is low, the biologicals are not going to act because obviously the half-life, in the sense the amount of time they stay in the blood would be reduced. Third thing is the oncostatin. Third thing is theoretical. That is like obviously cannot be done at any center. That is the oncostatin M receptors, which have been seen to be associated with that. But I think these 2 points are most important out here. Infection. Secondly is the serum albumin level. Third is that if you find that the quantum of inflammation is high, multiple fistula, you have horse-shaped fistula, multiple tracts and all, then there you realize that just the regular dosing of biological is not going to help. If you can measure the levels of biologicals, then obviously you would like to maintain higher levels than the one which you use for regular luminal Crohn's disease. However, if you're not able to do that, then just by looking at the clinical responses, instead of giving the maintenance dose of every 8 weeks, you can give the maintenance dose every 4 weeks initially so as to achieve the clinical response.
Okay. Sir, the other question I wanted to ask you was that, sir, we all agree that once you start the biologicals, the clinical remission or the symptom resolution may not always correlate with the complete healing of the fistula. So how do you go about trying to look for, when is the optimal time to investigate whether the fistula is completely healed? And what is your best way of trying to accurately look for the complete healing of the fistula, sir?
So you follow them up clinically. If they show that by 2-3 months, 50% healing of fistula, the drain in the fistula tract has decreased, you're happy continuing with whatever you're doing. Need not repeat a MRI or a EUS. Subsequently, at 6 months to 1 year, you find that the person is doing well. Fistulas have completely healed. Symptomatically is doing well. Biochemically, CRP and all are normal. Hemoglobin is normal. then in that case comes the decision whether you want to stop biologicals or not.
Yes.
So as I told you that amongst all cases of Crohn's, the fistulizing Crohn's, enteric fistulae or perianal fistulae, chances of relapse are higher if you stop biologics. So here, if you want to stop biologicals, best is to do a MRI or a US and you demonstrate healing. If you have demonstrated healing and Crohn's is also not active other places, then you can stop biologics. And so when we did the study along with Hong Kong, and what was seen was that when we stopped biologics in such a subset of patients, it was seen that the relapse rates were higher. But again, when you restart biologics, that is, you have stopped them, they have a relapse, you restart them, the response is again there. So you can do such a kind of, follow such a kind of thing.
Yeah. Thank you, sir.
Thank you, Dr.
If audience have any questions, I can take the question and pass on to him. Yes, ma'am. You can ask, I can pass on, or you can come.
What is the role of tacrolimus, sir? Topical tacrolimus. Nowadays, enema trial is going on. What is his experience with the
Professor Ahuja, the question is, what is your experience with tacrolimus? Enema and also local.
Tacrolimus has again been found to be useful, but as I suggested that we have hands-on, most of us have more experience with azathioprine and methotrexate. So try azathioprine and methotrexate. Still the patient is not responding and the patient cannot afford biologicals. Then you can give tacrolimus. Tacrolimus is like cyclosporin in a way in terms of responses. Short-term responses are very good, but the problem arises because you have to monitor tacrolimus levels, and then for a long time when you have to give, then often there is either a loss of response or you are not able to monitor the levels so well, and so you have to, in the sense, you cannot continue them for a long period of time. That's what we have seen.
Thank you, sir.
Whereas azathioprine, you can continue for years if the patient has got a response.
Thank you, sir. Any other questions? If any? Yes. Sir, the question is, the latest ECHO guidelines mentions about methotrexate.
Yeah,
As a
azathioprine or methotrexate, as I said. Both of them are excellent drugs. Tacrolimus, again, the cost, one is the issue of the cost. Secondly, azathioprine is something which you, in terms of you have used it so much that everybody is very comfortable in terms of using azathioprine or methotrexate. And if a patient cannot afford biologicals, then they should be the first line therapy rather than tacrolimus. That is what my understanding.
Question is, has it is set aside in the maintenance of fistulizing Crohn's, methotrexate?
Has it been? Pardon?
You want to come and ask? Sir? Has it been set aside in the maintenance of treatment of Crohn's disease? Methotrexate you're asking about, right?
Yeah, methotrexate is once, azathioprine and methotrexate are not very good for induction. They're mainly for maintenance. So the strategies you can use is that you start the patient cannot afford biological. You give antibiotic, you put in a ceton thread, and subsequently you start the patient on azathioprine. Azathioprine can induce a response, but after a period of 3 to 4 months. That is the issue. So patient starts doing well on azathioprine and antibiotics. Gradually you maintain azathioprine or methotrexate, whatever you want to, whatever you have started. So it can go on as maintenance regime for years, 4 years, 5 years and on. In fact, we have patients who are on azathioprine for 10 years now, and none of them have developed a lymphoma as yet.
Thank you, sir. So thanks for excellent discussion and talk, sir. Thank you very much for your time. We'll move on to the next session. So next topic is differentiating TB and Crohn's. We always debate on this topic and it's been going on for many, many years. So we got an excellent speaker to address this issue, Dr. Vishal Sharma, who is an associate professor at PGH Chandigarh. To moderate this talk, I request Dr. Shrikant Apasani, Senior Consultant Gastroenterologist at KIMS Secunderabad, and Dr. Naveen Polavarapu, Senior Consultant Gastroenterologist Apollo Jubilee Hills, to moderate this session. And Chairperson, I request you to continue, please. We'll take Dr. Vishal online, actually. Dr. Vishal, you can share your screen and start the session.
Is my screen visible?
Yes, yes, we can see you. Yeah, we can see your slides as well. Thank you. Over to you.
Thank you, Dr. Kiran, for the invitation to talk about this topic. And it is indeed a challenging task to speak after Professor Vineet Ahuja. Professor Vineet has done the largest amount of work in this particular area on discriminating intestinal TB and Crohn's. And as you will see, that I'll keep referring to his work in my talk. So this is an important problem that clinicians, gastroenterologists face across the country. And we have a rising incidence of Crohn's disease. And therefore, it is expected that there would be some amount of misdiagnosis. In fact, from this study, which was done in South Korea, you can see that 18% of patients who had Crohn's disease had been misdiagnosed as intestinal TB, and around 11% of patients who had intestinal TB, they were misdiagnosed as Crohn's disease. In fact, in India, more than half of the patients of Crohn's disease receive antimycobacterial therapy before a diagnosis of Crohn's disease is made. So I think what we'll do is that we'll start from a case, a typical case, which we will see a 32-year-old male who had chronic diarrhea for 1 year, often on abdominal pain, and he'd been evaluated somewhere with the IgA-SCA, which was positive. Colonoscopy was done, which had shown ulcers in the ileocecal area and in the rectum. And the biopsies were non-contributory and started on sulfasalazine and a low dose of budesonide. So the patient presented this time with abdominal pain for a week and obstipation for a day, with a bit of tachycardia and distended abdomen. And on workup, we found that MON2 and IGRA, which were done, were negative. Chest X-ray was normal. CRP and fecal calprotectin were both elevated. So this was the abdominal X-ray, which was consistent with intestinal obstruction, and the patient was managed as a typical case of intestinal obstruction, kept nil per oral, with an RT aspirate, and antibiotics were given, and the patient improved. So what are the possibilities? And certainly in such a situation, one would entertain the possibilities of tuberculosis and Crohn's disease, apart from other differential diagnoses. So are there any clues in clinical presentation which could point to one of the diagnoses? So if you have a shorter duration of symptoms, usually less than 6 months, presence of pulmonary lesions, fever, night sweats, or ascites, that usually favors intestinal TB. Presence of diarrhea, blood in stools, extraintestinal manifestations, and as elucidated in the previous talk, presence of perianal disease or fistulae may suggest a diagnosis of Crohn's disease. None of the clinical feature, though, is very discriminative, and pain and intestinal obstruction can occur in either of these two entities. So talking about IGRA, which was done in this particular patient, these are blood tests which were designed to detect latent TB infection, and usually we do them prior to use of biologics and small molecules. So we have 2 of these, quantiferon TB Gold and T-spot, and while one of them measures interferon gamma concentration in whole blood as a response to exposure to TB antigens, the other measures the interferon gamma producing cells as a response to TB antigens. The benefit, of course, is that there is no effect of previous BCG and it can be done on a single visit. But eventually, they are measuring TB infection or exposure and not disease, and therefore, they can be negative in patients who have TB in certain conditions, and they can be positive in those who have Crohn's disease, because that will depend upon the underlying TB exposure in a particular population. So they may be a good test in the West, but in India, they may not be a very good marker to discriminate TB and Crohn's disease. The other, of course, is the SCA. And if you look at this meta-analysis which was done for the diagnostic accuracy of these tests to discriminate TB and Crohn's, you can see that all of the Indian studies suggest that these tests are not likely to help in discriminating TB and Crohn's. And in fact, we do not use these tests in day-to-day clinical practice. So the patient underwent colonoscopy once the obstruction had improved, and you can see that there were ulcers in the colon, which were almost circumferential, and then there was involvement of the ileocecal area with ulceration, and even beyond that, you can see that the ileum appears to be involved, and we could not negotiate beyond this. So we know that there are certain endoscopic findings which may favor one diagnosis over the other. So circumferential or transverse ulcers favor TB, while longitudinal, serpiginous, or aphthous ulcers favor Crohn's disease. Cobblestoning is more frequent in Crohn's disease, while right colonic involvement, including the ileocecal involvement, favors tuberculosis. Pseudopolyps could occur in either of the conditions, as can skip areas. So none of these features, of course, is very, I would say, specific, but they can give an idea of the underlying diagnosis. So in our patient, you can see that there is ileocecal involvement and circumferential ulcers which favor tuberculosis, and a relatively long history with presence of chronic diarrhea, rectosigmoid involvement, the colonic ulcers were in that area, skip lesions, and of course, maybe ESCA positivity may suggest a diagnosis of Crohn's disease. So the next step is usually imaging, and this is taken from a meta-analysis led by the Ames group, where you can see that the presence of necrotic lymph node is very specific for the diagnosis of tuberculosis. The ileocecal involvement also suggests TB, but is not very specific. The features which suggest Crohn's disease are presence of Holm sign, skip lesions, asymmetric bowel wall thickening, fibrofatty proliferation, mural stratification, and a long segment involvement. Unfortunately, except for a necrotic lymph node, none of the features is specific for a particular diagnosis. Now coming to histology, once the biopsies are taken, the histopathologist should seek for granulomas, and if there are confluent large granulomas or multiple granulomas, they favor the diagnosis of tuberculosis. Fibrosis could occur in either of the conditions, and deep fissures are suggestive of Crohn's disease. Again, there are three histologic findings which give some degree of specificity for the diagnosis of tuberculosis. These are caseating granulomas present in around 1/5 of the patients, confluent granulomas, and epithelioid histiocytes which line the ulcer base. These may suggest the diagnosis of tuberculosis. The most important tests are, of course, the microbiological tests. Unfortunately, they are positive in less than half of the patients. AFB stain positivity is usually less than 5%. Culture positivity is usually less than 50%, and PCR positivity is variable. For IS6110, one meta-analysis suggested that the overall sensitivity is 46%, and for GeneXpert MTB, our meta-analysis suggested that the sensitivity is around 23% in intestinal tissue. So this suggests that negative mycobacterial tests do not exclude the possibility of intestinal TB. On evaluation, our patient had cryptitis, crypt distortion, but no evidence of any granuloma. AFB stain was negative, GeneXpert was negative, and the cultures were negative. So what we have is a conflicting picture. The CT showed mural thickening, no stratification, no lymphadenopathy, and there was an apparent lack of response to steroids. Of course, the dose was questionable. So what are the things that we can do now? So you could either treat it as Crohn's disease or as tuberculosis. So this is a paper which is in press from Ames Bhubaneswar, where 3 patients where there was a confusion between TB and Crohn's, they were administered a short course of steroids and they were hospitalized for that duration. All of them eventually turned out to have tuberculosis. And if you see that all of them had worsening of symptoms and one had dissemination of disease to the lungs, all of them became microbiologically positive, but this is a strategy with inherent risks. So usually what is done is empirical antitubercular therapy. This is after, of course, complete evaluation. And this is a remarkable study from Ames again, which showed that there is a clinical response in virtually all of the TB patients at 6 months. And here you see the orange bars, which is Crohn's disease. You can see that 1/3 of them had a clinical response at 6 months. So this means that patients with Crohn's disease may have a clinical response to antimicrobacterial therapy. So this is a meta-analysis which we have done and which is presently in review. Here we looked at stricturing intestinal tuberculosis and the effect of ATT. And you can see that although the stricture resolution occurred in almost 2/3, the symptom resolution occurred in around 75% of patients. So a quarter of patients may continue to be symptomatic even after ATT. So this means that patients with GI TB may not have a clinical response with ATT. So this is what, so this is again coming back to that study from AIMS. The endoscopic response of the healing of ulcers was present in almost all of the patients who had TB and in a very small minority of those with Crohn's disease. So this is the current standard that you look for mucosal response. But the question is, what happens to the underlying Crohn's disease with prolonged ATT? So there are suggestions from papers from AIMS and AIG, which suggest that this delay could result in a stricturing form of disease or a more severe form of disease and an increased need of surgery. Therefore, it makes sense to have an early discrimination of these two entities. And this was a work done at PGI, where we looked at patients where there was a diagnostic confusion between TB and Crohn's, and they were started on ATT, and an endoscopy, repeat colonoscopy was done at 2 months. And most of the patients with TB, out of 34 with TB, 30 had a complete resolution of ulcers at 2 months. Of those who did not have resolution of ulcers or improvement in ulcers at 2 months, 1 had drug-resistant TB and 3 had Crohn's disease. So this suggests that we can have an early diagnosis. Can we avoid a colonoscopy? So we looked at biomarkers. First, I'd like to talk about CRP. And you can see here that the levels of CRP fall with ATT in the TB group. But this also happens in Crohn's disease, although the decline is not as rapid. In fact, antimycobacterial therapy has been used for Crohn's disease in the past, and multiple, even RCTs have tried to evaluate the role of antimycobacterial therapy. More importantly, if you look at fecal calprotectin, almost all of our patients except 1 with intestinal TB had elevated levels at the baseline. And these levels declined at 2 months and at 6 months. But a similar decline was not seen in patients with Crohn's disease. And therefore, if you have an elevated calprotectin, this may be helpful in assessment of response. What we do at our center is that if there is a diagnostic confusion, we start ATT first. We assess for objective response at 2 months, and we do both colonoscopy and we look for biomarkers also. And the reason is that sometimes there may be strictures. And even if that has healed, you may not be able to evaluate the bowel beyond the strictures, and therefore these biomarkers, especially calprotectin, may pick up disease which you may not be able to pick up with a colonoscopy. And if there is a response, then you continue ATT. If there is no response, you reassess the diagnosis, exclude drug-resistant TB, and exclude Crohn's disease. So our patient at 2 months, the pain had improved, the ulcers had healed, fecal calprotectin had come down, but the stricture was present, and this patient underwent endoscopic dilatation. So what is there in the future? So there is a lot of description about models which use multiple parameters. Unfortunately, the problem is that most of these have been looked at a single center, and these need validation across various institutions and countries. But one model which is of interest is this Bayesian model, which has been validated out of this subset also. And this gives a probability of the diagnosis taking into consideration various clinical, endoscopic, pathologic, and imaging findings, and also takes into account the local disease prevalence. And it is available online, and it will give you a probability, and we have been using this model, and usually it is very helpful. Then there may be a role for peripheral T regulatory cells, and there are a couple of papers from All India Institute of Medical Sciences which has shown that the Tregs with FOXP3 positivity at a particular level could be sensitive and specific for the diagnosis of intestinal TB. And these numbers decline with ATT. Unfortunately, the problem is that, again, this is not validated as of now, and once it is validated, it may become an important tool to discriminate TB and Crohn's disease. There is a role of, upcoming role of artificial intelligence, and there are multiple papers which have not just used textual description of endoscopic imaging, but also the endoscopic images, colonoscopy images, use of multiple variables with machine learning, and use of radiomics for the ileocecal region. And most of these papers suggest that AI could be of use in discriminating TB and Crohn's disease. So to summarize, microbiology is important for the diagnosis of TB, but we need better tools, and we are looking forward to the advancements in gene expert in form of ultra for the diagnosis of TB and excluding Crohn's disease. ATT first is the standard of care in conditions where you cannot, in situations where you cannot discriminate upfront between TB and Crohn's disease. A clinical response assessment alone should not be the criteria to say that a person has responded to ATT. There should be assessment of mucosal response, ideally at 2 months, and a biochemical response could also be looked at, especially in patients where there is a switching disease. Place of multi-parameter models as of today is unclear, but the Bayesian model could provide a possible probability of the underlying condition. Thank you for your attention.
Thank you, Dr. Vishal. We pass on to chairpersons and moderators to ask any questions and share their experience. I think you can talk there now, I think.
Hi, Vishal.
Morning, sir.
Morning. Hi.
See you.
It was always an enigma. Hello?
You want to?
You're able to hear me?
Yes, sir.
You want to come here? Want to come here?
Vishal, it was a wonderful talk. So it's always an enigmatic area where to draw the line between TB and Crohn's. You would summarize saying that it is slightly better to err on the TB side, watch for 2 months and follow a few clinical and radiological or endoscopic parameters and then go ahead with the active Crohn's disease management. This is what you would summarize with?
Yes, I would agree. Of course, there would be a difference of opinion. There would be individuals who would suggest to complete the therapy at 6 months. But in setting, I think as our understanding of the mucosal responses is increasing, I'm increasingly convinced, and this is what we do here, that we take a call at 2 months, whether the person is responding or not.
The other question I would like to ask is there is always a subset of patients who would receive a combined modality of treatment for 6 months, and then at the end of 6 months they would have a re-evaluation or reassessment and then take a call whether to continue the Crohn's disease treatment or not. So at the end of the 6 months, if the patient has achieved a clinical response, so would you suggest to stop all the drugs, both obviously TB medications would be stopped, but stop the Crohn's management, wait for the reoccurrence, or continue if certain clinical parameters are present? So if so, what are those clinical, radiological or endoscopic parameters which you would consider where continuation of the Crohn's management would be apt?
So I think this is, I would say this particular approach of ATT plus steroids has been talked about, but has never been reported in the literature.
No, it's never been reported, but it's very commonly practiced out of the books.
Okay, so I'm yet to practice and see this, but then I think it's a very difficult call to take. But one thing which I can comment on is that even with the, I would say, steroids, or I don't know if somebody would continue steroids for 6 months, that is really not I would say okay. So are you suggesting that people start on immunomodulators also? If that is, the thing, probably a complete resolution of ulcers will not happen in Crohn's disease with the immunomodulators. You may have a clinical response, but a complete endoscopic response short of biologics, is not really what we see. It may happen in an occasional patient. First of all, this strategy should not be, used. I'm very, very convinced that this is not the right approach. But if it is done, then I think we can't really trust clinical responses. We have to look for mucosal healing. And I won't expect mucosal healing with this kind of a therapy, a half-hearted therapy, I would say, in Crohn's disease. On the other hand, ATT should, clear up the ulcers. And I would certainly argue against using this kind of a therapeutic approach, whatever be the clinical situation.
I do agree. We generally as gastroenterologists do not practice this, but as peripheral practitioners, we see some of the patients coming with this combined approach treatment, sometimes at 3 months, 4 months. Then we are in a dilemma because if we stop one of the modalities of treatment, the disease reoccurs, we'll be at the blame point. So I just asked this question to see where we can go ahead when somebody else starts the treatment and they come to us for a second opinion. How do we go ahead? I think the point is well taken that if the ulcers would not completely heal, there might be a clinical response, but the other responses might not be there in this combined modality of treatment. Sir, any other question?
Hello, sir. Good morning. Hello.
Hello, sir.
Most of the time, the problem is after 3 months, you do a repeat colonoscopy. They are clinically better. They have partial response on the endoscopic wise, partial healing. The problem is only partial healing. So what to do now? Because do you think it is because if it is a Crohn's, it won't anyway respond. But the problem is, do we start steroids at 3 months, or do you wait, complete the ATT for 6 months and start steroids?
So I think the question here is partial healing.
Yes.
That is, there is healing in some of the ulcers, or the ulcers may have reduced in size. Now, what we have seen is that unless the ulcers are associated with strictures, they are at the site of strictures, they usually do respond. And 3 months is a very good time. I think by that time, most of the TB ulcers should have responded. Again, if there is a partial healing, my suggestion would be to complete 6 months of therapy and repeat a colonoscopy at that time, rather than taking a hurried call to start therapy for Crohn's disease.
But if you do, because ultimately it turned out to be, suppose after 6 months, so still there is a healing only something like 60-80% like that. Then because there are a lot of studies coming up, they say if you delay treatment in Crohn's disease, there is a lot of stricturing disease.
See, again, as I said, that if you look at the original paper from AIMS, 5% of patients with eventual diagnosis of Crohn's disease do have healing or the mucosal healing even with ATT. So this may be that particular subset, and I think a close evaluation of what is happening in an individual case would help make a diagnosis. Again, at 3 months, if you have partial healing, my suggestion would be to complete ATT rather than starting ATT at that point in time. Ulcer healing, again, may not happen when the ulcers are associated with strictures, even in patients with TB.
Okay.
So that point is...
Hi, I'm Naveen. I'll just finish off with one last question from this talk. I think what you described in terms of differentiating between Crohn's and tuberculosis, and in terms of when to start ATT as point very well taken. I think we should have a very low threshold to start the ATT, especially when you have a dilemma. My question is, in your clinical practice, how often do you see the MTB gene expert being positive, and also the AFB cultures being positive? Because often, what we see is we very rarely get any, positive diagnosis with it. Of course, these are kind of more positive predictive. If you have these positive results, then you are very convinced that you have TB. But in your experience, what is a positive predictive value, and how often do you see it?
So the question was about culture positivity and expert positivity.
Gene expert positive, yeah. MTB gene expert.
So we have already reported out, yes, gene expert positivity. It is very important to continuously interact with the microbiologist. The problem which microbiologists face is that very often we just send one biopsy piece or two biopsy pieces. They want good amount of tissue. And the thing we found is that for expert, we found 32% positivity in our study. Overall, from AIMS, it was 8%. So this means that this is for expert, which is very small. And we are now looking at ultra, and I can tell you that ultra seems to be very promising. So I'll wait for the calculation of the results and reporting of the results, but ultra seems to be performing much better. And I think one problem which we face sometimes with the private labs, if you send it there, that very often they will do it on the fluid rather than doing on the tissue. So it is important to do it on the tissue, and the yield would improve. Again, it is for expert, it is definitely less than 50%. In fact, the pooled estimate that we had was 23%. So 1 out of every 4 cases with intestinal TB would be expert positive. MGH is probably better than the traditional culture, but again, the positivity is less than 50% in whatever clinical situation that they have been used.
Okay, well, in our experience, is much less than that, to be honest. I think probably 10% or even less than that.
You're talking about Gene Expert.
Gene Expert, yeah. I mean, cultures is even less, to be honest. Very, very rarely get any culture positive ATT, TB.
I would agree with you that in our clinical practice also, Gene Expert positivity is more than the culture positivity.
Okay, thank you.
Vishal, there's one question from the floor. When do we suspect MDR TB in either proven tuberculosis patients or in patients where there is a dilemma between Crohn's and intestinal tuberculosis? When is that we suspect this MDR TB, and how do we go ahead with the workup of it? Where do you sample and whether you send for culture or for the Gene Expert, etc. Second question second question, same relevant question is that what is the status of the 6-month, 9-month and a 12-month regimen for tuberculosis? There is no proven paper, but people do give tuberculosis treatment for 9 months to 1 year in extra pulmonary tuberculosis. So what is your say on that?
Okay. So I'll take the MDR first. I think the strategy should flow from other forms of tuberculosis. That first of all, the culture should always be sent at first instance. Second is that in patients who have been treated for TB in the past or have underlying HIV, there you should have a suspicion for underlying MDR. The MDR also should factor in the local prevalence. If I were in Mumbai, anyway, you are going to expect MDR in a subset of patients. In North India, a study from AIIMS and from our center suggests that MDR is not a big problem. I'm not sure of the local prevalence in Hyderabad or Telangana, but I think that should also figure into your eventual suspicion of MDR. The second, of course, about the 6 months and the 9 months and the 12 months. This is something we had done a survey amongst practitioners. And I think there is clear evidence. You will not have more evidence than that. One Cochrane review, one large multi-center randomized trial from India, which have suggested that 6 months should usually be adequate for both intestinal and peritoneal tuberculosis. And but 50% of the practitioners continue to use a longer duration of therapy. In an occasional patient, we do extend the therapy, but for most of our patients, I would say a vast majority, 6 months of therapy is adequate, and that is what we practice.
Yeah, that's right. And lastly, one concluding word. For all the postgraduates, there is a book by Vishal Sharma on intestinal tuberculosis. It's a very wonderfully written book. So I would suggest all of you to go through that book because it has covered most of the aspects of intestinal tuberculosis in completion. Thank you.
Thank you, Vishal. Audience enjoyed your talk. So in the interest of time, we'll move on actually. And thanks once again. We do have Dr. Chanchal Kumar Ghosh from Bangladesh, Bagabandhu Sheikh Mujib University joining in, but we'll take his comments on the next talk. So we got about 10 to 12 minutes coffee break actually. We'll assemble sharp here at 11 o'clock and for the next session. We are running late, so we'll please maintain the time. 10 minutes break, please. Thank you, Dr. Vishal. We'll switch you off now.
Sir, start China.
Good morning, everybody. First and foremost,
Request all of you to please take your seats. Just చెప్పేసి
అంటే మాట్లాడతారంటే అన్మ్యూట్ చేస్తాను అందుకని జూమ్ వాళ్ళకి వినిపించాలంటే
ఎక్కడ మాట్లాడుతున్నారు
జూమ్ వాళ్ళకి వినిపించాలంటే నేను అన్మ్యూట్ చేయాలి
చేసి అన్మ్యూట్ చేసి I request all of you to take chairs. We are starting our next session. So the next topic is by Dr. Rupa Banerjee. She is Director of Inflammatory Bowel Disease Center at AG Hospitals. All of you are familiar with her name. And she's going to talk on why the standard therapy fails in IBD. So it's a recorded talk and she might join live for Q&A. Please take your seats and we are starting the next talk.
The South Asian IBD Alliance and Dr. Kiran Reddy for inviting me to this excellent meeting. I'm looking forward to the whole day of nice talks, all covering inflammatory bowel disease. My job today is simple, as well as what we need to think about. Common errors in the management of IBD. Why does standard therapy fail? Traditionally, IBD was a disease of the West. Far away from the West, our developing world, we were happy. IBD was rare. We had our share of infectious diseases, but no IBD. Then there was globalization. India's new dawn. We had swanky malls, westernization, advances in technology, but together with this, we had the urbanization in Asia, the dietary changes, and we got into the headlines for the wrong things. The bad air, pollution, the diet patterns, how we got obese, and IBD came to the non-Western world. And if you see today, emerging IBD demographics, this was just published yesterday by the way, came in print yesterday, the story of an emerging disease. We find that both ulcerative colitis and Crohn's disease is on the rise in this part of the world, the entire South Asia, Southeast Asia region. We've come a long way with the treatment. To start from where IBD was recognized, we spent almost 3 decades searching for a treatment, and then finally when the steroids, mesalamines and azathioprine came, we thought we had achieved it. But then in 1993 came the first anti-TNF, infliximab, and gradually we had the whole series of biologics, and then now the JAK inhibitors and tofacitin. What happened was biologics revolutionized the management of IBD. In the past, we thought we just needed symptom control, improving quality of life, but today it is much beyond even simple remission or maintenance of clinical remission. We are looking for mucosal and histologic healing. We are looking for restoration of growth, development, avoidance of complications, and we've really tried to reduce hospitalization and at the same time reduce costs. We follow the standard step-up treatment protocol. Therapy is stepped up according to the severity at presentation or failure at the prior step. And this is how we are. But there are times when this standard therapy fails. And we must understand or try to understand why, because that is what will make the impact in our day-to-day clinical practice. Why do patients with IBD not respond to their medications? And what do we think? Drug or mechanism is not working. Well, I think that is the last thing that we should think about, if not the others. So what are the others? Primary non-response. Is our diagnosis correct? In a region where so many infectious diseases prevail, wrong diagnosis is one thing. Wrong dosage. Are we giving the right dose at the right time, the right delivery? And secondary non-response, we change dose. Sometimes the disease changes over time, and non-adherence. It can be intentional non-adherence. People may be worried of taking drugs for ages, and then unintentional non-adherence, which is so prevalent. They can't afford the medication, or the dosing regimen is such that they really don't want to take so many drugs at so many times, the question of polypharmacy. So we'll just go through one at a time, wrong diagnosis. And I'll start with this, this true patient that we had and what really happened. Her symptoms started in 2011 when she was 12 years old. She had recurrent postprandial vomiting. Her parents had separated. There was a weight loss, but we thought that, well, she was disturbed. Routine blood investigations, ultrasound, upper GI endoscopy was normal. She was managed symptomatically, received counseling, and apparently she felt better. But she continued to have intermittent abdominal pain. And then she came to AIG in May 2015, a 15-year-old high school girl. Symptoms had aggravated. There was abdominal pain, multiple white-based ulcers in the ileum. Biopsy, of course, was non-specific. She did have low-grade fever occasionally, but the picture was quite characteristic. If you see the CT enteroclysis, multiple segmental wall thickening in the jejunum and ileum. In view of a long history, imaging and colonoscopy typical of Crohn's disease, we started her on a combination of budesonide and mesalamine. A course of full-blown steroids did not work, and treatment was planned in the lines of Crohn's disease with infliximab. Chest X-ray was normal. TB quantiferon was negative, MAN2 negative. There was no family history of tuberculosis. Prior to starting, we repeated a colonoscopy, and TB PCR from the second biopsy specimen turned out to be positive. So the previous biopsy was all negative, as I mentioned earlier. So we were kind of morally, we thought that we did have to start TB treatment. We started on 4-drug TB treatment. Budesonide mesalamine was stopped, received 9 months of TB treatment, better with 9 kgs weight gain. The answer was that the repeat CT enteroclysis, mild thickening. So the lesson was worthwhile to err on the side of tuberculosis. There's no point in thinking, well, this is how it is, and it is definitely Crohn's disease. Wrong diagnosis is one important thing. How to differentiate? So if a patient is not responding, always think, is my diagnosis correct? And then recheck, re-evaluate, and then mix and match, case-to-case basis, multiple tests, whatever is available, if there is no response. There can be pseudo-intractability of IBD for other enteric infections, either together with the IBD or just an alternate diagnosis. Bacterial infections, CMV, Clostridium difficile, parasitic diseases, sometimes cigarettes, cessation in ulcerative colitis, or increased use for Crohn's disease can all cause lack of response. The next is the wrong dosing. And this is simple, and we know that optimize medication doses before considering that it is a refractory disease. So for mesalamines, you can go up to 4 to 4.8 grams, sulfasalazine 4 to 6, valsalazide 6.7, olsalazine, whichever. Prednisolone, you should start at around about 40 or even up to 60 at max, not beyond that. So we need to know the dosage and follow the dosage before we say that, well, this drug is not working. Similarly, the wrong delivery mechanism. Now we need to know what are we targeting. So supposing there is lower end disease and we pump in a lot of enemas, the proctitis does not improve. And if you see this is an age-old slide which I use, enema distribution for each colonic region, and you will see that in different kinds of rectal preparations, the rectum, the enema preparations, the rectum barely receives the drug. So if 2 grams mesalazine in 30 ml, only 1% in the rectum, and 1 gram mesalazine in 100 ml is 0%. So we need suppositories for proctitis. And that is what we must remember before saying, well, mesalazines are not working. Similarly, only 40% of foam enemas and 10% of liquid enemas detected in the rectum after 4 hours. So 5-ASA topical therapy is effective, but suppository is more appropriate than enemas for proctitis. So there have been numerous meta-analyses which has shown that rectal 5-ASA is in fact superior to rectal steroids in distal ulcerative colitis. Combination of topical and topical steroids superior in active ulcerative proctitis. So these are the things that we need to know. After this comes the question of non-adherence. We all know, and there are numerous studies since Sunanda Kane's famous study, non-adherence increases the risk of relapse. Non-adherence is associated with higher costs. Drug adherence actually is a real problem. And it's not simple. When we did this study of Indian patients, for more than 400 Indian patients, we always earlier had thought that it is the cost. People don't take the drug because they find it costly. But no, what we found was it is not always the cost. In fact, the most costly drug, many patients thought, well, this is the most costly thing, so it must be the best. And then they tend to continue that drug. What made a difference? What were the factors associated with non-adherence? People who were working full employment, they did not get time. 3 times daily dosing, they were missing doses in between. Depression, they did not feel like taking the drugs. And whether you believe it or not, males and singles who did not have the wife to run after them will take the medicine were the ones associated with non-adherence. Factors associated with adherence, the most important, which I want to stress on, is the physician reinforcement. So when the doctor told specifically to the patient that do not forget your drugs, it's important, and the necessity for drug adherence was reinforced, those are the patients who really followed the drugs and took the drugs regularly. When all this is clear, why do patients not respond to their medication? We must then think whether the drug or mechanism is working. Why is the drug not working? And this is again a case of 2 brothers with ulcerative colitis. Patient number 1 and 2, the first 18-year-old with pancolitis, steroid responsive, steroid dependent, but steroid dependent, and the 15-year-old brother, ulcerative proctitis, steroid resistant. Both were started at azathioprine and were unable to wean steroids below 15 milligram, and the younger brother was not responding at all to azathioprine. So we must know the thiopurine metabolism and how it works. So then we will know whether increasing the thiopurine or what needs to be done. So if the patient is not responding, we have to do their 6 TG, 6 MMP, and then decide the possible cause. So if we find that both 6 TG and 6 MMP are undetectable, possibly there is either underdosing or the patient is not taking the drug. If the 6 TG is low, as well as the 6 MMP is low, again non-adherent underdosing. If 6 MMP is high but 6 TG is low, it's a 6 MMP shunter, in which case you can either increase thiopurine or consider allopurinol as to add together with the thiopurines or switch agents. If 6 TG is therapeutic, 6 mmP is in the normal range, then there's no point in increasing the dose of thiopurine, assess the disease, and switch to a different mechanism. For the two brothers, what we found was one of them was actually a 6 mmP shunter, and we added allopurinol. For the other, we actually switched to methotrexate because azathioprine was not working. So a practical approach to allopurinol and thiopurine combination therapy, not for everyone. Be aware of safety concern, choose the patient wisely, drop thiopurine, add allopurinol, do a CBC weekly for 1 month, then monthly, assess the metabolites at week 3, dose adjustment if necessary, but usually better to keep to a low dose of allopurinol only. The case 3 is failing biologic therapy. Now we did azathioprines, we learnt about the mesalamines and the optimal dosing. What about patients who fail biologic therapy? And this was a 21-year-old student for a 4-year history of extensive small bowel Crohn's disease, no previous abdominal surgery, no family history, was on infliximab up to 10 milligram per kg every 8 weeks for the last 2 years. Now we need to understand that biologics are good, but there may be primary non-response, primary failure, or secondary non-response, works for a while and then does not work. Factors that influence the efficacy of anti-TNFs, what we need to remember is concomitant use of immunosuppressives actually gives better clinical outcomes. So anti-TNFs alone versus it is better to use a little bit of low dose of azathioprine together with the anti-TNFs. Again, demographic and phenotypic associations with primary anti-TNF alpha response, we must know that in general it has been seen that non-response is higher in ulcerative colitis, higher in those with P-ANCA positive. At the same time, ASCA positive cases known to respond better. Of course, this is again what we call personalized medicine, and more details are coming in, other genetic markers are coming in, which will tell us whether a drug will work or not work. We should, of course, do the infliximab levels and antibodies and then take a decision. Because if the infliximab level is already therapeutic level and the patient is not responding, it is better to switch to other drugs, because now, since there are so many biologics in the offing, we can afford to change from one drug to the other. So for our patient, of course, therapeutic infliximab trough level, and there was a short segment of fixed non-inflammatory disease. We sent for surgery and ileocecal resection was performed. Here again, I'd like to say that for the Asian context, rather than give years of treatment, sometimes if it's a short segment, small limited disease, particularly in the ileocecal region, may be worthwhile to just go for surgery. At the, it's much more cost effective sometimes if you do the follow-up after that. So the patient is doing well, 10 months post-op with colonoscopy demonstrating two aphthous ulcers, generally okay. IBDs are chronic lifelong diseases. As IBD emerges in India, we again have to think not only the disease presentation, but the cost. Treatment of IBD is costly, numerous costs, diagnostics, tests, drugs, maintenance, medications for a lifelong, hospitalizations, and of course, the employment and quality of life issues. The biggest pitfall, we fail to understand our population. We sit on that high chair and tell the patient, just take it. And that's why sometimes standard therapy fail. That's why people don't take the drug. We've just published this in Lancet, IBD in resource-limited settings in Asia. It's an interesting read on how and what we should do how we can reduce the cost. Let us use low-cost drugs. Let us use the immunomodulators, which are less costly. Let us ensure drug adherence, optimal use of biologics, sometimes biosimilars. Novel therapies, why not use curcumin, which is known to work for mild ulcerative colitis, less cost. Let us tell our patients that they can use the curcumin, which is a regular food ingredient in our diets nowadays. What about fecal transplantation? Efficacy of fecal transplantation has gone through the yin and yang, but yes, in certain cases it does work, and the cost is less. The yuck factor that we have to overcome. And this is interesting that, you know, there are barriers to acceptance of fecal transplantation, but if you see these two pictures and try to think which is the doctor and which is the patient, you will be surprised as a doctor, because it's the doctor who is more worried. The patient feels, well, okay, which option was available, which it is safer than steroids or biologics, and the doctor feels, who would do it? I don't think my patient would accept. So ultimately, that is something we need to understand. We need to understand our patients and then take a decision. Clinicians should be specially mindful when ordering expensive diagnostic tests, choosing the lifetime maintenance medication, escalating infliximab, the cost doubles, considering benefits of earlier surgical referral for refractory ulcerative colitis, educating patients, because that is what they need to understand, the importance of adherence. Other common pitfalls: delay in diagnosis, steroids and initial therapy. Just start with steroids. Some people do it, but that is not the way. For mild to moderate ulcerative colitis, trust the evidence. Go with mesalamines first, using anti-TNF therapy as monotherapy. Concomitant favored at least for induction. Avoiding surgery when it is needed. Not vaccinating. Ignoring vitamin D. Relying on crisis management. No follow-ups. But today it is the time that we do proactive monitoring. If the fecal calprotectin is high, step up therapy. Don't wait for a full-fledged flare before you do that. Dismissing patient interests in diet or complementary therapies rather than working with them, and not referring to mental health professionals. And I think this is another important point that we need to know. Mental and emotional well-being challenges. I think if I ask all of you today, what percentage of your patients face emotional and mental well-being challenges? We don't know, because we don't ask. What about the primary caregivers? What is their status? We don't know. Do we talk about mental health? In our busy practice, it's an often no. And when we did this survey at the IBD Emerging Nations Consortium across 7 countries, now we have 9 countries, high prevalence of mental health issues. Depression in more than 2/3 of patients. Anxiety in roundabout the same. Poor quality of life. High caregiver burden, again in roundabout 67%. So this is something we need to address, because this impacts quality of life, this impacts drug adherence, this impacts whatever as clinicians we are trying to achieve. So the key messages today is stop and think. Why is the drug not working? IBD is on the rise in emerging countries. This is a chronic, lifelong, high-cost disease. There are common pitfalls in the management. Sometimes that is what causes failure of standard therapy. Ensuring a simple adherence may improve outcomes. We must rule out confounders like infections, use of NSAIDs, smoking. There's no point in staying within a class of drug if actually the drug mechanism has clearly failed, be it biologics, be it thiopurines. Surgery may be an option to consider in patients with limited disease. So the final thing is why? Ask yourself as a physician, why is the standard therapy not working? To know more about IBD, we have now formed the IBD ENC online platform, www.ibdenc.org. I welcome all of you to be a part of this endeavor because you have your personalized IBD registry, difficult case discussion forum, journal scan, latest IBD news, and the master classes. Thank you so much for your attention. This is the team IBD at AIG, all masked throughout the year, and thank you so much.
So thank you very much for the invitation by the organising committee to speak, and thank you very much.
Thank you, Rupa. Thanks for that wonderful talk. So this session is being moderated. Are you online, Rupa? Dr. Rupa, are you online? Yes, we can see you, Rupa. Yeah, so Rupa, we have about 40 gastroenterologists sitting in the auditorium here, and we have this session is being moderated by Dr. Chairperson Dr. Srinivas Murthy and Dr. Balamurli, who is consultant gastroenterologist at KIMS Kondapur, and also we have online Dr. Chanchal Kumar Ghosh, head of the Department of Gastroenterology from Bangabandhu University, Dhaka, Bangladesh. So, you have any comments and questions to make, Dr. Srinivas or Dr.
Can you hear me, Dr. Kiran?
Yeah. Yeah, please go on.
Awesome. At first, I like to say sorry as I became delayed to join the program due to network problem. But I am lucky that my favorite speaker, Rupa Banerjee, I am present in his speech. But I failed and another favorite speaker, Onit Vinit Ahuja. But Rupa Madam, in Bangladesh, IBD is growing and detecting more and more like India. But here is the scenario is different, ma'am. From the patient side, there is two factors in the, I think, in the common errors in the management of IBD. And the delaying of diagnosis is more here. As the most of the patient at first go to the local doctors and local physicians, co-physicians, and they gave continuous antibiotic. And so the Crohn's disease, especially Crohn's disease diagnosis is delayed. And in one of my study, and shows that at least 4 years needed most diagnosis in Crohn's disease usually. And another factor is a financial constraint. Most of our patients cannot afford biologics. Sometimes biologics is needed, but immunomodulators, I am using immunomodulators, it is working good, but most of our patients cannot afford biologics. And from the doctor's side, physician side, this is, I am sorry to say that most of our physicians, there is lack of expertise in IBD management, and they manage IBD with a small dose of steroid, sometimes with very high dose of steroid, and not in a standard dose, and sometimes with steroid for prolonged time, which is not needed usually, and most of the times and dose adaptation is not correct here. And another important thing is cancer screening is very lacking here. We know that after 8 years of IBD, especially outside of colitis, and though it Crohn's disease, cancer screening is important. Here, it is mostly lacking here in most of the institute. In Bangladesh, BSMMU and Sheikh Russell Gastroenterology Institute, we do practice, but most other centers usually do not practice cancer screening. So this is the scenario in Bangladesh. Thanks and congratulate to Madam for excellent delivery. Thank you.
Thank you, Dr. Chanchal. I agree that across the entire Asian region, our socioeconomic factors, our disease phenotype itself is different, and we must adjust to our local situations. In fact, we've just published last month the study on demographics of IBD in this part of the world. I think Kiran and many doctors from Bangladesh are all part of this. And what we are finding is our disease itself may also be different. Our dose requirement for azathioprine may be lesser. Our need for surgery, fortunately, looks to be lesser. So yes, we need to work together from this part of the world and find our own guidelines and algorithms for management.
Thank you, ma'am.
Hello. Madam, good morning.
Good morning, good morning.
Good morning, ma'am. So I just want to share one experience. I had one patient who had I had one patient with perianal pain. Actually, he concealed the history. Some surgeon suggested whenever you have perianal pain, for Fisher, he was suggested that one diclofenac suppository. So he took almost 100 suppositories and then presented to me with like IBD presentation, 50 days history of diarrhea and bleeding per rectum. He concealed this history on probing and probing, then he came out with that he has consumed around 100 diclofenac suppositories. But this is all due to NSAID induced. And another close mimic is that Strongyloides stercoralis. I have seen some mimics like IBD mimics where you miss. And I also missed one case because ultimately came on histopathology that it was diagnosed as a Strongyloides stercoralis.
I think you're absolutely right. We are always, often surprised. We had an ulcerative colitis and then the biopsy showed frank amoebiasis. These things do happen. But what we are seeing is that over time, earlier, 2 decades ago, in any exam, if somebody diagnosed Crohn's disease instead of tuberculosis, it would be a distinct, oh my goodness, thinking of rare diagnosis. But we've already reached a stage when we are at a 50-50 with tuberculosis. And from what I'm seeing, what we are seeing across, and now that we are seeing the rural population as well, slowly the paradigm of diagnosis is changing in this part of the world. Now, I think awareness is more, the bloody diarrheas, people do think of ulcerative colitis. The infectious diarrheas are coming down. We are at that epidemiologic midway. So I think the mimics are going to get lesser. And as we get more globalized, westernized, our malls are getting better, our roads are getting better. So is the incidence of autoimmune diseases like IBD. But interesting case, the NSAID-induced rectal ulcers. I think that is real.
If you remember the Michael Kramer's talk in AAG, because he was mentioning about the food preservatives, 300 food preservatives in India, which are responsible for the rise of IBD.
Correct. So it's now the emulsifiers, and this is for the general, that now we feel that not only the preservatives, it's the emulsifiers which makes our food looks better, The mayonnaise in general is a liquid with something solid below, but when we get it, it's like a spread. So they've added emulsifiers, and I think emulsifiers is one of the important factors responsible. So lifestyle changing, emulsifiers, we have to find some solution, and of course, increase awareness about the disease.
Thank you, Rupa. And in the interest of time, we'll move on actually. Thank you very much for joining.
Thank you, Kiran. I think it's an excellent show on. Congratulations.
Thank you,
your
Rupa.
efforts.
Thank you, Rupa. So after this now, we'll move on to lamp lighting ceremony. For this, we have our director. I welcome Dr. Pawan Gorkanti. By qualification and training, he is a pulmonary and critical care specialist, but by his role, he is the director of Yashoda Group of Hospitals. He is quite liked by all the doctors in the group, and that's one thing strikingly noticeable because he's very, very simple and very approachable by all the doctors. So we'll do the lamp lighting. For that, welcome Dr. Karthi sir to join as well. Along with that, our organizing committee, Dr. Chandrasekhar Reddy, Dr. Akash, Dr. Sharda, and Dr. Sriram to join as well. I request Dr. Pawan to say a few words about the conference and welcome you all.
Thanks, Kiran and the organizing team. And thanks all of you for attending on a Sunday. Having been in the US, my thing was if I work 1 week was off, and then 1 month vacation because I have to go all the way to India. So 5 months here I was working, but after coming back here, looking different. Anyhow, inherited role director, so I can come whenever and go, but Indian doctors, daily full-time work and all, great. Thanks all for your efforts for these 2 days, particularly on a Sunday too. Even the Sunday half day also you need to spend, but I'm sure you need to, this intense competition and all that, you need to be updated with all the latest in everything, even if you don't necessarily do all the latest in IBD and all, but everybody, it's important to know the absolute latest. So yes, looking like disease patterns have been modified. When I was younger in quite so many years ago in Osmania and all, yes, it's true that IBD and all were a rare diagnosis. I don't know, we would have failed in the exam, I think, if you say like ulcerative colitis and these kind of things. But I think it's changing. Same like COVID, influenza. Before going to US, I rarely seen influenza and all. I thought, why is this influenza coming every year? Influenza season, like in winter and all that. But now, even in India here, looks like every year we'll get something like COVID or H1N1 or something like that, dengue and also the routine things like malaria, typhoid, parasites. Maybe they had a protective role too. I don't know. We need to do some studies. So maybe the T cell immunity is modified or whatever. So things are changing, particularly pulmonary wise too. Tuberculosis is now almost, previously it was everything, pulmonary was called DTDC or something like that here, but now I think majority is going to viral infections and all. I think same in gastro too. Looks like when was the last time we saw typhoid and all? Is it still there? Or typhoid, malaria, and these kind of things, like tapeworm, roundworms, and these kind of things are going, I think. But always something else is there in that time, and T cell modification or whatever. So now IBD definitely, yes, it was underdiagnosed in India previously, but I think incidence itself is increasing too, without a question. Like quite a few people are suffering from these, and IBD maybe not necessarily affects the lifespan with the treatment and all, but it's a pretty debilitating disease, and it needs early diagnosis and proper treatment to have the best course of treatment. And not only that, even yesterday we have this was from Crohn's Foundation, or yes, Crohn's Foundation, and also we heard a lot of patients sharing their experiences, including their psychosocial aspects, dietary, and all of these things. It needs a combined multidisciplinary approach for this debilitating disease. I think it's better to be like interacting with, having interacting session with, and live sessions are even more useful though after so many virtual sessions. I think the practical day-to-day tips of like, you know, the finer things are whatever you're missing in these virtual things, we can have a personal interaction with whoever, all the luminaries of the city and the country seem to be here, and even the world too. So we encourage these kind of conferences, and we'll do our bit to support whatever is required for academic wise and conferences, research. Hopefully research also changes. I think with this kind of volume and all, now we should be leading in the world in the publications of what exactly is the etiology of Crohn's disease, ulcerative colitis, and even the treatment wise particularly need not be super expensive, and also maybe all these things gradually keep changing. So like many things have changed since when I first went to US and all. I thought, okay, liver transplant was done somewhere in the US and all, but now last year I think I did 150 liver transplants. So liver transplants, and same thing, ECMOs, like ECMOs once or twice we used to do like 20 plus ECMOs during the second wave, and 100 air ambulance transfers. I never thought in India we would be talking in the same sentence, but like 100 air ambulance transfers, ECMOs, and also, and 25 lung transplants last year when we first started. So all these things are changing in India, I think, like, and gastro is leading field, I think, intervention, and like other gastro is leading in the leading specialties. So I think it's great to see you all on Sunday. And anything else? And thanks for all the faculty logging in from online from all over the world, looks like from US, UK, and here in India, Bangladesh, and everywhere. So it gives me great pleasure to see all the, despite your super busy schedule. Maybe we should have one more session on other things too, like how to be successful in private practice, how patients come, or any of these kind of tips you need to. Also all these luminaries in the front page, they'll tell you about the finer aspects of whatever is required, how to deal with difficult patients, how to get patients, how to not get patients. So whatever you want, you can discuss here. And okay. And all the best for your further conference. Thanks.
Thank you, Dr. Pawan. Thanks for all the support you rendered for this conference. So we move on to the next session. Dr. Ajit Sood. So to moderate the session, the topic is role of FMT in IBD. To moderate this topic, I request Dr. Rohan Reddy, consultant gastroenterologist at Sunshine Hospital and Gastrocare, to join Dr. Srinivas Murthy, and Dr. Jahangir, consultant gastroenterologist at AAG Hospitals, to join the moderator seat. And we'll be playing Dr. Ajit Sood's video now, and he'll be joining live for Q&A. Ajit Sood. So Dr. Ajit Sood doesn't need introduction to gastroenterology fraternity. He's a professor and head of the Department of Gastroenterology from Ludhiana. He's also a recipient of many awards, and is one of the founding members for CCFI, Crohn's and Colitis Foundation of India. He's got numerous publications in the field of IBD, and is one of the pioneers in the diagnosis of Crohn's disease and ulcerative colitis as well. So we'll start his video now.
Thanks, Dr. Kiran. Thanks, Mr. Chairperson. Can I have the first slide? In continuation with the treatment options for IBD, I'm going to take up role of FMT in management of IBD. I'd like to say that because of pandemic, FMT at most of the centers had come to a halt. And I think with the situation becoming better now, most of the centers are likely to restart with the FMT program. Starting with pathogenesis of IBD, what causes IBD really nobody knows, but we have evidence to show that gut dysbiosis is important. The organisms like mucolytics and invasive organisms predispose a person to develop IBD, while short-chain fatty acid producers like Bacterium prosnitzi and other Clostridia may be protective. Not only it's the presence of the organisms, it's their byproducts or metabolites, what also matters in addition to the organisms. So the metabolites like bile salts, the sphingolipids and amino acids, they together with the organisms can result in inflammation. And of course, we know that genetic predisposition and dysregulated immune system have ultimately to pull in for disease manifestation. Fecal transplant is not something really very new, as it's mentioned as early as 4th century BC, when in Chinese medicine, fecal suspension was given through oral route to children and adults who have persistent diarrhea and other intestinal diseases. It was possible because those days there was no informed consent required for any experiment. Coming to the literature, in ulcerative colitis, there are 4 landmark RCTs which have been published so far. 2 appeared in 2015, and 1 in 17 and 1 in 19. There's another RCT which has come up recently as an abstract form. These 4 RCTs have been conducted in patients with active ulcerative colitis, and they have focused on induction of remission. Now, when we look at the 4 RCTs and we compare these, they are very, very heterogeneous. Regarding route of administration, in 3 RCTs, the colonoscopy route was used. In 1, oral route was used. The dose and frequency varied from 2 sessions to as many as 41 sessions. The placebo also differed from water or autologous stool to saline. The disease severity varied from mild to severe cases. The concomitant medications which are allowed also were different. So much so even the definition of clinical remission differed. But what the RCTs agreed upon, 3 out of 4 agreed upon that FMT works, as nearly 1/3 of the patients or 30% of the patients, they could achieve clinical remission with FMT, and this was significantly better compared to placebo. One trial where oral route was used failed to achieve significance. Now, as I mentioned, that the RCTs were very heterogeneous, and we started our FMT program in 2015. So we were interested in trying out FMT in a select group of patients. So we selected a steroid-dependent disease, which, as you know, is a difficult group of patients to treat. So we used colonoscopic route, and we used 7 sessions as induction protocol in steroid-dependent ulcerative colitis. And we were really amazed to find that we could take all these patients off steroids, and so much so that 45% of the patients, they could actually attain clinical remission. So we knew that, or we also found that FMT works as far as induction of therapy is concerned. Like other drugs, it's not a question of induction, it's a question of maintenance as well. So we tried evaluating role of FMT in maintenance as a maintenance therapy. Our patients who have achieved clinical remission with FMT, we put them on maintenance therapy with 8-week session of FMT, and we found that with 8 weeks therapy, they did better as far as clinical remission, histological remission or endoscopic remission is concerned compared to standard of care plus placebo. So we found that FMT works not only for induction but for maintenance as well. The predictors of response to FMT, we looked at age, disease severity, extent of the disease, and we found that younger age, moderately severe disease and E2 extent are the predictors which predict a better response. We like to mention that patients who have very severe disease, the two problems in such patients, one that it's doing colonoscopy is not very easy. We may not go for a full-length colonoscopy, but even then, even a limited procedure may not be very safe. And these patients have such strong urge to defecate. Urgency and incontinence are problems, and it's very difficult to retain FMT. So these are the two problems which we face in patients who have very severe disease. Interesting observation, we evaluated whether the passage of time, the time between passage of stools and administration or storage of stool has an impact on the responsiveness. And we found that the shorter the period, better the response. If the period between passage of stools and administration or storage is 1 or 2 hours, the response is better. If it goes beyond 4 hours, the response declines. Now, based on a recent meta-analysis, which included 4 RCTs, which I showed earlier, and one recent RCT, which has appeared only as an abstract form. So based on these 5 RCTs, these are some of the observations which have been depicted as forest plots. I'll go through these. Then when we look at the overall response is better as compared to placebo. We can see the results on the left side, which favors FMT. And the various factors which influence the response, they evaluated pooled donor stool versus single donor stool. And they found that the pooled donor stool does better. It may be because of richness of the bacteria and better diversity. When it came to the number of the sessions and the route of administration, the route of administration is important. When they looked at oral route, the results were not better compared to placebo. The results of per rectal route was better compared to oral route and compared to placebo both. So the route of administration is, I think, definitely in favor of a colonoscopic route or a per rectal route. The frequency of administration matters, but not significantly. Safety profile is nearly same as placebo. There's a very slight difference in the adverse effect as compared to placebo. Now, acceptability, tolerability, and safety. This study is again from our center. And the acceptability, I will mention that among patients is higher as compared to acceptability among healthcare providers. When we looked at the side effects, the short-term side effects means that day or next day, most of the patients will have some abdominal discomfort or flatulence or the tummy is gassy. You know, these kind of symptoms are there. Very few patients, they actually have worsening of the disease in a subsequent days. And the long-term side effects, we have followed them up for as long as 1 year after the last session of FMT. And the patients did show some of the side effects like urticaria or arthritis, arthralgias or axial arthritis. One patient had mild depression and allergic bronchitis. One patient had partial hearing loss, which may not be related. But these arthralgias or arthritis can appear as EIM of IBD. But these are some of the problems which happened or which were noticed by patients who received FMT. Now, coming to future of FMT, is future FMT going to be same what we are practicing today? I think the answer is definitely no. As FMT modulates the gut microbiota, and gut microbiota is prone to so many confounding variables like genetics, immune system, or habitual diet, age of a person, environmental factors other than diet, exposure to drugs, antibiotics, infections, location, and stress. Now, can we, when so many confounding variables can affect a therapy, what to do? Should we try to control all the variables? If you don't control the variables, the results will not be true. But if we try to control all the variables, we'll be left with a very small and select group of patients, and the choices can shape the data, and again we can have wrong information. So we have to take a middle path. Continuation with the factors, the attributes related to the donor and the recipient which affect the response to FMT. I would like to highlight that the habitual diet of a donor as well as recipient is very crucial. If we do FMT and let patient remain on a same uncontrolled diet, which may not be very healthy diet or which may be some so-called pro-inflammatory diet, the response rate is likely to be less. Same time, we do donor screening not only once. What is important is a periodic donor screening. And should we look for donor recipient compatibility, or it should be a random kind of a thing? It seems logical that there could be some kind of compatibility. I'll come to the next slide. I'll come to its importance in the next slide. And whether we should look at the host genetics, the microbial analysis of the recipient, and the concomitant therapy which a patient is on. Whether patient has been exposed to biologics, his immune system has been tampered with, the response to microbial therapies might differ. The attributes related to the FMT procedure also matter. At the moment, we have seen that the safety profile is fairly okay, but these observations are based on small studies, and for a limited period of time, we need to have a longer follow-up of these patients. The standard protocol of long-term FMT as a therapy, we don't really know. We are aware that once we put a patient on 5-ASA or once a patient goes on biologics, the duration is indefinite. So can we really have that kind of concept in mind as of today, that we will continue a patient on long-term FMT? It's difficult to say until unless we have definite evidence for the efficacy and the safety of a long-term FMT. The duration of therapy, as I mentioned, that is important, but at the same time, documentation of efficacy also should be more objective. It should be more based on the biomarkers and histological remission, and these parameters at the moment are not really documented. And what should be the frequency, and what should be our aim? That should we use it as an induction therapy and then carry on with the other therapies to maintain? Can we combine the two, or can we use it as a rescue therapy? This is what we've been using it as a rescue therapy so far, but can we use it as an initial phase of the disease also? Now, this is what I meant about the compatibility. It has been observed that after transplant, the recipients who have the organisms which he receives from the donor, if those species were pre-existing in him or her, then chances of engraftment of the received microorganisms is better as compared to recipients who did not have those favorable organisms at all in the gut before transplant. The effect of recipient diet on response to FMT, this is a small study, only 18 patients from an important group, Thomas Brody. They evaluated the role of diet in 18 patients, and they found that the patients who had high fiber content, in them symptom control was better. It was not statistically significant, but the trend was that the symptom control was better in patients who could attain or who could keep a high fiber diet. The refinements in techniques to deliver FMT, as I said earlier, that we are going to see many changes in the FMT procedure in coming years. The lyophilization of the oral fecal matter transplant or lyophilization of the stool does not take away its efficacy. And as in the study Lotus, it has been documented that lyophilized powder does better than placebo. And Firmicutes spores have been used as a single microbe therapy. This is the first study, and the important observations were that if we pre-treat these patients with oral vancomycin before giving them firmicute spores, the response is better, and daily administration of spores is better compared to alternate or weekly therapy. In addition to these ways of administration of FMT, the different machines which are coming up now, there are automatic microfiltrate machines which can prepare a washed microbiota for transplant and which can help in giving us the precise dose of microbiota and which can take away the heterogeneity which happens because of FMT based on stool weight. COVID and FMT, as I mentioned, that most of us have stopped using FMT. We also were not using FMT. We are just taking off now after a gap of more than 2 years. That vaccinations for both donor and recipient is done. This is as per the universal vaccination program. And what is important is that should we do PCR in the stool of a donor or not? That is the important issue. We do not have facilities or we don't have standardization at the moment to do that, but we are depending on a regular nasopharyngeal swabs for PCR. So where are we at the moment? To some extent, I'll say that we are at the crossroads. And I'll show this slide. I'm showing this slide to put up a question to you that what should be the positioning or what do you think is the positioning of FMT in IBD in today's time or even in future? If I ask someone today that what happens to a patient who's steroid dependent, what will you do? I think the obvious answer will be we'll use immunosuppressives. If they don't work, we will go to biologics. And there are so many groups of drugs available, anti-TNFs, anti-Dns, anti-interleukins, small molecules. Many molecules are in the pipeline. And we're going to have a plethora of new drugs. But what are the problems with biologics? The evidence is robust, but we are playing with the immune system of a patient. The risk of infection is substantial. The cost of therapy is prohibitive in countries like ours. On the other hand, we have a science which is microbiome-based strategies, which at the moment has limited data, but it doesn't tamper with the immune system of a person much, and the safety profile seems fairly good, and the cost is much less. So I'll conclude that FMT is effective for inducing as well as maintaining remission in mild to moderate ulcerative colitis. Data in ulcerative colitis is very limited. Data in Crohn's is very limited. That's why I didn't refer to Crohn's. The lower GI route of administration is better than the upper GI. Higher frequency and pool donors may be better. Safety profile seems good. Maintenance therapy is beneficial, but the confounding effects of diet, concomitant medications, and other environmental factors which can influence the response rates should be kept in mind. So FMT should not be taken in isolation. A holistic approach is needed. Thank you. Thank you very much.
Hello.
Thank you, Dr. Sood. It was a difficult topic, and none couldn't have done any better job than anybody else. So, any questions, comments from the panelists or chairpersons?
Good morning, sir, for that excellent talk and providing so many insights about FMT and IBD. So as you have mentioned, the experience in Crohn's disease is limited, but just wanted to know, is there any difference in the selecting the stool, especially in the composition, in particular bacterial strain would be better in ulcerative colitis when compared to Crohn's? Is there any data, anything to have that?
Thank you. Regarding IBD, when it comes to FMT, it doesn't matter. We prepared the stool in the same manner. I didn't mention because we don't have ourselves even experience of using it in Crohn's, though we could have had the pandemic not been there, because we were about to start using it in inflammatory ileocecal Crohn's disease. But as the things shaped up, now we were off program for 2 years and now we're getting back to it. The preparation of the stool remains the same.
Sir, it's still investigational therapy. So, how much time would you take that it would be into clinical practice, and what is the way forward to it? Because in a country, in our country, what I feel because of the dietary habits when compared to the Western world, maybe the stool sample may be better when compared to the Western stools, and most of the data is coming from the Western, only from your data from India. So since we believe that our dietary habits are better when compared to West and stool supposed to be better, so is it going to be more promising in Indian countries like that when compared to West, and the future is more here than West? Do you?
I totally agree with you. I also share your thoughts that Indian stool may be better because of our vegetarian diet, or little more regulated diet. Now, when we talk of pathogenesis of IBD, the first thing comes to mind is the westernization and the Western diet. So it has been known since many years that Western diet is not very good, and it's more pro-inflammatory. And I agree that Indian donors may turn out to be better, but it's just presumption. We have to document it. At the moment, really, if you ask me, is there a definition of a healthy gut microbiota? There's none. We really don't know what matters in FMT. Is there a particular set of organisms which determine the response or which makes the response better? We really don't have that much information. And that's why FMT is still at the experimental stage, because we don't really have a definite link as far as responsiveness is concerned, or as far as direct relationship of cause and effect, and you try to block a particular mediator of the inflammation. We don't have full details about the efficacy of FMT at the moment. And we need to have more RCTs before we can say, because what we base our observations for induction is around 200 patients of FMT. So that's too less a number of patients to have a generalized acceptability.
Thank you. Thank you.
Any other questions, comments from the floor? Yes, sir. You can ask, I'll pass on the question. You can ask from there, I'll pass on the question. Sir, the question from the floor is, don't you think by doing FMT, there is a chance of introducing opportunistic infections into somebody without them, basically?
Yes, I think that's a very important question. The theoretical risk is there. That's why I mentioned that the periodical screening of stool is very important. Donor stool is very, very important. And we do that every 3 months. And nowadays we're depending on this multiplex PCRs, which checks the bacteria and the viruses and the protozoa. So it's important. Theoretical risk remains. But what has been observed that if there's an infection, obviously deterioration will occur after receiving FMT. This doesn't happen. So this is indirect evidence that the infections are not being transmitted.
I mean, despite the strict protocols, even in US, there was a death reported, I think, a year or 2 years ago. So yeah, it's a valid concern. Any other? Okay, for no more questions, thank you, Dr. Ajit. Thanks for that wonderful disposition. With that, I will thank Dr. Srinivas Murthy and Chairperson Rohan Reddy and Jahangir, and we'll move on to the next session. So next few talks will be Chairperson Dr. Chandrasekhar Reddy, consultant gastroenterologist at Yashoda Hospital Somajiguda. Dr. Pandrangaro sir, retired Professor Usmania, he's in private practice now. And Umadevi madam, currently working as a professor in gastroenterology, Usmania. To chair the next session, please. We got a slight change in the topic order. Instead of my topic, we are swapping with next one, which is very, very debatable, very important topic, which biologic and when. We often get into this confusion whenever we use biologics, which biologics to start with and how to switch and when to use what and all. Very, very common dilemma. So for this, we have an excellent speaker, Professor Ian Lawrence. So I worked very closely with him. Most of my IBD training was guided by him in Australia when I spent a year. He is currently working as adjunct professor in University of Western Australia. He is also head of Centre for Inflammatory Bowel Disease, St. John of God, Subiaco, Western Australia. He is in management committees for many organizations, Crohn's and Colitis Care, and he is also in the management committee for Australian New Zealand IBD Consortium. He is also part of the management committee for International IBD Genetics Consortium. He is a very big name in IBD circles. He is also an excellent colonoscopist, which many people don't know because I worked very closely with him. I know very well. So his video will be played and Professor Ian Lawrence will be joining for Q&A. So we got two moderators for this session. Dr. Raju is not there actually. So I invite Dr. Chandrapuli, who is a consultant gastroenterologist at London Gastrocare, to join the panel, and we'll play the video shortly.
Thank you very much for the invitation by the organising committee to speak. And thank you very much to Kieran, who I've known for a very long period of time, for the invitation to speak. I wish I could be there, but unfortunately, with the world the way it is, this is probably the best we can do. Hopefully one day I might be able to visit. Now, these are my disclosures. We know that Crohn's disease is a progressive disease. We know that things get worse with chronic inflammation. They can develop strictures, fistulas, abscesses. Many people need surgery, and unfortunately, that does not stop the recurrence of the Crohn's disease. So the whole point of what we're treating with Crohn's disease is to try and keep the inflammation under control so we do not develop complications. If we have the inflammation under control without complications, then people can lead an extremely normal life, no symptoms, and feel perfectly well. Ulcerative colitis is also a progressive disease. With the chronic inflammation, we get changes in the permeability of the gut. We can get disease extension, so up to 50% of people with proctitis can extend to a pancolitis. We get altered motility, so if people, even if they have the inflammation fully under control, they still get irritable bowel type symptoms. They feel unwell. They may be going to the toilet frequently. And eventually they can develop narrowing, stricturing, a lead pipe, and we know that malignancy is also a complication. Now, we want to alter the natural history. We want to avoid complicated disease behaviour. That means we want complete resolution of symptoms without complications, and that's complete control of both the macroscopic and the microscopic intestinal inflammation. How are we going to achieve that? Well, hopefully we can achieve that with the minimum amount of medication. We know that cost is a major problem in all of our health systems, so if we can do it cheaply and keep people well, then we're doing a lot better. We want to minimise the risk of complications, surgery, structural abnormalities, and also the risk of malignancy in later time. And we want maximum compliance. Patients need to take the medications. If they don't take the medications, they do nothing in the bottle. So we have our drug choices. Basically, we say for mild disease, we tend to have the lower of the pyramid, and for more severe disease, we go at the top level. And in terms of biologics, we have the anti-TNF-alpha medications, the anti-integrin medications, such as vedolizumab, anti-IL-23 and IL-23, IL-12 antibodies, and at the moment, the JAK inhibitors, which are not strictly biological agents, they're small molecules, but they tend to fit in that category because of cost. So when we're looking at the patient, we need to get the right drug for the right patient. We want individualization of the therapy. So the inflammation and inflammatory bowel disease, this is probably both true for Crohn's disease and ulcerative colitis, although they are quite different diseases. It's thought to result from inappropriate activation of the mucosal immune system by intestinal luminal antigens in genetically susceptible individuals. So we know there's a lot of genetic components, at least over 160 genetic markers have been found in Crohn's disease and ulcerative colitis. We know that colonic Crohn's disease is very similar to ulcerative colitis, while ileocolonic and ileal Crohn's disease is quite genetically different, both to ulcerative colitis and colonic Crohn's disease. So they're actually a multitude of diseases. They're not just Crohn's disease, they're not just ulcerative colitis. Acute severe colitis is different to the mild colitis that we get that's just treated by 5-ASAs. So it's a multitude of diseases, and if we can actually profile the patients by looking at their molecular genetics, their external environment, which we do know impacts greatly on the way the disease presents, that then impacts on the intestinal flora, and then we might be able to get a clinical phenotype, and we'd be able to target that clinical phenotype. Unfortunately, our science is nowhere near there. We're trying to do that. We're trying to actually look at this, but we're not there yet. Hopefully, we will be in the future. So when we've got a drug choice, we have the mild to moderate to severe treatment. And the way I've actually broken up these drugs is into topical, which are the polymetric fees, the 5-ASAs, budesonide, budesonide MMX, and the rectal preparations. And then I've put the anti-integrins into a targeted, because they do not work anywhere else around the body apart from the small population of chronic lymphocytes that target to the intestine because of the integrin alpha-4 beta-7. And in terms of natalizumab, it's alpha-4, so that goes to the intestine and also to the brain. Then we have the systemic medications, which are more likely to have systemic side effects. So we have prednisone, the immunomodulators, azathioprine, 6-mercaptopurine, methotrexate, tacrolimus, mycophenolate mofetil. And then we have tofacitinib, again, a small molecule that probably fits into the immunomodulator category, and the anti-TNF-alpha, IL-23 and IL-12 antibodies. But be careful. The way we use them, beware of complications. They may be unexpected. So when we're looking at the use of these medications, there's several things we need to consider. We need to consider the disease type and the location. That's going to give us the severity of the disease. We do know that the anti-TNF-alphas work well in terminal ileal Crohn's disease. Perhaps things like vedolizumab don't work quite as well in terminal ileal disease or stricturing disease. We have the various different medications we want to look at. We need to see their efficacy both in Crohn's disease, in ulcerative colitis, in the phenotype of Crohn's disease. We want to see what the long-term outcomes are. Some medications have more serious side effects depending on the background of that particular patient and also their age. So the older a patient is, the more likely they're going to get a problem with lymphoma if you use the thiopurines. If patients have a clotting disorder, then you don't really want to use tofacitinib, which is increasing the risk of clotting. And if people have got skin cancers, 6MP, you try to avoid. Melanomas, you may want to avoid the anti-TNF-alphas. Severe cardiac disease, again, the anti-TNF-alphas would want to be avoided. Complications, we want to avoid the stricturing, the perforation, but if you've got people who've got perianal Crohn's disease, then we know that the medications infliximab and Humira have been shown to be efficacious in perianal disease. It's probably also true of Stelara, though they have not done specific dedicated trials looking at that. So we need to think about safety. We also need to think about fertility. So there have been published studies looking at infliximab, vedolizumab, Humira in the safety throughout all of pregnancy. We know it's also 6-mercaptopurine is safe throughout pregnancy. We don't know that so much with tofacitinib, tacrolimus, less likely to be known. So knowing about fertility and what people's choices are when they get well. Compliance. Some people have needle phobias. You do not want to give them a subcutaneous injection unless you can actually get somebody to give it to them. People may be very bad at remembering to take their medications every 8 weeks, and they're vastly better to remember taking it every 2 weeks or having a daily tablet. Cost, very, very, very important, but it's cost with efficacy. So you may have an expensive medication, but they do not use all the other aspects of the health system, so overall it becomes a lot cheaper. But if you have a cheap medication and they're using the health system a lot, then you're probably going to find that it's actually not quite as good. And then travel. So people, can they take their medications with them? So if we look at vedolizumab in Crohn's disease, we know in clinical remission, clinical response, yes, it is better than placebo, but it's not as good as we would have liked. And if we look at 6 weeks and we look at in clinical response, it was not as good. Over time, the clinical remission at a later stage, yes, it was better at 8 weeks and 4 weeks. There really was no difference between it, and is better with corticosteroid withdrawal. Ustekinumab, however, at the primary clinical response was better both at 12 and 8 weeks. And I know you cannot compare between studies, but if you look at the numbers in terms of the clinical remission and the clinical response, it was better than vedolizumab. And the secondary endpoint, which was remission at week 4 and 44, we're looking at 50 to 60% of patients. That is actually really rather strong. If we look at adalimumab, we have numbers that are approximately 40% at weeks 26 and 56. Numerically lower, is it statistically different? Well, this particular study doesn't show it. If we're looking at the remission in terms of clinical remission over a longer period of time, so basically 3 years, we're finding that people with ustekinumab maintain that remission if they're actually remission at week 44. If people have previously had an anti-TNF-alpha medication and failed that, their response is worse than if they've only had conventional therapy. Now, is that due to the fact that the disease is worse, or is it due to the fact that there's modification of the immune system, meaning that the second biologic doesn't work as well? We actually don't know. If we look at adalimumab and then we scale it, that's 60%, we find that over 1 year, the response, remission rates, and so on are less than you would for ustekinumab. Again, you cannot compare between studies, but it would suggest that ustekinumab may have a better long-term response. If we look at it overall, people from the time at the beginning, an intention to treat throughout, it's still extremely good at 3 years. If we look at the SONIC study, infliximab, we know that people do better on combination therapy with azathioprine and infliximab. It's also true for methotrexate and infliximab. Janssen did not think that was going to be the case when they did the study. This is both true at 6 and 12 months. So this is using combination therapy. It's not just one medication. It's now looking at 2 medications. That's going to increase the risk of potential complications. And it's also going to increase the cost. So when we're looking at the induction of remission, when they're doing this comes from the ECHO a couple of years ago, it showed that really infliximab, adalimumab, ustekinumab, and vedolizumab all work as first-line biologics. They also all work for clinical remission, as does golimumab. But when they looked at the way it worked, they thought that infliximab and adalimumab at that time, probably because we've had the most experience with them, have the highest induction of clinical remission. Now, I think ustekinumab can now be put in there as well as a definite first-line medication. But if a patient has lost response to infliximab, then ustekinumab is the preferred second-line agent. But as we know that patients are less likely to respond to a second biologic than a first, and ustekinumab does not require a dual immunotherapy, and it's maintained at least for 3 years very well, that's something to think of at first line. Now, if we're looking at ulcerative colitis, vedolizumab data is a lot stronger than with Crohn's disease. So at 6 weeks, very much different. If we look at the clinical response, we had 47% patients. Now, clinical remission was only 17%, but despite that, 41% had mucosal healing. Showing again in ulcerative colitis, just because you've got mucosal healing doesn't mean you don't have symptoms. So our clinical remission criteria are flawed when we're looking at active inflammation. Over a long period of time, it worked extremely well, vastly better than placebo. If we compare ulcerative colitis to the ACT studies, we can show that it's actually not, it's actually better than the ACT studies. So clinical remission of 52% was 44%. We have 56% with durable clinical response, 20% with durable clinical remission, 51% with mucosal healing, whilst we're looking actually only at 41% with response and 15% with remission. So vedolizumab is probably even better than infliximab, but when you're looking at the induction of remission, infliximab and vedolizumab are regarded as the first two choices. That is definitely above adalimumab. Now, because tofacitinib is a newer medication, we don't have the experience, and also it has the potential of side effects, possibly more so than infliximab and definitely more so than vedolizumab. So induction of mucosal healing, again, infliximab and vedolizumab. If we look at maintenance of remission and clinical healing, infliximab and vedolizumab are very strong. And so first line is regarded as infliximab or vedolizumab, knowing that infliximab is going to have to be combined with an immunomodulator such as methotrexate or 6-mercaptopurine to reduce the risk of antibody formation. 70% of people who are going to make antibodies do it within the first 6 months, and 90% of people who are going to make antibodies do it in the first 1 year. So the combination therapy should be continued for approximately 1 year. We know that there's a 50% loss of response in 1 year if you do not try and reduce that. Second line, tofacitinib is a very good medication, or vedolizumab over infliximab. So the things to consider: patient genomics. We need to consider the patient themselves, the intestinal flora. Unfortunately, we do not have all of the data to be able to do this, but in the future, hopefully we will. Fertility, vedolizumab, infliximab, adalimumab, and hopefully Stelara are all going to be perfectly fine in pregnancy. We look at complications. We want to avoid those, so look at the patient, what risks they already have and whether the medication will make it worse. Look at the long-term outcomes. And also, particularly with ulcerative colitis, can we ever stop the medication is something to be considered as well. So hopefully that is actually helpful for you to have some idea about which biologics to use when in ulcerative colitis and Crohn's disease, and hopefully I'll be able to take some questions for you. Thank you very much.
Good morning, everyone. I'm extremely grateful to Dr. Kiran Peddy and the entire team at Yashoda for inviting me to give this talk. I'll be talking about visualizing Crohn's disease, essentially perianal Crohn's disease. I put across out here 7 or 8 issues which I feel are very relevant for managing a patient with perianal.
Thank you, Ian, for that wonderful talk. Any questions or comments from chairpersons, moderators? To come here and ask, actually. Are you able to hear us, Dr. Lawrence?
I can certainly hear you, yes I do. I haven't seen you for a long time, Kieran.
Very nice and very clear understanding presentation, sir. Actually, do you prefer infliximab or other biologics? In case of ulcerative, is there any difference between ulcerative colitis and inflammatory bowel disease depending on the severity? And what about your take on biosimilars?
Well, I think in the biosimilars, the name is exactly what it is. So a biosimilar is identical in all categories. And so the medication, whether it be infliximab biosimilar or infliximab originator, will make actually no difference. And it's the same for adalimumab and any of them, because under the criteria, they have to be identical. everything to do with the company in terms of patient support and education and so on. That's really the difference, whether you can dose escalate. In terms of acute severe colitis, well, ulcerative colitis, you would go for infliximab prior to vedolizumab, just because of the speed of action. And also it's had examinations looking at acute severe colitis with cyclosporin or infliximab, and even rapid dosing tacrolimus has been used by the Japanese for acute severe colitis. So you certainly wouldn't use vedolizumab first line in that situation.
Thank you.
Many thanks, Ian. I'm Dr. Pulli. I have a very limited experience of IBD practicing in India. And I'm not sure if you know Barney Hawthorne, Ian, from Cardiff?
No, sorry.
No. He's one of the IBD specialists. I was with him for more than 12 months with IBD over there. And I was practicing in UK for almost 2 decades. And my practice is exactly what you've been doing there. There are a lot of challenges of practicing IBD in India. Few things that I see is as you probably know, the viral hepatitis is very high. And we do monitor that. I'm sure you had a different topic on that or no? Okay, fine. And we do see those challenges in some of those Chinese immigrants in UK about what to do, how to monitor with biologicals those patients. And also, you probably know the tuberculosis is very high in India. And what's your practice about changing the biologicals, switching from one to another? Would you actually go back and redo all those TB screening? And what's the practice that is relevant to India if you had to do that?
Well, I think there's several things that are very good. It's one, vedolizumab, I don't think we have to worry about TB at all. So therefore, using that on a first line ulcerative colitis is very good. And so if somebody is TB positive or latent TB, it's actually not a concern. You would treat the TB or the latent TB on its own merits, not by the fact you're going to be starting the vedolizumab. Stelara may also be the case as well. So we don't have enough data yet, I think, with ustekinumab with that, but we also have found that TB exacerbation with ustekinumab doesn't appear to occur. I'm not 100% sure on that, but we'll have to watch this space. So again, if we're looking at Crohn's disease, ustekinumab may be a better first line than the anti-TNF alphas, which we are all very, very aware can reactivate latent tuberculosis. I personally, if somebody always is tuberculosis positive and has been treated, there's really no point rechecking because they are going to be positive. And so it's not going to help you. Yeah. If they are latent and have been treated, again, rechecking is not going to help you. If they're latent or they've been positive and not treated, well, then you'll treat them, I think, for 4 weeks before you'd start the anti-TNF alpha medications. That would be our practice. It depends on the severity of the tuberculosis, I think, in terms of how much damage and how much activity there would be, depending on how long you would wait. In terms of vedolizumab, I'd be quite happy. I would check everybody for tuberculosis anyway, just so I know. But vedolizumab, I'll be quite happy to start with. Ustekinumab, I probably would still talk to my infectious diseases consultant and say, should I actually do anything? But I suspect it would be a watch and see.
Okay.
What happens? What is the practice in India?
No, I have a very limited exposure here. I only just moved back less than a year ago. So, and the clinical dilemma is quite high. It starts from right from the first topic Kiran has started today, and you see these structuring diseases and you think it's Crohn's from there. And then you do all the TB tests on those things that come back as negative. Your gut feeling still says TB, and I've been enlightened with that this morning. And then we had another topic where halfway through the biological treatment, they did biopsies and they found some microbial organisms in that.
I must admit my practice has been informed by Indian papers on this, very much so, in terms of the differentiation between tuberculosis and Crohn's disease.
And the other good topic would be the viral hepatitis along with this IBD in future. That would be quite useful.
Again, I think viral hepatitis is probably not a problem with vedolizumab.
The monitoring aspect, I mean.
Oh, in terms of monitoring, I think the monitoring would be as is, as per the viral hepatitis. I don't know if the vedolizumab would alter that at all.
Thank you very much. Thank you.
Thanks for the very informative talk. I'm a gastroenterologist who's moved more into hepatology practice. I do happen to see IBD patients from time to time. So I'm going to ask you a controversial question. Should we be treating as a generalist or somebody with other subspecialty interests in gastroenterology, not particularly focused on IBD? Should we be treating patients with moderate to severe Crohn's or not with biologicals? That's the first question.
So you mean as a hepatologist, should you be treating moderate to severe?
Yeah, I mean, not necessarily as a hepatologist, but you could be a generalist. You could be a generalist. Could be treating all kinds of GI diseases. At what point do we stop treating these patients? Should we be treating them at all? Number one. Number two is the role of 5-ASAs in Crohn's disease. I do treat some patients with mild IBD, Crohn's disease, where I find that some of them go into remission with these 5-ASAs. And what is the role of 5-ASAs long term? Thank you.
So I think from the first point, absolutely all gastroenterologists should be able to treat inflammatory bowel disease with biologics, and it is the level of the comfort and the knowledge that they have, and it is wonderful to have a specialist centre that they can access, contact people to ask for advice, what should I do next, and also then be able to refer on when they feel uncomfortable, it's getting outside their experience level. That's exactly what we do here. So there's a lot of general gastroenterologists who do IBD. I get a lot of phone calls from gastroenterologists asking, look, I've got this. We talk about the patient, I give them suggestions, they come back, they do this, and usually get the patient perfectly fine. But then there's a tertiary or even a fourth level referral area that when the patients are difficult, when it feels like it's not working and the consultant feels like I'm not winning and I need more help or it's outside my expertise, then they refer on. So I think gastroenterologists all should be able to treat IBD with biologics, moderately severe disease, as long as they are comfortable with their experience and their expertise. The second question with the 5-ASAs, this comes back to the genetics and the fact that Crohn's disease is not simply one disease. It is an umbrella term for a variety of diseases. So we know that colonic Crohn's disease is genetically very similar to ulcerative colitis and quite genetically dissimilar to ileo or ileocolonic Crohn's disease. So therefore, you're less likely to get perforation, you're less likely to get transmural disease, you're more likely to get responses to 5-aminosalicylic acids. So although there are colleagues of mine who say there's no role at all for 5-ASAs in Crohn's disease, I totally disagree. So for people with colonic Crohn's disease, particularly isolated colonic, I think the 5-ASAs can be extremely effective and maintain mild disease under control. For people who have had a terminal ileal resection for fibrotic disease, I would often start them back on a 5-ASA if they're a Rook-Git score 2 before I'd start immunomodulation, and then recheck. Just because of the long-term concerns about immunomodulation, and the 5-ASAs can convert a Rook-Gits 2 to a Rook-Gits 1, and I'm very happy just to monitor them from that point. Obviously, if it extends, goes up to Rook-Gits 3, or it's not affecting the Rook-Gits 2, I'll talk about immunomodulating therapy there. But certainly I think 5-ASAs do have a role in the targeted specific patients, and that's definitely a particular phenotype.
I'm Dr. Ravi Shankar. Recently, we had a patient who used adalimumab and had myocarditis. So when we checked up the literature, there was some support in favor of that. Some case reports are there where use of adalimumab, patients developed myocarditis and cardiomyopathy. Any experience from your side, sir?
I think it's extremely rare. And it's like when we get adalimumab-induced pneumonitis and the fibrosis from that. Yes, it occurs. I think they're rare. I think the pneumonitis is a lot more common than myocarditis and cardiomyopathy. But I think, yes, we would use our consultant respiratory physicians, consultant cardiologists, and be guided by them as well. And if they say, look, really, I do think it's related to the medication, we have other medications we can use. And so it would not stop me using the medications, because I think they're rare complications, but it's also something to be aware of, so that if they do appear, then it's something to think of as a side effect from the medication, and then look to stopping it or transferring to a different biologic or different medication.
In this patient, we had to stop the medication because the patient became breathless and ejection fraction has gone down a lot, and she improved subsequently. In my experience, I don't know about, maybe the same in India, out of 5 patients we give infliximab, 2 patients develop tuberculosis. And the response to ATT is quite good in these patients. Sometimes we may have to restart, but sometimes we prefer to go to the other types of medications. With vedolizumab, there isn't that much, we haven't found tuberculosis that much. But in certain clinical trial situations in India, if a latent TB is found, the drug is not allowed, even if it's treated. Vedolizumab trials, vedolizumab. Is the same situation world over?
Yes. Unfortunately, when they make the clinical trials, you basically have to be TB negative. You're not even allowed to be indeterminate. It has to be negative. If you get an indeterminate, you have to retest. And if it's indeterminate again, often the patient's not allowed to be included in the study. So yes, unfortunately, that's all clinical trials have done that. Both for vedolizumab, ustekinumab, tofacitinib, and so on. It's just their generic inclusion criteria or exclusion criteria, unfortunately.
Thank you so much.
Hi, sir. Hello.
Hello.
I have a 14-year-old kid actually had a severe Crohn's. He was doing well clinically on adalimumab. The parents, because he was already on for 3 years on adalimumab now. Clinically is better, endoscopically only partial remission. Is it right time? Because parents go on asking, can we stop biologicals? But there is only partial remission on endoscopy, colonoscopy, and he was doing clinically well. So they are asking 3 years down the line, can we stop biologicals? This is the one question. And second thing is it time? Because there is only partial remission on colonoscopy. Because the disease is still there. There is remission on ascending colon, and ileocecal disease has come down, descending colon disease has come down, but transverse colon, there were long ulcers, and so endoscopically there was not much remission. Is it time to shift over to another biological?
So first question is no, you can't stop medication. Before, in Crohn's disease generally, if they've had severe disease, I think they're going to be on medication for life. I don't think they're ever going to come off medication. I think you've got a very high chance of flaring severely.
How long? How long?
Sorry?
How long biologicals? How long?
Oh, indefinite. I'm sorry. We may change biologics when they get 50, 60 years, we get more biologics. But my experience is people do not do well coming off the biologics if they've required them for Crohn's. The adalimumab, that shows you our issues with our clinical acumen versus our endoscopic, histological, and objective measures, whether that be fecal calprotectin. Did he have a fecal calprotectin at all?
Yes, that was coming down. That was coming down, but he's doing clinically very well. He has gained weight. His height, he has, yeah.
And that's great. The other thing is, because it's a chronic disease, he's doing very well, but he may also not be doing as well as he thinks he is. So if we say that, here we go, they're my hands. If we say that that's full remission, he may be here, he used to be here, but he wants to be up here. So I would suggest with him, you should do an adalimumab trough level if that is possible, because if you find he has antibodies and there's no trough, then you go, right, well, the reason why he's still doing well, he's actually not getting any adalimumab that's actually doing anything, so he needs to change biologics.
We don't have adalimumab drug levels. In between, we shifted to infliximab, but he was not tolerating well in infliximab.
So the other thing is, are you able to get compassionate dose escalation in the adalimumab to go to weekly or 80 milligrams fortnightly?
Okay.
Because that's what I would probably do first, is double the dose of the adalimumab.
No, according to his weight, he's already on 80 milligrams every 2 weeks.
Yeah, so he's already on double dose.
He's good.
Yeah.
He's on good dose. His weight is around 31 kgs.
Yeah, so he's already on double dose.
He's quite young. He's 15-year-old.
What was he not? So it may be worthwhile to ask the company if they can test the adalimumab trough level for you, if you had that at all, because the company may be able to do that for you. If the double dosing is not working, then sometimes the addition of an immunomodulator, a very low dose.
No, he was already on azathioprine. He's already on
that.
Yeah.
So if infliximab did not work and adalimumab's not working, the question is, what are we going for here? We want him to have a good quality of life, and sometimes it can take many, many years for inflammation to fully resolve.
What about total enteral nutrition in this child?
He's 14. If you can get him to do it, it would be a great way to potentially put him into remission and maintain that with the adalimumab. It's obviously not a long-term option. I mean, we've seen Ari Levine's work in Crohn's disease and ulcerative colitis with the restricted diet. That is a very difficult diet to do. You need 2 potatoes, 5 strawberries, it's very restrictive. So I have a dietitian doing a PhD at the moment looking at diet and basically pretty much an optimized vegetarian diet and various other things to see whether or not this is going to impact on diet. And going very much from the previous talk, the changes of the microbiome, the way diet can actually affect that. If he is well clinically, if he is continuing to improve, even if that is slow and his growth is going well, then I think that the adalimumab 80 milligrams would be continued because he's actually clinically doing very well. We always have to treat the patient before we treat our parameters. Doing dietary modification for a period of time may not be a bad idea because that can give us a 6-week potentially induction of remission to see if that actually makes any difference to him clinically. If he says, oh, I feel amazing now, I thought I was well, but now I actually am well, that shows us that actually clinically he was doing okay, but he was not as good as he could be. It is difficult because we're already on adalimumab, you're already on another immunomodulating medication in an environment in a young person that long-term infection risk is something we try to avoid. Vedolizumab certainly does work in Crohn's disease. Absolutely. We have published on that. It definitely does work. Does it work on everyone? No. But I certainly have people with ileocolonic Crohn's disease who have gone into complete remission with it, endoscopically, histologically, and clinically. So that is always something to think of. Do you have access to Stelara for the 18-year-olds by compassionate use at all? No? That may potentially be coming, so ustekinumab and Stelara, so that's a potential something for the future. But I would think that the diet would be a good option to the double dosing of the adalimumab. If that shows that things are very much better and you come off the diet and he maintains that, wonderful. If he does progressively get worse, then perhaps change into vedolizumab might be an option.
Thank you.
In the interest of time, we'll close this session. Thank you, Ian, once again for the wonderful lecture.
Thank you, Kiran.
Good
Lovely
to see you.
Bye-bye.
Bye. Okay, so I'll try to catch up some time here. So I'll be giving my talk on vaccines in IBD. For this, I request Dr. Ravishankar Reddy, Dr. Shivanand Reddy to join the moderator panel. So I'm going to run my slides a little faster to catch up time, but we'll be happy to answer any questions. Vaccines in IBD. Yeah. Share yellow. Okay, so vaccines in IBD is again little controversial topic. When should we do and all? So I'm going to run few principles. So if you look at IBD patients, they are very vulnerable because of infections and also because of the medication they regularly take, be it immunomodulators or be it biologics. And the other general principles are non-replicating vaccines can be given irrespective of the immunosuppression. So don't worry about what the patient is taking, but we can safely give them. But if you're talking about live attenuated vaccines, and you can give them if there are no plans to start immunosuppression in the next 1 or 2 months. But if you're already on immunosuppression, you need to stop for 3 months and 1 month for steroids before we give any vaccines, live vaccines. We need to check immunization status on diagnosis. Hepatitis, I'll come to that, B and MMR, varicella and Epstein-Barr virus, and even for azathioprine. Vaccine effectiveness can be lower if the patient is already on immunosuppression. Yeah, there are different grades of immunosuppression. I'll show one of the slides here. Okay, what are all the vaccines to consider? We can consider yearly influenza. We should ideally include H1N1 and one of pneumococcal 13 and 5 yearly 23. Human papillomavirus, meningococcal, hepatitis B, Tdap, and questionable Haemophilus influenza, and zoster is not available in India. When to vaccinate, the timing? At the time of diagnosis ideally, because 2 reasons. One, it will allow enough time for vaccines to work. And also if the patient goes on immunomodulator in the future, if you were to consider vaccine, whether it's live or non-live vaccine, the effectiveness of vaccines will be lower. So for these 2 reasons, you can consider vaccination at the time of diagnosis of IBD. If the patient is already on immunomodulators, when by the time you see the patient, you need to vaccinate, especially before biologics. And because if the patient is on immunomodulators, yes, you can still vaccinate them, but before you contemplate biologics, it's better to vaccinate. So something is better than nothing. If you're talking about pneumococcal vaccine, you need to give a gap of 8 weeks between 13 and 23. But sometimes you get a patient who already received 23 vaccine. I'll show you a slide on that as well. You need to give a gap of 1 year before giving pneumococcal 13. And most of the vaccines can be given together, but obviously it's a painful experience for patients, so the patient logistics won't allow. So you need to categorize the patient depending on the medication, 3 or 4 categories. So no immunosuppression, that means he's not on any immunomodulators or biologics. If somebody on low immunosuppression, that means patient is taking less than 20 milligrams of isolone or azathioprine and methotrexate as well. High immunosuppression, patient is on anti-TNF. And some special category patients, pregnant children and travelers. So a series of these non-live vaccines. Influenza, you don't need to check immunization status, and this is technical details you probably can get anywhere in the product information as well. That can be given yearly. Pneumococcal 13, you can give once, but if the patient already received 23, you need to give a gap of 1 year. And if the patient not received any pneumococcal, you give 13 first, and then give 23 2 months later. But repeat after 5 years again. Tdap, again, single dose, and then TD booster in 10 years' time. Hepatitis A, in Indian context, we don't routinely check and probably don't require vaccination. Hepatitis B, and check immune status 1 month after and consider double dose to revaccinate. Human papillomavirus, considering 11 to 26 years, both males and females. Meningococcal, high-risk individuals and teenagers. If the patient is not on any immunosuppression, you can give live vaccines, MMR, varicella and zoster. Zoster is not available in India, as I said. And if especially patients on MMR, we are considering giving MMR, household contacts should also be vaccinated. And once they receive live vaccines, defer immunosuppression for at least 1 to 1.5 months. Varicella zoster can be considered even if the patient is on low level of immunosuppression. Vaccination in pregnancy, children born to mother on immunosuppression is a little controversial. So you get a patient who is already on immunosuppression, patient delivers a baby. What is the vaccination strategy for babies? If the mother is receiving biologics, for example, you need to avoid live vaccines to children or babies for 6 months. If these are kind of vague recommendations in IBD circles, but no strong guidelines on this. If the patient mother is on azathioprine, for example, delivers a baby, and you should consider stopping live vaccine to baby for 3 months. What about vaccination for children in IBD? Most of the children, by the time we see them, they're already vaccinated. But very early onset IBD patients are at an increased risk. But you need to go through the immunization diary with the parents and fill any gaps. But if the patient requires some kind of therapy to go into remission, consider exclusive enteral nutrition. If the patient is already under 13 years of age, they usually get 2 doses of varicella zoster vaccine. But if you happen to see a child who is 13-year-old, not received, not immunized with varicella zoster, as adult you give 2 doses of varicella zoster 4 weeks apart. Some special situation, no again consensus guidelines like rabies in rural areas. Travelers, yellow fever is a live vaccine. There is no alternative for that. If the patient is traveling to endemic area, you need to stop immunomodulators for 3 months before they give vaccination, then give a gap of another month before they travel. So household contacts is again little controversial, and if you have immunocompetent contacts of immunosuppressive patients, you can safely receive inactivated vaccines. But if they're going for live vaccines, some kind of barrier should be observed. They should be staying away from live vaccines for some time. So I'll skip this. So what about the vaccination response? If the patient is on monotherapy, that's better than on combination therapy, and is the patient anti-TNF that comes in between. So cost analysis, this is pertinent to Indian population. Just a rough idea how much that will going to cost. Total course for the pneumococcal vaccines is about 5,600 rupees, and again 600 every 5 years. Hepatitis B, as we know, very cheap, and this is hepatitis human papillomavirus, costs about 7,000 for the 2 doses together. MMR, so it's about 3,000, and in the context of IBD, contemplating higher treatment, that is significant cost, but that will prevent a lot of opportunistic infections and prevents hospitalizations. What do? I counsel the patient about the disease and implications, and I tell them that we need to prevent any complications and protect from infections. I do immune testing, hepatitis C, hepatitis B, anti-HCV, HIV, anti-HV total. Sometimes check immunity levels for hepatitis B. I regularly do antiviricella zoster IgG, and sometimes, especially young patients going for azathioprine, I do anti-EBV IgG. And newly diagnosed and patients start with 5 SS. We complete vaccination both live and inactive, whatever is deficient, and then go on to screen for medication-specific screening like TB quantiferon gold and other things. Patient already on immunomodulators, immune testing to see what is on the horizon. If need be, we need to stop the immunomodulator for 3 months and vaccinate starting 1 month after starting and then finish off. If the patient is immune for varicella zoster and MMR, and you just stick to annual flu and pneumococcal vaccine. Especially you're contemplating biologics, varicella zoster pneumonia. Varicella pneumonia can be very nasty for these patients. Already on biologics, difficult call whether to stop the biologics and immunize these patients, or you just carefully watch for infections and then counsel and then treat them as they come. If the patient is unaffordable for vaccination, by default they are not affordable for biologics. So we need to take help from societies, pharma guys to help these patients. Thank you. I can take a quick 1 or 2 questions, but we're running out of time, or I'm here, I can take during lunchtime as well. It's up to you. Vaccines. Vaccines, we don't have enough time for that anyway. So we have to go for biologics and then carefully watch for any subsequent infections and all. So any vaccination you consider, we are talking about 3 months, because we have to stop current medication. If the patient is acute severe colitis, he is not on the medication, so we don't have to wait for that 1 month. But even if you start, say, varicella zoster vaccine now, we have to give second dose after 6 weeks at least and wait for another month. So we're talking about 2 to 3 months gap. So it is not practical for acute severe colitis. Yeah, but we don't have enough time for vaccines. So in that case, vaccines are out of the place. Madam. We don't have any data, madam, as far as you know. No, I didn't do anything personally, but we are actively recommending for these patients to go for COVID vaccination because it's a non-live vaccine.
I think
I do, sir. I do give and pneumococcal 13 and then 23, both vaccines. Then every 5 years, 23.
Sir, is it the duration is 2 weeks or 2 months? Because the recommendation is 2 weeks.
Which one? Pneumococcal 13 and 23.
13, 23, because usually that is the schedule.
2 months. That is 2 months, yeah.
Okay, one last question. Basically, I think this whole vaccine landscape, we have to look at it in a different way. If you, somebody, for example, had a severe disease and you got control with immunosuppression, and then for the sake of a vaccine, you're going to stop it for 4 to 6 months, you have to balance the risk of relapse against what protection the vaccine offers. So in this corollary, what I'll give is, COVID has changed some of the thinking. Post liver transplant, patients are on triple immunosuppression. We are still giving them a vaccine and they're still mounting an immune response.
COVID vaccine.
COVID vaccine. Yeah. So previously, some of the fundamental concepts have been challenged in COVID. Post liver transplant, the previous wisdom was you cannot give live vaccine because they are on immunosuppression. There can be an escape and the virus can proliferate and potentially cause the disease. That is the worry giving live vaccines in somebody on immunosuppression. But all that has changed and we are vaccinating all our post-transplant patients 1 month after the transplant. Just wait for the patient to recover. I think even in IBD, you probably have to maybe take a different look.
So you're giving live vaccines when they are on?
COVID is a live, Covishield is a live vaccine. It's a No, even Covishield has been authorized for use post-liver transplant. So we are giving a live vaccine in somebody on triple immunosuppression post-transplant.
Covishield is not live.
It is a live vaccine. It is live. Covaxin is inactivated. Covishield is a live vaccine.
Okay.
It's definitely, there are again 2 types of live vaccine. One is where there is replication competent, the virus can replicate. Then there is a replication incompetent live virus. Okay. So COVID technically is replication incompetent. Even that was contraindicated previously, but now we've been giving this. So I think what is curious and what is important is what is the risk of relapse of somebody who might have been a difficult disease that you control with immunosuppression, you're stopping it just for the sake of vaccination, versus what is the incidence of these infections that can happen. What I'm assuming is you stop immunosuppression because you want a better response. That's what I understand from what you're saying. You want a better vaccine response.
And also live vaccines, again, the flare-up of, it's an infection basically.
No, but even for the non-live also you're saying you should stop it. It's only for live.
Give it without stopping.
Okay.
I think probably for those type of patients who are a flare, I think we can start and probably after while tapering that, but when you come to the low risk group, like when you are reducing the steroids, when you are
the low immunosuppression,
then we can, I think we can give
less than 20 of steroid.
Yeah, then we can give them.
There is a difference between biologicals and immunosuppressants. Biologicals have a lot of problems with whereas immunosuppressants you can give.
Yes, madam. Biologic fall into high immunosuppression category. We can't give live vaccines, and also immunogenicity will also be lesser. So 2 problems with that. Again, it's an immunosuppressant basically, so the same rules apply. Exactly. So that's very, and even with the, the tofacitinib is notorious for varicella zoster infections. So we have to screen and then use it. So yeah, the induction. Correct. So for that, better to, if they can have time, better to screen and vaccinate. That will require 3 months again. That's the problem. So patient may not be patient, and We don't have adult vaccination centers. Like in my clinic, we always give it. So it's like it's just the same as the child vaccination center. There's no special precautions, obviously. So we can kind of inculcate that habit.
I think if we have a vaccination cell in the hospitals, I think there more chances of patients getting vaccinated and more chance of people referring to the center for vaccination.
Correct. Somebody you go through kind of a whole chart. That's a good point. Correct, correct. That's true. So we'll move on to the next topic actually. So we're running late. So next topic is by Dr. Sumit Bhatia to moderate this session. I thank Dr. Ravishankar Reddy, Dr. Shivanand Reddy for moderating this session. Next moderators, Dr. Bharat, consultant gastroenterologist from Yashoda Malakpet, and Dr. Partha Paul, consultant gastroenterologist from AIG. Partha is not here, I think. So the next topic is the Stride 2 consensus. What are the new targets to treat? So to take us over, I request Dr. Sumit Bhatia. Sumit, are you online?
Yes, I'm there.
You want to do live now? Yeah. Please go on.
Yeah,
Dr.
I think you have to allow to share my screen.
Ashish, you need to allow to screen. So Dr. Sumit Bhatia is consultant gastroenterologist Paras Hospital in Gurgaon. And is also an active member of SAIA. You can share now and see, Sumit.
It is not allowing me to share. I think I'll have to open it from a different browser then. Just give me 30 seconds.
Yeah. So Sumit, if you can try and finish off below less than 15 minutes, that will be great. Sumit? Are you able to share, Sumit? Sumit, are you there? Left. Yes, Sumit, you're on. Sumit, I was just saying, if you can try and finish less than 15 minutes, that will save some time. But I know Stride 2 is exhaustive, but you try your best.
No, I'm sorry, but I'm not able to.
You're not able to share?
Not able to share.
Ashish? Shall we move on to next talk while you are trying to sort out?
Yes, I think so.
Sorry? You should be able to share, Sumit.
I can see the share screen, but all the icons are.
Okay.
Icons are just blurred. So.
Shall we move on to the next topic while you try to sort it out again, Sumit?
Yeah, sure. Please do that.
Sorry about that. Thank you. So we'll move on to next topic, role of TDM in IBD management. So we got two more moderators joining first. Anurag Jaina is a consultant gastroenterologist from PGH Chandigarh. He does he's doing extremely good work in IBD. And Dr. Abdul Khalek, consultant gastroenterologist in Hyderabad. Dr. Devendra Desai, one of the very popular name in IBD circles. He's done a lot of work in therapeutic drug monitoring in IBD. Dr. Desai, are you on?
Yes.
Yeah, please share your screen.
So
please start.
we can have recorded talk, no problem.
Yeah.
Good afternoon. Dear friends, thank you Yashoda Hospital for this kind opportunity. My today's topic is role of therapeutic drug monitoring in management of inflammatory bowel disease. The therapeutic drug monitoring is measuring drug and or antibody concentration, individualizing the dose and maintaining the drug concentration in the therapeutic range. The effect of desired drug concentrations include increased rate of response to treatment, endoscopic healing, reduced relapse rate, hospitalization and surgery, and improved quality of life. The rationale for TDM in IBD are to improve the efficacy and predict toxicity when the drug has a narrow therapeutic range, as in case of thiopurines, and to achieve the desired drug concentration when there is a variability between the dose administered and concentration of drug, as in case of biologics. Proactive TDM is monitoring when the patient is in remission, and reactive TDM is monitoring when the disease is active. Let us move on to thiopurines. Thiopurines are mainly useful as maintenance rather than induction therapy. Up to 40% of the patient discontinue thiopurine due to severe adverse drug reactions such as hematological toxicity, hair loss, and this is due to increased drug level due to genetic abnormality in thiopurine metabolism. And we know that Asians are more susceptible. Little bit about preemptive testing for TPMT and or NUDT15 genotype. Not everybody does this. It may be useful in 50 to 60% of the patient, and NUDT15 testing is more useful than TPMT in Indian patients. So if the genotype is wild, start with normal dose. If it is heterozygous, start with 50% of the dose, and if it is homozygous mutant, which is rare, do not use the drug. If these tests are not done, we can start with the smaller dose of azathioprine and monitor CBC for 4 weeks every week. Thiopurine metabolite testing, which is done after starting the drug, includes 6 Tg and 6 mmP. The therapeutic range for 6 Tg is 235 to 450, and for 6 mmP, it is less than 5,700. As per the AGA guidelines in 2017, thiopurine metabolic testing should be done in patients who have active disease and when there is suspected thiopurine toxicity. It should not be done in patients with quiescent IBD. Now let us look at the interpretation of thiopurine metabolite. We know that these are the normal levels and they indicate optimum drug level. If both 6 Tg and 6 mmP are undetectable, it indicates that patient is not taking the drug and we need to improve the compliance. If 6 Tg is less than 235, it is subtherapeutic range and we can increase the dose. If it is more than 450, it is high, that is supratherapeutic level, and we need to reduce the dose or change the therapy. If the 6 Tg is less than 235 and 6 mmP is more than 5,700, these are the shunters to 6 mmP and we need to reduce thiopurine and add allopurinol. So if we look at the comparison between subtherapeutic level and therapeutic level, we can achieve 40% higher rate of remission with therapeutic levels. This is our data in 272 patients with 342 levels. About more than 55% of the patient had subtherapeutic level, indicating there is a scope for optimization by increasing the drug dose. And 28% had therapeutic level, 16% had supratherapeutic level. It indicates that there is a scope for reducing toxicity by reducing the drug dose. To illustrate this, let us have two examples. This is a 29-year-old engineer, ileocecal Crohn's disease since 2017. He had abdominal pain, high calprotectin and CRP level, and he was initiated on budesonide 3 mg and azathioprine 25 mg. TPMT was wild, NUDT 15 was heterozygous, and body weight was 80 kg. So this is the baseline when it was started. We can see that in January he was well, calprotectin came down, CRP was negative, however 6 Tg and 6 MMP were undetectable, indicating non-compliance, and whatever improvement was directed to budesonide. Then he was started on 50 mg azathioprine, and the levels were repeated in May 2018 and they were subtherapeutic level, so the dose was increased to 75. Subsequently, he remained well, calprotectin also improved, and budesonide was stopped, and 5-ASA was also reduced. The second patient is 51-year-old male with ulcerative colitis. He had active disease on oral and topical 5-ASA. The TPMT was mild and NUDT 15 was heterozygous. He was started on azathioprine 15 mg daily and he was advised weekly CBC. After 2 weeks, the hemoglobin decreased, WBC count decreased, and platelets also decreased, and he had weakness. Calprotectin was within normal range, indicating clinical remission. So his 6 Tg level was 851, and the normal is up to 450. So it was very high level. So the dose of azathioprine was reduced to 25 mg, after which CBC improved and patient remained in remission. Now let us move on to biologic agents. Biologics have brought a paradigm shift in the management of IBD. However, up to 50% of the patients discontinue biologic because of primary non-response or secondary loss of response. And the factors which are responsible for this variable response or loss of response are high BMI, male gender, high baseline C-reactive protein, low albumin, high TNF alpha, and presence of anti-drug antibody, which actually increase the clearance of drug. The concomitant use of immunosuppression decrease the clearance, so it is improvement in the level of the drug. So the AGA guidelines suggest that TDM should be done in patients with active disease, that is reactive TDM, and it should be done in patients on maintenance therapy. The guidelines from the other societies also are similar. About proactive TDM, AGA makes no comment, saying that it is knowledge gap and it is cautiously recommended by Australian Society and the expert panel. The recommended trough level for infliximab is more than 5 with a range of 3 to 7, and that for adalimumab is more than 77.5 microgram per ml with a range of 7 to 12. However, some patients will need higher trough level. For example, patients with Crohn's disease and perianal fistula will need infliximab level of more than 10 microgram per ml. About vedolizumab and ustekinumab, their concentrations have been suggested, but there are no definite guidelines. So, is there evidence for efficacy of therapeutic drug monitoring? So, this is a systematic review and meta-analysis in 2018. It included 9 studies, 3 were RCTs and 6 were observational, and it compared proactive and reactive to each other versus empirical care. The primary outcome was clinical remission, and the secondary outcomes were clinical relapse, endoscopic remission, anti-TNF response durability, the cost, and adverse event. So the clinical remission was not superior with either reactive or proactive as compared to empirical dose optimization. There was, however, cost benefit with reactive as compared to empirical, and the anti-drug antibody formation was less with reactive. The durability of anti-TNF response was better with proactive as compared to reactive or empirical therapy. And however, there was no endoscopic or surgical outcome benefit with either reactive or proactive. There is additional data after 2018, and SAIA et al. Studied pediatric patients, and they found that proactive TDM was better than empirical therapy. However, serine UC and serine study for adalimumab showed no benefit of TDM or empirical dosing. So this is our small experience in 50 patients, and we found that 80% of our patients had subtherapeutic infliximab level, and 27 or 1/4 of the patient had antibodies. So the management was changed in 35 patients with clinical response in 25 patients and remission in 5 patients. So TDM has been questioned or criticized a lot, but what do we do in clinical practice when we really face the difficulty? So let us look at the real life cases. This is a 40-year-old patient with luminal ileocolonic Crohn's disease. He was initiated on biologic for severe disease, not responding to prior therapy. At week 14, Harvey-Bradshaw index was 2, indicating clinical remission. CRP was normal and calprotectin reduced to 150 from 1500. Albumin was normal. In this patient, is TDM required? Not really. Some people would do 1 level at week 14. The second patient is 18-year-old girl with ulcerative colitis, E3 disease. She needed biologic as she had active disease after 3 courses of steroid and azathioprine. At the end of induction, she still had active disease with a bowel frequency of 5 per day with blood in 3. Serum albumin was low, CRP and calprotectin were high. So infliximab dose was preponed. However, her symptoms persisted after giving that. So should we do TDM in this patient? Yes, in this patient, reactive TDM will be beneficial. The third is 21-year-old student, Crohn's disease, luminal Crohn's disease without any perianal disease. Previous treatment included adalimumab failure and vedolizumab failure. At presentation, he was severely malnourished with low albumin of 1.9, high C-reactive protein, high calprotectin. So first 1 week went in improvement in nutrition. After that, he was initiated on infliximab. So in this patient, should we do TDM? Yes, because he has previous 2 biologic failure and it should be proactive. Azathioprine was also added in this patient. So there are some further development in the field of TDM. In case of non-response, we actually change the dose from 5 mg to 10 mg per kg, or we reduce the dosing interval from 6 weeks to 8 weeks to 6 weeks or 4 weeks. Can the patient need actually say 7 mg per kg of dose or 5 weekly dosing interval? So these are the questions which we don't have answer at the moment, and it may be answered by Bayesian model-based dosing, which is called as dashboard approach. So dashboard are basically software program, and they integrate the pre-existing pharmacokinetic model generated from the population, patients and disease characteristic, and the patient's drug level into single display like a dashboard of the car to predict the drug level and dose timing to individualize the therapy. At present, it is available only for infliximab, and there is some efficacy, some evidence for efficacy at present. So, dear friends, TDM has a role in inflammatory bowel disease due to narrow therapeutic window and poor dose response relationship. TDM can be reactive or proactive, and currently reactive TDM is advocated in the guidelines. For thiopurines, if we do preemptive testing, NUTT 15 is more relevant in our population than TPMT. Thiopurine metabolite measurement can improve the thiopurine efficacy by 40% and reduce the toxicity. Biologics, there are low drug level of infliximab, which are very common. Trough level measurement could be useful in approximately 72% of the patient. There is more evidence required for the efficacy of TDM and its use in real life. Newer approaches like dashboard may improve utility of biologic, prevent failures, and save costs. I would like to acknowledge my colleagues in biochemistry and molecular biology department, and thank you for your patient listening.
Good afternoon, everyone. At the outset, my sincere thanks to Dr. Kiran.
Thank you, Dr. Desai. That's wonderful talk. We have just time for 1 or 2 comments or questions from chairpersons and panelists before we try next one. Rami.
A very good afternoon. Thank you, Dr. Desai, for lucid and latest in IBD management. And how early we go for this reactive management? Is it at 2 weeks or when the patient is not responding? Because you said the cost effectiveness will be there when you use reactive TDM.
Yes. So basically, madam, we start thinking about the TDM at the end of induction.
Okay.
At the end of induction, supposing your patient has active disease, then we need to think about the reactive TDM.
I think then that will become empirical.
No. What we do, say at the end of your induction, if your patient is active, then one would do the infliximab or whatever adalimumab level. And if the levels are low, then we would modify the dose.
Thank you, sir. And what is the cost of the average cost of these tests for the thiopurines and in
approximately 5,000.
Okay, thank you.
But certain companies actually subsidize these. At least 2 companies that I know subsidize these. One drug level, they do it free of cost.
Okay, thank you.
Sir, can I have a quick comment, sir?
Please.
Sir, hello, sir. That was a wonderful talk.
I have been reading a lot of literature from you.
Thank you, sir.
Correct.
So your experience on dashboard experience and the biologic TDM monitoring level, it's country's first, sir. I don't think anybody center has still published that. I have a comment regarding that NUDT testing, sir.
Yes.
The odds ratio of NUDT was very high for predicting adverse events in leukopenia. So if in a cost constrained setting, if you are to ask to test one of these, it should be NUDT. Yes. On the contrary, AGA recommends it should be TPMT. But for our guidelines, it should be better the NUDT should be tested.
Your review has itself showed that, isn't it?
Yes, sir.
It's a very nice review.
Sir, Dr. Partho from Hyderabad. Sir, yeah. So I wanted to ask whether what is your approach regarding biosimilars, because this infliximab antibody levels, are they helpful for the biosimilars? Because sometimes we use them.
We do use PARCA. We do use the infliximab antibody for the biosimilar, and in our earlier study we have showed that it is effective, because whenever we are using new drug, we need to document that it is equally efficacy. The levels are slightly different, but it is useful for biosimilar also.
The same assay can be used. Sir.
Yes, same assay can be used, and the same thing has been showed in the Europe also, where they have now in some of the country biosimilar is the first line of actually treatment.
Okay, and also for this thiopurine metabolite levels, do you use mass spectrometry or ELISA, sir?
No,
do you recommend?
mass photometric.
Okay.
So can I ask one thing, Dr. Sumit here?
Yeah, hi.
Sir, regarding adalimumab levels, we only have biosimilars. So
yes.
Are the tests validated to use in all those biosimilars?
Yes, we have just actually presented in the ISG. The level of adalimumab are slightly higher than the range that is mentioned in the West, but they are sort of validated now.
And the cost remains the same, approximately 5,000 rupees for...
Approximately.
Thank you, Dr. Desai. In the interest of time, we'll close this session. Thank you very much.
Thank you so much for this invitation.
Thank you, Dr. Anurag. And Dr. Kalik, you want any comment to make? Okay, thank you. And Dr. Sumit said he'll try once more, just one attempt, and if he's not working, he's going to sponsor us early lunch. Thank you, sir. You can, yeah. Sumit, you want to try once?
Yeah, I think I'm able to do it now. Can you see my slides?
Yeah, yeah.
Are you allowed to bear with me?
Yes, we are.
Okay. Okay, good afternoon, everybody. And at the outset, let me thank Dr. Kiran and the entire Yashoda organizing team for giving me this opportunity to present in this esteemed conference. I'll be very quick in interest of times. I'll be talking about the new therapeutic targets in treatment of IBD, and we'll be discussing what are the STRIDE 2 consensus. So STRIDE 2 consensus are a consensus statements given by a group of international experts on IBD on the therapeutic goals on treat to target strategies in IBD. Now, what is treat to target? So treat to target concept initially was introduced earlier in rheumatological disorders, specifically in rheumatoid arthritis, but soon it gained acceptance in treatment of IBD. Now treat to target means defining a treatment goal before initiation of any therapy and applying tight control and therapeutic adaptations to reach that target. So as we know, what's the basis of treat to target? As we know that the IBD is a relentless progressive inflammatory disease, and as time passes, because of this relentless inflammation, there is an accumulation of complications and bowel damage over a period of time. Now, the concept is that if an intervention is rightly applied at the onset of disease when the inflammatory damage has not occurred, the overall bowel damage can be prevented. So meaning of treat to target is that we do a baseline assessment of every patient. We define their risk factors and we define their risk of progression from low to high. And we decide our treatment targets based on a target board. Now, as we see that if you look at this target board, these are the various treatment targets which can be incorporated into our baseline assessment. The clinical response is the widest of all targets, which is on the outside. Now, as we move towards the bullseye, you see that you are going towards a deeper level of remission, and the targets to achieve becomes more and more difficult. The commonly used targets are the following: the clinical response, biochemical response, endoscopic remission, histologic remission, and the molecular response. So far, even globally and in India, molecular response is still not a validated thing. So these are the 4 targets which are commonly implied. Traditional definitions have been that if a patient has clinical response and has endoscopic mucosal healing, we call this as deep remission. Clinical response, mucosal healing, and histologic remission, we say that the patient is in complete remission or complete mucosal healing. So meaning of treat to target becomes that you do a baseline assessment, we prefix our targets, then we treat the patient as per our therapeutic targets, and then we reassess. Now at reassessment, if we are not able to meet those targets, then we go back to our planning board, drawing board, and then redefine and retreat the patient so as our final target is achieved, which is majorly control of inflammation and avoidance of long-term damage. Traditionally, the targets have been clinical. In Crohn's, these were the index, the Harvey-Bradshaw index, and CDI, and ulcerative colitis, it was the resolution of bleeding and resolution of diarrhea. Now, we all know that the clinical scores poorly correlate with objective markers of inflammation and endoscopic assessment, and half the patients in clinical remission will still have endoscopic and biochemical disease activity. Now, again, why do we need treat to target? Whether mucosal healing actually helps. So this was a study, a very good study on 67 patients of Crohn's disease, and it was seen that if proactively the colonoscopy was planned earlier in less than 26 weeks, and the adjustments in the medical therapy was made if mucosal healing was not achieved over a period of time, the cumulative probability of reaching mucosal healing improved in these patients. So based on available literature, a STRIDE consensus was initially planned, and the first consensus was published in 2015. So this was done by International Organization for Study of IBD, and they named these consensus statements as selecting therapeutic targets in IBD initiative. This was a consensus statement on appropriate evidence-based treat to target strategies in routine clinical practice. Rather than for trials, these consensus statements were given for practice. So briefly, when the STRIDE 1 came out in 2015 for Crohn's disease, the major targets defined were clinical and endoscopic, and clinical targets was resolution of pain and normalization of bowel habits, and endoscopic targets were absence of ulceration. Similarly, for ulcerative colitis, it was predominantly clinical and endoscopic targets which were defined by STRIDE 1. which was resolution of rectal bleeding and normalization of bowel habits and endoscopic healing of mucosa in ulcerative colitis. Ever since STRIDE-1 came out, the number of biologics, the number of small molecules have increased quite a bit. So the last literature review done by STRIDE-1 consensus was in 2013, and there was felt a need to revise these based on available current literature. So in between came CALM trial, which came in 2017, which clearly showed that if there were two groups in patients of Crohn's disease, which was one group was followed only on clinical management guidelines based only on Crohn's disease activity index, and another one was the tight control group where the dose escalation of therapy was done based on the clinical management guidelines in addition to the biochemical markers of fecal calprotectin and CRP. The results clearly showed that in the tight control group, the amount of remission, mucosal healing and complete endoscopic remission was much higher, and hence STRIDE-2 consensus were formulated and published last year in 2021. Now, STRIDE-2 are the updated therapeutic targets for our patients, and the STRIDE-2 consensus statements comprises majorly of 13 consensus statements. They aim to provide the contemporary recommendations for using different targets in IBD treatment course, and they are specifically focused on clinical practice rather than clinical trials. And it covers treatment targets for both adult and pediatric IBD patients as opposed to STRIDE-1 consensus. So what are the different headings under which these consensus statements are placed? So we have clinical targets, we have endoscopic targets, we have biomarkers, and we have quality of life and disability. So clinical indices comprise of two things, clinical response and clinical remission. So these are the most important short-term and intermediate treatment goals, and patients identify clinical symptoms as the most important parameters in their treatment. But clinical symptoms correlate poorly with mucosal inflammation in Crohn's, but fairly well in ulcerative colitis. Now, when we talk about clinical indices, in today's world, it is very important to know what are PROs or patient-related outcomes. When considering any signs and symptoms, they are becoming the standard of measure, and empirically derived PROs have been developed to satisfy regulatory requirements. So most commonly used PROs in Crohn's disease are PRO2, which have only two components, some of the weighted daily stool frequency and some of the weighted abdominal pain items from CDAIA score itself. For adult ulcerative colitis, the PRO again comprises of only two components, rectal bleeding and stool frequency. So coming to the targets per se, clinical response is an immediate treatment target, and we have to consider changing treatment if our initiated treatment has not met this target. And the clinical response, as per the statement, is defined as minimal 50% decrease in abdominal pain and stool frequency in Crohn's, and in ulcerative colitis, minimum of 50% decrease again in the PRO2 requirement of rectal bleeding and stool frequency. Now, clinical remission is an intermediate treatment target, and we have to again consider changing treatment if this cannot be achieved. Now, clinical remission, as per the consensus statement, is defined in Crohn's disease in adults as having a CDAIA score of less than 150, and in adults as having a partial Mayo score of less than 3. Please realize that clinical response or remission in isolation are insufficient to be used as a long-term treatment targets. So another change from STRIDE-1 in this was that this also encompasses the pediatric IBD guidelines. So in children, restoration of normal growth now is a long-term treatment target, and we have to consider changing treatment if we are not able to achieve that. So this is a new formal target which has been incorporated in STRIDE-2. The most important of STRIDE consensus, both STRIDE-1 and STRIDE-2, was endoscopic healing to achieve long-term remission. And treating to target of endoscopic healing is associated with improved long-term outcomes and may reduce the risk of bowel damage. So endoscopic healing is a long-term desired target as per STRIDE-2 consensus. Endoscopic healing has two components, endoscopic response, which is a short-term target, and endoscopic remission. So endoscopic response in Crohn's disease, as per the STRIDE-2 consensus, is defined as having a simple endoscopic score of more than 50% decrease from baseline, or a CDAIA score of more than 50% decrease. We say a patient is in endoscopic remission of Crohn's if the SES-CD scores becomes 0 and the aphthous ulceration score becomes less than 3, and the CDIS score if the patient does not have any ulcers and the score becomes less than 3. For ulcerative colitis, the endoscopic response, the Mayo endoscopy subscore decrease should be more than 1, or the UCIS score, which is commonly used now, or for a more than 2-point decrease from the baseline. Remission if the patient has a Mayo endoscopic subscore of 0 or the UCIS score is equal to 1. Now, assessment of endoscopic healing can be achieved by sigmoidoscopy or colonoscopy, and when not feasible alternatives in Crohn's disease, we can use capsule endoscopy or balloon endoscopy. Now, histological remission so far is not a treatment target in either Crohn's or ulcerative colitis. Nonetheless, we know that in ulcerative colitis, it could be used as an adjunct to endoscopic remission to represent a deeper level of healing. But it remains a target which may be incorporated in future, but as of now, it remains a high hurdle which is yet to be achieved. Transmural healing, similarly assessed by cross-sectional imaging of using a CT enterography or an MR enterography, is yet not a treatment target in either Crohn's disease or ulcerative colitis. But in Crohn's, it can be used as an adjunct to endoscopic remission to represent a deeper level of healing. One of the other changes from Stride 1 consensus was the inclusion of biomarkers as a formal target. Normalization of CRP to values to the upper limit of normal and fecal calprotectin to the range of 100 to 250 is an intermediate target now in ulcerative colitis and in Crohn's disease. In ulcerative colitis, CRP, ESR and fecal calprotectin can predict endoscopic activity, although fecal calprotectin we know is supposed to be better than at predicting models as compared to CRP or ESR. Now, high correlation of calprotectin with clinical disease activity, endoscopic and histological indices has been described in children and as well as in adults. And studies have also indicated that fecal calprotectin can be useful in predicting relapses in ulcerative colitis. So the most important component of these Stride 2 consensus is defining quality of life and disability. So absence of disability and normalized health-related quality of life are long-term treatment targets as per treat to target strategies. So the entire group has voted to include restoration of quality of life and reduction of disability as a formal long-term treatment targets. So implication of this statement is that if a given treatment is impairing quality of life, that treatment should be revisited even if deep healing has been achieved with that treatment. So we have to balance different targets. We have to have shared decision makings with the patient so as to maintain this quality of life, and not always everything can be achieved in every patient. Now, how do you measure quality of life? So these are some questionnaires which are available, and the recommended ones are the IBD questionnaire, the short IBD questionnaire, and for disability, there is an IBD disability index and IBD symptom index. As of now, all these questionnaires are implicated for clinical trials, yet not very commonly used in clinical practice. So again, coming to what's new in Stride 2. So now we have, as per Stride 2, time to expected response, remission, or endoscopic healing with different treatments have been introduced. Now added clinical response and clinical remission both, as well as normalization of CRP as immediate short-term treatment targets. Reduction of fecal calprotectin to an acceptable range has been added as a formal intermediate treatment target. Pediatric targets have been incorporated, and restoration of quality of life and absence of disability have been added as long-term treatment target. Transmural healing and histological response have been newly recognized as adjunctive targets, but they are yet not defined as the formal targets in the consensus statement. So to summarize, treat to target algorithm works in this manner. If the patient has been diagnosed with active disease, we decide therapy according to the risk. We aim for symptomatic response, which is a short-term target. We aim next for the symptomatic clinical remission and normalization of CRP, decrease in calprotectin to acceptable range and normal growth in pediatric population. and then go on to endoscopic healing, normalized quality of life, and absence of disability. So these are the ideal targets we should be aiming in every IBD patient. We can consider, but these are yet not formal targets, a transmural healing as per the radiology in Crohn's disease, and in ulcerative colitis, we should aim for histological healing. But yet, as of now, they are the holy grails which we have yet not achieved with the current therapeutic strategies. Thank you for a patient listening.
Thank you, Sumit. At last we made it. So any questions or comments quickly from chair?
Hello. Hi, Dr. Sumit. This is Dr. Parth. Yeah. So, what is your take on how would you extrapolate the findings of STRIDE to consensus in case of small bowel Crohn's disease? Because seeing for endoscopic healing is difficult because capsule endoscopy capsule may be retained, or else doing a balloon enteroscopy every time is difficult. So, what is your take on that?
So, good question, and the similar problems we face at all centers. So yes, balloon enteroscopy, first of all, is not available at all centers. Second thing, as you rightly said, the capsule can be retained. So in these cases, the endoscopic healing, you will have to take help of radiological, CT enterography and MR enterography. In clinical practice, what I generally practice at my center is to look for normalization of the biochemical parameters of CRP, and look for the clinical response, and then follow these patients up with radiological assessment. So again, these are not formal targets as per the STRIDE consensus, but then in every patient we cannot, go on for we have to modify, these targets as per an individual therapy. So maybe if available, a balloon enteroscopy, if documented earlier, there were significant ulcers. If the CT or NMR enterography is showing complete resolution with normalization of biochemical parameters and clinical response, I will generally follow these patients up.
Okay. So another thing, this time to clinical response for tofacitinib they have mentioned is almost 6 weeks. But in our clinical practice, we see that even within 3 or 4 days, this bleeding per rectum resolves. So why is that?
So in the consensus statement, there is I have hidden that slide because of time constraint. Yeah. They have given an expected time of response with different therapies.
Yeah. So it was very high for tofacitinib, 6 weeks.
It is very high for tofacitinib, but again, they have written down a rider there that it's based on expert consensus and not based on any real world or literature data. So I think we need to come out with the tofacitinib data from India, which I think will be robust in next coming 2 to 3 years, which will define it as, less than a week possible.
Thank you.
Bharat, one comment from you, Bharat. Then after that, we'll last comment.
This is Dr. Bharat, Dr. Sumit. Hi.
Hello.
So I have a small question for you. I have one patient with ileocolonic Crohn's disease who is on long-term follow-up. She's been having this disease for 10 years now. She's on 2 mg per kg of azathioprine. She has complete clinical remission and her inflammatory markers are normal. But every time, I did colon 3 times till now. So she's having this moderate mucosal erythema and erosions, which are not healing.
So do we have a baseline colonoscopy findings?
Yeah. She has, all the after-cells have disappeared, but a lot of erythema and erosions are persisting.
So there is definitely a clinical endoscopic response, but it is not a complete endoscopic response.
Yeah, their worry is about malignancy. She has a lot of pseudopolyps and this erythema and erosions. So should we escalate to biologics based on these findings alone in the presence of normal CRP? And
if your patient has achieved clinical response, if the biochemical parameters are within the normal range, there is no unexplained anemia or weight loss, and you have a partial response on endoscopy, it does not at present justify escalating the treatment. So these remain challenges of treat to target strategy. So in each patient, you have to assess the cost of therapy, the complications and the side effects of escalating therapy vis-a-vis what target we are trying to achieve.
Right.
So that's what I mentioned, that in all patients, everything cannot be achieved. So having some mild erythema and erosions and not having any large active ulcers, I would rather default on continuing with the same therapy rather than escalating for biologics, unless and until if there is an additional radiological finding of development of any early strictures or any new symptoms coming in there.
Right. And there's another small question. Does preparation affect findings, especially in UC, sir?
In ulcerative
bowel
colitis,
preparation, does it affect the findings we see in rectum and sigmoid? Or?
If you're talking about the screening colonoscopies in ulcerative colitis, yes, the bowel preparation will affect in picking up of dysplasias or mucosal abnormalities. So the preparation has to be really good. And if you're talking about assessing only the disease activity in ulcerative colitis, for that I think a sigmoidoscopy is good enough. You don't need a full-length colonoscopy. So we generally avoid any kind of bowel preparation if the disease is active clinically. So we do only a sigmoidoscopy for assessment of disease activity.
Thank you.
Thank you, Sumit. With that, we'll close this session. We got 20 minutes lunch break. And I thank all the chairpersons and panelists. So post-lunch, we have a slight change in the plan. Shaji Sebastian's talk is being cancelled because he had some family emergency. So we'll have only 3 talks after the lunch. So we'll join here 2:10 roughly. Thank you very much. Thanks, Sumit.
I have to speak about extraintestinal manifestations in inflammatory bowel disease. I'll start off with a case scenario. So patient is a 35-year-old male, a follow-up case of ulcerative colitis with pancolitis, who received steroid in his first year and was subsequently maintained on oral 5-ASA, currently presented with increased stool frequency with blood, with an SCCI of 7 associated with joint pain in the bilateral knee and the right ankle joint, with swelling, tenderness, and early morning stiffness. So this patient was diagnosed as a patient of UC with E3 disease, 3-year duration, presenting with a moderate flare with an extraintestinal manifestation. So at this stage, there are certain questions which we would like to answer related to the extraintestinal manifestations in IBD. First of all, what are EIMs, or what is the definition of EIM? As per the ECO consensus, EIM is an inflammatory pathology. So please mark the word inflammation. Inflammation is key to the diagnosis or the pathogenesis of EIM in IBD. So an inflammatory pathology in a patient with IBD that is located outside the gut and for which the pathogenesis is either dependent on the extension or translocation of the immune response from the intestine, or it's an independent inflammatory event which is perpetuated by the intestine, or it shares a common genetic or environmental risk factor with IBD. But the important point is inflammation. So now we need to differentiate EIM from other extraintestinal pathologies seen with IBD. So there is difference between EIM and difference between the extraintestinal complication. So if we look at the examples, then if we look at the joint and bones, that the classical arthritis, which could be peripheral or axial, are EIMs, but the non-inflammatory arthralgias, metabolic disease, bone disease would be complications. Similarly, inflammatory skin conditions such as eczema nodosa, pyoderma gangrenosum are the EIMs. However, the drug-induced conditions such as anti-TNF-induced psoriasis, cancer, infection, and nutritional causes could be the complications. The inflammatory conditions such as episcleritis, uveitis, scleritis are EIMs. Drug-induced cataract, nutritional IDDs would be complication. Primary sclerosis cholangitis is an inflammatory condition of liver associated with IBD, the EIM. Other etiologies such as Snaffeld, drug-induced liver injury, portal vein thrombosis, gallstone disease are complications. Orofacial granulomatosis could be an EIM or simply an extension of the intestinal pathology, and metastatic Crohn's disease oral cavity could be considered as an EIM. Thromboembolism is an important vascular complication associated with patients with inflammatory bowel disease. So the next 10 minutes, we would be discussing about these extraintestinal manifestations and their approach to treatment. First of all, why do these EIMs occur? So what is the pathogenesis of EIMs? Well, as we learned, EIM is an inflammatory condition, which is an extension of immune response from the intestine. So the pathogenesis also occurs hinged upon this. So the proposed mechanisms would be the ectopic expression of the adhesion molecules such as MADCAM1, which is usually expressed in the intestine, but if expressed in the liver, can attract the T cells there and can subsequently lead to liver injury. Similarly, T cells can also be carried away to the other sites by these non-specific adhesion molecules such as the VAP1 and may cause joint damage. The microbial associated etiologies such as molecular mimicry may cause T cells to react with the autoantigens, which react with the molecule with microbes in the extraintestinal tissues, and the antigen translocation can occur due to T cell damage. Certain non-specific inflammatory events which are independent of the intestine would be because of the enhanced inflammatory tone in the body with these cytokines, or priming of the innate immune cells in the body, which could again lead to damage at the extraintestinal sites. The third question is, when do EIMs occur? What are the risk factors for EIMs? So like IBD, EIM may have environmental risk factors, EIM may have the genetic risk factors. So similar to IBD, not to and cartridge have been associated with increased risk of sarcoidosis and uveitis. And if you look at the common risk factors in patients with advanced age, patients with advanced disease duration, and females may have higher predisposition to EIMs, but the evidence is heterogeneous. If you look at the disease phenotype, that patients across most of the series, Crohn's disease has more EIMs than ulcerative colitis. In Crohn's disease, colonic CD has more EIMs. In ulcerative colitis, pancolitis may be associated with certain EIMs such as PSC and pyoderma gangrenosum. Patients with severe disease again will have higher frequency of EIMs. And smoking, especially in the Eastern world, has been associated with EIMs. So we also looked at the EIMs in our cohort at AIMS, and we saw that patients with ulcerative colitis who are steroid dependent have higher frequency of EIMs, and patients with Crohn's disease who have colonic CD have higher frequency of EIMs. The smoking association is similar to the differences seen with relation to its IBD between East and West. So the study from Netherlands showed that smoking was associated with higher frequency of EIMs, while the study from our center did not relate smoking with the extraintestinal manifestations in patients with inflammatory bowel disease. The other question is, does one EIM lead to another EIM, or patients who have one EIM, are they predisposed to other EIMs? This was the Swiss IBD cohort study, which showed that about 60% patients had 1 EIM, but 20% patients has 2 or more, and 10% patients had 3 or more EIMs. Similarly, in our study also, we showed that about 5 to 7% patients with IBD have multiple extraintestinal manifestations. Does EM occur before or do they after? So about 1/4 of patients may have EM before the onset of IBD, but more than 3/4 will have EM which occur after the onset of inflammatory bowel disease. Now coming on to the type of EIMs. The 3 most common types are the articular, ocular, and dermatological. If you look at the articular EIMs, then they can involve the peripheral joints of the body or can involve the axial joints such as sacroiliac joint at the spine. The peripheral is again divided into type 1, which is postearticular, affecting the large joints, especially the weight-bearing joints such as the ankles, and occurs in asymmetrical fashion. Type 2, which is polyarticular, may involve both large as well as small joints in a symmetrical fashion. However, these two entities are not very distinct, and sometimes type 1 may progress to type 2 EIM. Axial EIM usually involves either the spine or spondylitis, may occur as sacroiliitis, or may occur in when both the joints may be involved. If we look at the other characteristics of these EIMs, so there are certain EIMs which are associated with the disease activity of IBD and certain which are independent. If we look at the articular EIMs, then type 1 has a strong association with the disease activity. That is, it will occur when the patient is in IBD flare. However, the other EIMs, which are the axial and type 2 peripheral, are usually not having, or the association is controversial. If we look at the natural history, type 1 is a self-limiting disease, usually lasts for less than 10 weeks, non-destructive. Type 2 peripheral arthritis may be long-lasting, but usually does not damage the joint. However, the axial involvement can lead to destructive arthropathies and complications in patients with these etiologies. If you look at the prevalence, then the peripheral arthritis is the commonest across all the cohorts, which includes a meta-analysis, the Swiss cohort, and the Indian study from our center. Axial involvement is usually seen in 2 to 5% patients, especially the ankylosing spondylitis, and sacroiliitis may be seen in about 5 to 10% of patients. An important point to note is that HLA-B27, which is seen in more than 90% patients with classical AS, is seen only in about 50% patients when it occurs occurring in association with IBD. An important thing to differentiate when we are evaluating a patient with joint pain is to differentiate arthritis from arthralgia. So as we discussed earlier, arthritis is an EIM. It occurs due to inflammation. So has inflammatory symptoms such as young age of onset, insidious onset, stiffness more than 1 hour in the morning, associated pain, tiredness, warmth, and this usually worsens with rest, improves with exercise. Arthralgia, on the other hand, may have a precipitating factor such as trauma or injury, increases with weight-bearing exercise, improves with rest. There is no definite evidence of inflammation. So it is important to differentiate arthritis from arthralgia. The dermatological EIMs, the commonest is the erythema nodosum, which usually occurs as tender nodules on the shin, which are painful. Pyoderma gangrenosum, which starts with plaque or nodules, which then usually spread horizontally and vertically, causing deep excavated ulcers, which may go up to the bones. And Sweet syndrome is a maculopapular pustular type of rash seen on the back in patients with IBD. It's a rare EIM, seen very infrequently. If we look at the disease characteristics, then of all the 3, erythema nodosum has a strong association with disease activity. For other 2, it is controversial. Erythema nodosum is usually non-scarring and non-deformative. Pyoderma gangrenosum may lead to deformity and complications. Aphthous stomatitis is usually limiting, which may occur as oral aphthous ulcers in the oral cavity. Commonest is the EIM, seen in about 6 to 9% patients, more common Crohn's than UC. Pyoderma gangrenosum, seen in about 3 to 4% patients. In India, it was rare, seen in less than 1% patients. And aphthous stomatitis is very common, seen in about 5 to 10% patients, and parallels the disease activity. Of the ocular EIMs, 3 most important are episcleritis, when it involves the membrane over the sclera, scleritis when it involves the sclera, and uveitis when it involves the middle layer of the eyeball. Again, if we look at the disease characteristics, episcleritis is the mildest, presenting as mild hyperemia, some eye irritation. Scleritis and uveitis may present as orbital pain, headache, blurring of vision, photophobia. Episcleritis matches the disease activity. The other 2 association is controversial. Episcleritis is self-limiting, heals without scars. Other 2 may have pulmonary presentation and may lead to vision loss if not treated in time. Episcleritis is the commonest, seen in about 3 to 5% patients. Scleritis is very rare, and uveitis again seen in about 5 to 10% patients in different series. In India, it was seen in about less than 1% patients of inflammatory bowel disease. Primary sclerosing cholangitis, which are hepatobiliary extraintestinal manifestations of IBD. Usually, if we look at 100 patients of PSC, 60 to 80 will have IBD. If we look at 100 patients of IBD, then about 5 will have PSC, but this data is from the West. If we look at the Asian and other Indian series in the study from our center, of about 1400 patients with IBD, only 0.4% had PSC. It is only most commonly seen in patients with ulcerative colitis, and that too with pancolonic disease. Patient may present with fatigue, fever, malaise, myalgia, pruritus, recurrent episodes of cholangitis, and subsequently may lead to end-stage liver disease. The usual survival is about 10 to 12 in hospital-based and 20 years in the population-based cohorts. These patients may have the biliary complications such as cholangitis, cholelithiasis, cholecystitis, malignant complications such as colorectal cancer, GB cancer, cholangiocarcinoma, and other complications which are related to the vitamin deficiency such as osteoporosis and steatorrhea. The IBD which is associated with PSC has certain distinctive features which differentiate it from the routine ulcerative colitis. So these patients may have rectal sparing about 1/3, may have backpass colitis about 20 to 40%. Most of these patients have pancolitis. The disease course is mild, the histological inflammation is mild, but they are associated with high risk of colorectal metastasis in about 10 to 50% of these cases. So now, once we have discussed about the IMs, how do we diagnose them? A very important aspect is the multidisciplinary care, where it involves other specialties. So for arthritis, rheumatology, for skin, dermatology, and for eye ophthalmology. And the same was also endorsed by the recently published guidelines in LGH. So now coming back to our patient. So this patient had peripheral arthritis, which was a type 1 type of post-articular arthritis, which was probably related to his disease activity. At this point, the questions are, what are the treatment options? Are they same as the treating IBD or different? And what would be the treatment approach or algorithm for these patients? So we look at the articular EIMs, then we start off with the patient. Our rheumatology consultation is very important, and we need to differentiate EIM from other etiologies. So arthritis needs to be differentiated from arthralgia. With patient with arthritis, the etiologies could be axial, type 2 or type 1 arthritis. The treatment depends upon the associated IBD activity. In patients who have active disease, for type 1 arthritis, treatment of IBD is important, plus short course painkillers like NSAID and local steroids. For type 2, the patient is mild IBD, then sulfasalazine may help in addition to local steroids and some short-term COX-2 inhibitors. In patients who have severe IBD, use steroids or anti-TNF. For axial arthropathy, if short-term NSAIDs are not helping, then anti-TNF is the treatment of choice because steroids, methotrexate, sulfasalazine are not effective. If the IBD is in remission, for type 1, local steroids, short-term COX-2 may help. For type 2, if the patient was on mesalamine, it can be switched to sulfasalazine. Otherwise, patients may require methotrexate, or if the disease is not responsive, then anti-TNF. For axial arthropathy, again, short-term NSAIDs. If patient is not responding, then these patients may require anti-TNF. For arthralgia, the underlying cause needs to be ruled out. Patient needs to be supplemented with calcium and vitamin D, and physiotherapy may help these patients. Important point is the use of NSAIDs in these patients. The classical NSAIDs are associated with increased risk of IBD, should be avoided. However, the COX-2 inhibitors such as etoricoxib and celecoxib were shown to have similar risk of flare as compared to placebo in patients with remission. However, they were not compared to the routine NSAIDs. So the evidence is still uncertain on them, but they can be used for sure. If you look at the dermatological IAMs, again, a dermatology consultation is important. EIM needs to be differentiated from other conditions. For the skin EIMs, if the monodosis is self-limiting, treatment of IBD may improve. However, this patient may require topical steroids. Refractory cases may require steroids or anti-TNF. For pyoderma gangrenosum, the mildest variety can be improved with topical tacrolimus. However, the more aggressive cases may require steroids. If not, then cyclosporin. If not, then anti-TNF agents. An important point to note is that of all extraintestinal manifestations of IBD, the only RCT available for anti-TNF is that for pyoderma gangrenosum, where it led to significant improvement. For other EIMs, for anti-TNF psoriasis, drug need to be stopped. Patient may require treatment for psoriasis, or some cases may require stropinumab. Other conditions need to be treated specifically for their own etiologies. Again, same pathway for ocular EIM. Ophthalmology consultation, differentiation from other conditions. For episcleritis, self-limiting disease, topical NSAIDs may be sufficient. Some may require steroids. Scleritis and anterior uveitis, urgent consultation, time-bound management with topical steroids, oral steroids, if not improving, then and immunosuppressants or anti-TNF agents. Other etiologies will require their own specific treatment. For primary sclerosing cholangitis, no definite medical therapy. UDCA in moderate doses may help. Higher doses are harmful. Immunosuppressants, no definite role. Vedolizumab, there was a lot of hype because of its BADCAM alpha-4 integrin blocking property, but in cohort series did not lead to any improvement. In fact, led to worsening in one study. Again, antibiotics such as vancomycin and metronidazole inconsistent results. The interventions like ERC may be required in patients who have a dominant stricture with obstructive jaundice, but 2 or 3 important points. Prophylactic antibiotics is a must. The stricture needs to be dilated, minimum duration of stent placement, and breast cytology to rule out cholangiocarcinoma. Because these patients had a higher risk of malignancy, colorectal cancer screening yearly, and for GB cancer and cholangiocarcinoma, yearly ultrasound with biomarker assessment. Patients with end-stage liver disease, debilitating cholestasis may require transplantation. However, cholangiocarcinoma needs to be ruled out. The role of newer agents. So if a patient doesn't respond to anti-TNF agent and has severe or debilitating IM, these newer biologics or small molecules may help this patient in certain circumstances. However, point to note, there is no RCT for any agent. Only evidence is from post-hoc analysis and cohort series and from other inflammatory conditions such as rheumatoid arthritis or psoriasis. Vedolizumab may lead to improvement only with improvement in intestinal activity. So AIMs which parallel the intestinal activity may improve with vedolizumab. Some evidence for improvement in arthritis, but some studies also showed paradoxical worsening. No evidence for other conditions. Tofacitinib, a JAK inhibitor, may improve peripheral arthritis, and has some role in the treatment of spondyloarthritis and cutaneous and ocular arthritis. Ustekinumab, again, IL-23 blocker. The only contraindication would be spondyloarthropathy because of phase 3 trial was prematurely terminated because of non-response. However, peripheral arthritis, cutaneous and ocular EIMs, if refractory, may respond to ustekinumab. So if you look at the step-ladder approach of EIM, it starts with the topical treatment, ends with anti-TNFs, and if the patient is anti-TNF responder, then these newer EIMs may help these, newer molecules may help these patients. We come back to the patient again. So he had posterior ocular arthritis, treated with topical steroids for IBD, local steroids and FOX2 inhibitor. Initial improvement followed by worsening, so required oral steroids on which he attained remission and was maintained on oral files. However, 3 months later, he had a severe flare, required hospitalization and intravenous steroids, but this time developed swelling of the right lower limb and developed thromboembolism. So coming on to thromboembolism in IBD, 2 to 4 times increased risk in the general population. Overall prevalence about 1% in our study. Both Crohn's and UC similarly affected. The risk factors include hospitalization, severe disease, surgery, steroids, and high-dose JAK inhibitors. Anti-TNFs may be protective. Both thromboembolism and IBD mutually influence each other. Thromboembolism leads to increased the aggressive disease course of IBD and increased mortality. IBD leads to complicated thromboembolism with more recurrences and more severe phenotype. Approach: prophylaxis in patients who have hospitalized, who have aggressive disease, usually till discharge. Therapy with anticoagulation, usual duration 3 to 6 months, may be prolonged if the patient has aggressive disease course. So to summarize, it is important to distinguish an extraintestinal manifestation from the routine complications. Multidisciplinary care is very important for optimal management of these patients. A step ladder of approach to therapy should be followed. Associated IBD activity needs to be considered. Newer molecules and small molecules may add to this ladder and may expand the therapeutic options in coming days. Thanks a lot.
Good afternoon. Thanks to Dr. Peddy and colleagues in the...
Thanks, Saurabh. Wonderful overview of extraintestinal manifestation in IBD. Any questions and comments from chairpersons or moderators? We also have Dr. Girinath Lekkala, Professor of Gastroenterology from Andhra Medical College online as well as chairperson. And any comments from the floor?
Thank you, Dr. Saurabh. I think you covered quite extensively, including the tiniest of the details, I think, within this short span of 15 minutes.
Thank you, sir.
I think nothing much to ask, but actually a few common things. In patients, you said that 80% of the PSC can have associated IBD. So, we need to do screening colonoscopy for all these patients. And any role for preemptive starting on a mesalamine preparation, even colonoscopy is normal and with no symptoms?
So we need to do colonoscopy and take biopsies. So if both the biopsy and colonoscopy is normal, then the patient doesn't need any treatment for it.
And sacroileitis is very common, and the patient not responding to COX-2. Any role of steroids? I mean, you can we start on steroids if there is no response to COX-2?
May help in short term, like pulse steroids or methylprednisolone, but the evidence suggests that if the patients are not responding, then Anti-Dns would be the best choice.
Yeah, because going on to biologicals, I think too invasive, I feel, yeah. And how about third, indomethacin? I mean, people sometimes do write Indocap for extraintestinal manifestation, especially arthralgia. And how it is when compared to COX-2? I mean, still we should go with COX-2 or sometime maybe short course of indomethacin?
Yes, sir. So if we go by the evidence, then the evidence suggests that the routine NSAIDs like indomethacin, ibuprofen, or diclofenac may cause flare of IBD. So should be avoided if possible. The COX-2 inhibitors, again, the evidence is limited, but as per the evidence, they may be safer than these NSAIDs. So they may be given as the first choice of patients who have pain. But if the patient is not responding and has severe pain, then we may give a short course of these agents also. So maybe the COX-2 followed by indomethacin. And secondly, if you look at the exolarthropathy, the rheumatologists do use steroid, methotrexate, and sulfasalazine in the patient. So if the patient is not affording, and if the Anti-Dns is contraindicated, then he may use a short course of steroid along with sulfasalazine and methotrexate.
Sometimes I think we tend to miss avascular nucleus of the hip, especially patient on steroids. I think we should not forget.
Yes, sir.
Thank you. Thank you so much.
Any other comments? No. So if no comments, we'll move on to the next session. Thanks, Saurabh. Thank you once again for taking your time.
Thank you.
So I thank both Dr. Srivenu and Dr. Abhilash for being moderator for this session. So we move on to an interesting talk that's interventional endoscopy in IBD, very exciting field and very interesting topic. We got a recording from Dr. Gursimran Kochar. He is Director of Interventional Endoscopy at Allegheny Health Network in Pennsylvania, USA. He is not able to join live for Q&A because of the time difference. To moderate this session, I request Dr. Sharath Putta to join the chairpersons. Dr. Vamshidhar is not here today, I think. Chair, you have to sit there.
My name is Gursimran Singh Kochar. I'm the Associate Division Chief and Director of Advanced Endoscopy at Allegheny Health Network in Pittsburgh, USA. I would like to wholeheartedly thank Yashoda Hospital, Dr. Petty, and the SAIA leadership for inviting me to talk to you about something I'm very passionate about, is the role of interventional endoscopy in IBD. It's a new frontier. The learning objectives of my talk are to learn the advances in management of strictures, fistulas, and also in colitis-associated neoplasia. So these are my financial disclosures. So management of IBD traditionally has been split between the surgery, the medical therapy, endotherapy, and obviously nutrition and psychological support. The traditional role of endoscopy has been mainly diagnostic. We need the biopsies, and then we go from there on, and then in cancer surveillance, be it the chromo or the high definition white light endoscopy. And then therapeutic procedures have been largely limited to endoscopic balloon dilatation, and then disease surveillance for surveillance of mucosal healing. So these are some of the complications that we encounter, and we're going to discuss few of these today. And this is, I think, the spectrum of interventional IBD as I see it from where I am, on the role of balloon dilatation, endoscopic stricturotomy, sinusotomy, abscess drainage, and so on and so forth. So let's start with stricture. So 3 years ago, I, along with Dr. Shen, put together this global interventional IBD group. We have Dr. Ajit Sood from India in this group as well. And we published our first ever guidelines of how to manage strictures in patients with Crohn's disease. So endoscopic stricturotomy is defined as a procedure in which we use the electroincision knife to widen the lumen. Needle knife, you are all familiar, is used in ERCP. Extension of needle knives have been the modern knives, and we use them. And it can be performed in a radial, horizontal, or circumferential fashion based on the configuration of the stricture. We defined it as stricturotomy when we just use the incisions to widen the stenotic lumen of the GI tract. If we assess those incisions by clips, we call it endoscopic stricturoplasty, and we define this in our consensus paper. So let's start with the case. We have a 19-year-old young boy who presents with symptoms of weight loss, fatigue, and abdominal pain. His MR enterography shows mucosal hyperenhancement at the TI, about 5 centimeters. And they said there's a questionable stricture in the ascending colon. They were not sure. And then he subsequently undergoes a colonoscopy with one of my partners. And these are the pictures from his colon. That's ascending colon, and that pinhole is the opening along with that small fistulous opening. He was sent to me. We end up balloon dilating him at that time. This is after dilatation to 18 millimeters. As you can see, the cecum is here, and here is the TI. We discharged him home. He was diagnosed with Crohn's disease, and then we start him on infliximab. 6 months later, he again comes back because he was having symptoms, and we do a colonoscopy, we find this. So in this patient, would you again repeat balloon dilatation, but inject steroids at this time, refer the guy to surgery, switch his infliximab, or consider endoscopic stricturotomy? There's a bias. He came to me, so we did do endoscopic stricturotomy, and I would like to share this video with you guys. So you see the TI opening to 11 o'clock, and then you have the cecal opening. So I use an IT nano knife. This is one of my go-to knives because the tip is insulated. I'm going to cut this lesion towards the luminal side. And the whole idea is to cut the scar tissue. And once you start doing this, you'll realize the moment you cut sufficient amount of scar tissue, the stricture just gives away. Like there's no force in that where you have to push against. So we cut that TI stricture, then we cut a circumferential stricture in the ascending colon or the colonic stricture. I cut it at least to the part that my colonoscope can pass through. That is usually a diameter of 15 millimeter. This is the appendix. This is how the stricture looks now. And now I want to get into the TI. So I was having resistance. So that's when I decided to cut a little bit of more scar tissue to get that feeling of giving away. And once you do a few cases, you realize it just kind of gives away. There's not much force. And then we are able to enter the terminal ileum. As you see, the TI was not bad. It was not inflamed. There was not too much aphthous ulceration. Here's the image of the TI. It looked nice and shiny, no ulcerations, no erythema or inflammation. So at the end of this, we will do the clipping part. I use clips because A, I don't want these cut edges to go back, stick together. And secondly, I think they do help with delayed bleeding. So we clip the TI side, clip the colonic side, and that's how it looked. Patient was discharged same day home, no issues. We'll take one more case here. 51-year-old female with PSC and has a J pouch. She's an anal canal stricture. She got referred to us because she had a J pouch for 10 years. They were basically not able to do any pouch surveillance for the last 7 years due to inability to pass the scope, even the upper endoscope, the EGD scope through. She self-dilates herself twice a week. So in this case, these are the various options. This is, for the sake of argument, I list them there, but we decided to consider endoscopic stricturotomy again. So you can see this is the anal canal stenosis. You can see the dentate line right there. So this is a female patient, so we decided still to do a stricturotomy. However, being very cautious of the fact that I avoid the interior rectal or J pouch wall, which is attached with the posterior vaginal wall. You want to avoid heat in that region for the risk of rectovaginal fistula. So we will do not a full circumference cut, but a semi-circumference cut in this case. If you go in anti-clockwise direction, 12 to 6, semi-circumferential cut. And you're cutting the scar tissue out. And you will realize that, again, the same thing, the stricture kind of gives away and the scope was able to pass through. And then we were able to assess the pouch. So bring the knife all the way down nicely to 6 o'clock position, cut the scar tissue out, and then get into the pouch. And pouch was very badly inflamed. We did start her on different medical therapies after that. At this site, I don't use clips, but patient did well. It's been at least a couple of years. I've scoped her multiple times since then. We were not required to repeat the stricturotomy, so she did very well with that. The data on stricturotomy is limited. I must say these are largely case series or case control retrospective studies. Largely data comes from one predominant group from Cleveland Clinic. That's where I trained with my mentor, Dr. Boshin, and he did majority of the study. So as you see, the technical success is very high. However, the adverse event rate is also high. But as we go more into the adverse event, two things to keep in mind. Like you see 20% here, but the patients are 5. So even if one patient had bleeding, the complication rate goes up. So we have to keep in mind that when we look at pure percentages. But if we dive more into adverse events, we realize that the risk of perforation is very little, like 4 patients out of 200 compared to bleeding. The risk of bleeding is about 5%. And the risk of perforation is low because if you think of it, as we are dilating, we rely a lot on our endoscopy nurse and tech as to how much resistance they're feeling when the balloon is going up. Whereas when you're cutting stricturotomy, the knife is in your scope control, your foot is on the pedal. You can anytime take it off if you think you're cutting too deep. So what has been my experience at AHN so far since that initial series we published? We have done so far 93 cases, multiple locations, upper GI, ileocolonic, anal strictures, primary small bowel, primary colonic strictures. Technical success rate has been great. Bleeding, 5 patients, so about roughly 5% risk of bleeding. I had 1 perforation in the duodenum region. We were able to manage that endoscopically, and the longest follow-up period is more than 4 years. We had 1 patient that did require pouch surgery because of the pouch failure. So advantages of stricturotomy, in my opinion, you preserve the bowel length, you have more control. There was a study that showed similar surgery-free survival as ileocolonic resection for anastomotic strictures. I think the need for repeat procedures is less compared to balloon. And I think it's very good for anal canal strictures because you don't have to self-dilate or balloon dilate. Can we combine balloon and ESD? Yes, obviously. Balloon is still not out of the game. I don't want that to be the message. So here is a IC valve stenosis, young female sent to us with partial obstructive symptoms. I'm not able to get my scope through. So I would like to balloon dilate this first. Obviously, we start with a smaller size. This is the 15 to 18 balloon. Standard technique for balloon dilatation. I always like to visualize the lumen of the bowel through the balloon as much as possible. I like to see that whiteout that you see in the back, that whitening of the mucosa that tells me that enough stretch has happened. And once we did that, we were able to get inside the small intestine. The TI for the most part looked beautiful, like here. There was 1 stricture very close to the IC valve. And then I come back and we start doing the stricturotomy. Again, same technique towards the lumen, cut as much scar tissue as possible. And when I make the second incision, you'll see the stricture kind of gives away. And you can see that in the scope as well, that the colonoscope now readily goes without any tension. And that's the feeling that you are looking for. Scope can go in and out with no issues. This is the second stricture that we cut it more and see how wide the lumen is now, the stenosis, which was so tight before. So you were able to combine that, and then you use clips, as I do in this case. So this patient also did well. So it's a new technique. Everything can't be rosy and good about it. There is definitely a learning curve. It does require training and expertise, not only in how to use the knife, but also to understand the disease process of IBD. I think that is much more important than learning the endoscopy here, because IBD stricture is not same as peptic stricture, and where to cut and how much to cut comes with the understanding of disease. No billing codes. This is more of an issue in US because insurance doesn't have billing codes, so you don't get reimbursed for your procedures, and it's time consuming, can take sometimes upward of an hour. Complications, bleeding is still a problem. We're trying to figure out how to stop that from happening. So moving on to fistula from stricture. This picture basically shows the pathogenesis of fistula. You have a stricture that's going to block the path of the fecal stream, and then you're going to form a fistula and an abscess. This diagram basically shows the procedure of fistulotomy, in which you can pass a wire through, secure your fistular tract, cut the stricture, make the fistulous opening one with the lumen. We'll take this case, young male with good looking pouch mucosa, but having diarrhea, lots of bowel movements and aphthous ulcers. Was scoped in the outside hospital, then sent to us for further examination of the pouch. I do the pouchoscopy, I see the fistula, we put a guide wire through. This fistula causes fecal stasis. That's why you can have more diarrhea and the aphthous ulceration lead to inflammation. Again, we use an IT nano knife in this case. We're going to cut again towards the lumen. The idea is to cut open the tract, make it one with the pouch body so that there is no fecal stasis. And fecal stasis can cause inflammation, as we all know, so to avoid that part. So as you see, we cutting towards the luminal side, assess your cutting margins, and this is how the fistula looks tracked open. We're going to seal the cut edges with the clip. He subsequently improved in his clinical symptoms. He has not had aphthous ulceration since then. So what has been our experience with fistulotomy? 29 patients, 26 had a pouch-related fistula. It was successful in 26 patients. 3 patients still required surgery. 1 patient had a significant post-procedure bleeding that required hospitalization. So overall successful, and I think we did publish this in GIE a couple of years ago, or sorry, 2018, now 4 years ago. So in my opinion, endoscopic fistulotomy can be attempted in short fistulas, simple fistulas, should be used as an adjunct to your medical therapy, and can be used in both primary and secondary fistulas. Colitis-associated dysplasia, very important topic. So AGA came with their practice update. Basically, in nutshell, what they are saying is, if you have a resectable lesion with clear borders that's less than 2 centimeter, endoscopy is good. If it's larger than that, you can still do it as long as you can see the lesion clearly. And in other cases, they're recommending surgery. So let's discuss this case here briefly. 71-year-old female was referred back to me for a polyp that was found on surveillance colonoscopy in descending colon. She has history of ulcerative colitis, more than 20 years, has been on mesalamine. The polyp was non-lifting and measured about 25 millimeter. This here is the polyp in this region in the picture. I had done an ESD on her in a polyp in the rectum that came back as tubular adenoma, and her inflammation score was Mayo 1. So since it's a non-lifting lesion, should we just send her to surgery? IBD patient, UC, she will likely require a total colectomy, or we should consider endoscopic resection in expert hands. So we considered a second. I don't consider myself an expert, but for the sake of the answer, we had to put that in. But so in endoscopic resection techniques, we have endoscopic mucosal resection, endoscopic submucosal dissection, and now endoscopic full thickness resection. I think all of you guys are familiar with the EMR and ESD. It's the full thickness resection that we opted in this case because of only reason, the longer the history of UC, the more the fibrosis and harder the ESD or EMR becomes. So I'm going to show you this video. This is the polyp that I was showing you. This again is the polyp just marked in the middle here. So we take a scope in. So the procedure is straightforward. I do most of my colonoscopies with the cap. I'm sure you guys do. So I take a scope in. We try to find the polyp first, and sometimes it's subtle. You have to locate it just like here. So you can see now this is the polypoid tissue. And then we mark the polyp with the snare tip. Once the border has been marked, then we know how much tissue to come. This is how the device looks. The Ovesco full thickness resection device. Basically, it's a cap that allows the forceps to pass through. You pull the tissue in, you deploy the Ovesco clip and cut on top of the clip. That's your view, how you see the lesion. It's a 3-person procedure. So you have the scope and you need 2 attendants with you, 1 nurse and 1 tech or a fellow, and then you pull the lesion inside the cap. And once you see all the white markers are gone, you deploy the clip, and the deployment of the clip will be clear because the white ring will go forward. And as the white ring goes forward, you can then cut with the snare, and then you can remove the tissue with the scope. And this is how it looks afterwards. Nice clean cut. You do see serosal fat, but nothing to be worried about. The clip has sealed everything from the back. That's how the tissue looked. And the pathology came back as tubular adenoma as well. So we were able to save another colon, I would say. So in my opinion, the management paradigm of IBD is shifting. Endoscopy is, now coming into a position where it is going to be an equal player, hopefully in future with surgery and medicine. I think one of the aspects, nutrition and psychosocial has always been neglected in IBD patient, but I think that also requires an equal space along with surgery, medicine, and endoscopy to take care of the IBD patients. So in conclusion, patient first, please choose your patient very judiciously. Management of IBD is complex. Surgery should not be the last resort. Involve your surgeons early. endoscopy will continue to become a major player, especially as our techniques improve. And we have to make sure that our faculty and fellows are also learning these techniques. In the same regards, in regards to learning techniques, if you guys need to be involved, I am the chair for the special interest group through ASGE for intervention IBD. I welcome you all to join that. You guys can, touch base with me on LinkedIn or Twitter. And then this year at DDW, we'll be having a hands-on session for interventional IBD. And I would welcome any and all of you if you guys are attending the DDW this year. With that, I would once again like to thank the organizers, Dr. Petty and the SAIA group, for giving me this opportunity to be with you all guys virtually doing this conference. So thank you so much. And if you have any questions, please do feel free to get in touch with me. Thank you.
First of all, I'd like to
Thank you, Gursimran. So he's not live for Q&A, but I think you can share your experiences, and I don't do much of this endoscopy anyway. I think Santosh and some other people can share their experiences.
That was an excellent talk of some of the good cases, complicated cases, but they are very stable cases. So there are 2-3 cautious approaches we need to take when we are doing these procedures. One of the things is up-to-date scanning is important, and they should not have any pelvic collections and very active Crohn's disease before you dilate the terminal ileal strictures. Better to dilate one at a time. And if you go through the literature, the 3 centimeter strictures are likely to respond up to 90%. With 2 settings, it will respond perfectly fine. 5 centimeter strictures are not the ideal ones. They don't respond, and you cannot cross the balloon. If there are 2 strictures, one behind the other, it's better to dilate the distal one and then go after a few weeks and dilate both and come back. I agree with his terminal ileal bridge division procedure, which is pretty safe actually. I've done in a couple of cases. You don't need any clips there. Actually, it doesn't serve any purpose. But they are just because it's a right side colon and a thin area, so he's taking extra precaution. We can go with the clips over there, but rectal clips are useless. You don't need any rectal clips for that fistulotomy thing because it's a wide open, laid open fistula tract. So what are we clipping there? So that's what I wanted to ask him, but he's not available. Yeah, that's a concept, but you are widely opening and you are laying it open. No, once it is laid open, the scar formation will be on all directions. It usually doesn't go back like that. So I don't know what is their experience about fistulotomies. Yeah. And I think we should use the fluoro while doing that procedure also. No. In the crater. The terminal ileal one is different purpose. You didn't want that area to separate up and then leak out and then cause a delayed perforation. But I think the rectal one is controversial. I don't think there is a role for that.
No other questions. We'll move on to the last topic for the day. To moderate this session, I request Dr. Chalpati is online and Dr. Sriram, our colleague gastroenterologist at Yashoda Hospital. And I also request Dr. Vishwanath to join. He's the consultant gastroenterologist at Yashoda Secondary. The topic is COVID and IBD, which is very topical nowadays. It's by Dr. Deepak Parakal. He's a consultant gastroenterologist from Washington. He also won't be able to join live because of the time difference, but we can play his video.
Hello, good afternoon. This is Dr. Deepak speaking to you on the topic COVID-19 and inflammatory bowel diseases, all we need to know. I'm an associate professor of medicine at Washington University in St. Louis, and thank you, chairpersons, for inviting me for this talk. Here are my financial disclosures. Let's start with an overview of the topic. Let's start with IBD and risk of contracting COVID-19. Look at IBD patients with COVID-19 and the risk of adverse events, the impact of IBD medications on the risk of severe COVID-19, the impact of COVID-19 on IBD disease activity, and then finally data and guidance on COVID-19 vaccines in IBD patients. Let's look at IBD and the risk of contracting COVID-19. IBD patients do not appear to be at an increased risk of contracting COVID-19. We know this from two studies. One was a systematic review that showed relatively low incidence of COVID-19 in IBD patients. Published reference as shown here. A second study was published in the National VA database that looked at matched IBD patients with two patients without IBD. Seroprevalence studies also indicate that the risk of SARS-CoV-2 infection does not appear to be greater in IBD patients. And this includes early reports from Germany, Italy, and the UK that showed that the percentage of IBD patients showing evidence of COVID-19 infection was no greater than local populations and healthcare workers. Data from Mount Sinai showed similar findings when comparing IBD patients to seroprevalence in the city. Next, look at IBD patients with COVID-19 and risk of adverse events. The US National Database study from TriNetX with over 40 million patients showed that patients with IBD appeared to be at no increased risk of severe disease or death from COVID-19. Severe COVID-19 was defined as hospitalization and/or 30-day mortality. As shown here at the far right of the slide, after propensity matching, IBD patients were not at increased risk of severe COVID-19 or hospitalizations. Furthermore, data from Secure IBD Registry shows that in a multivariable model, age itself had a strong association with ICU ventilator use or death, with the majority of deaths occurring in those aged 60 years and older. Another finding from Secure IBD was that patients who had two or more comorbidities appear to also have a stronger association with ICU usage, ventilator, or death. Furthermore, another study from Secure IBD showed that patients who had moderate or severe disease activity appear to have a greater risk of ICU, ventilator usage, or death, especially seen in those aged 50 years or younger. Next, let's look at the impact of IBD medications on the risk of severe COVID-19. Data on this comes again from the previously mentioned Secure IBD Registry. At the point of final analysis, they had over 6,000 IBD patients with IBD and COVID-19, and they built multivariable models controlling for various factors including country, age, sex, race, ethnicity, disease activity by a physician global assessment, smoking, obesity, number of comorbidities, and time of report. And they looked at various outcomes from top to bottom. First, hospitalizations and/or death. Next, severe COVID-19, and then finally death due to COVID-19. And what do we see here in terms of the association between medications? First, they show that corticosteroids were consistently associated with increased risk of hospitalization or death, severe COVID-19, and death due to COVID-19. Furthermore, biologics such as anti-TNFs, interleukin 12-23 inhibitors, as well as anti-integrins, all were not associated with a adverse COVID-19 events, defined as one of the three outcomes. And even more interestingly, potentially a protective effect was seen with these medications. Furthermore, mesalamines, which were earlier on seen to suggest maybe a possible negative impact, were no longer shown to have such an association with adverse COVID-19 events in the updated analysis, as shown here. Other associations included showing that thiopurine monotherapy and, more importantly, anti-TNFs in combination with thiopurines appeared to increase the risk of severe COVID-19. This was shown in an initial analysis as shown here, and then an updated analysis published the next year, also from Secure IBD, of 6,000 plus cases, showed that clearly this association was true for anti-TNF use with a thiopurine with an adjusted odds ratio of 1.82 for hospitalization and or death, while the adjusted odds ratio was not significant for anti-TNF with methotrexate for the same outcomes. Next, let's look at the impact of COVID-19 on IBD disease activity. Now, we know that new gastrointestinal symptoms are common in IBD patients with COVID-19 infection. This was a study from Secure IBD of 2,917 IBD patients with COVID-19, where about 764 or 26.2% experienced new GI symptoms, as shown here, across a spectrum of abdominal pain, diarrhea, nausea, vomiting, or other non-specific GI symptoms. Furthermore, Dana Lukin and group published in the Clinical Gastroenterology and Hepatology that COVID-19 does not appear to have a durable impact on IBD disease activity. They looked at a longitudinal cohort of 118 IBD patients with COVID-19 infections and compared pre-infection versus post-COVID-19 infection IBD disease activity, and also looked at various time intervals 0 to 30 days and beyond 30 days and up to 10 days after COVID infection. They concluded that no significant impact during the 6 months of follow-up on disease activity was seen. Additionally, no impact on inflammatory disease markers, IBD-related surgery, or hospitalization. Now, let's get to the final section of data and guidance on COVID-19 vaccines in IBD patients. This is a general slide that's really more informative and tells you about all the many different vaccines that are currently available. Inactivated vaccines containing a SARS-CoV-2 virus that is chemically inactivated, which is Covaxin, which is available in India. Other vaccines are recombinant protein vaccines, such as Novavax. And then to the far right, you have the viral vector vaccines, such as the J&J vaccine and the AstraZeneca vaccine, also known as Covishield in India. And then bottom right, you have the RNA vaccines, such as Pfizer, BioNTech, and Moderna, which are mRNA-based vaccines. And then you have the few DNA vaccines out there being tested. So let's start with the first study. This was a study that I led as a co-principal investigator, along with, you see on the right, Dr. Alfred Kim from rheumatology. We published our first paper in the Annals of Internal Medicine that was titled The Effect of Immunosuppression on Immunogenicity of mRNA Vaccines to SARS-CoV-2 Infection. So we did a prospective cohort study, which at the time of the first paper had 133 participants with chronic inflammatory diseases, which encompasses IBD and various other autoimmune diseases, and had 53 immunocompetent controls. All of them had received 2 doses of mRNA vaccine against SARS-CoV-2 infection during the timeline shown here. And we looked at blood assessment 2 weeks prior and 20 days after the second dose of vaccine. And we tested anti-SARS-CoV-2 spike anti-protein, anti-IgG antibodies in all participants and neutralizing antibodies in a subset. About 32% of the patients had IBD, while 28% had rheumatoid arthritis. One of the key takeaways from our study was that glucocorticoids were shown to reduce immunogenicity of mRNA-based SARS-CoV-2 vaccination, as shown here, comparing those on prednisone versus those not on prednisone and those who were immunocompetent. Now, shifting briefly to the Clarity IBD study out of UK, This looked at patients who received infusions, either infliximab or vedolizumab, and reassuringly, after the second dose, about 85% of those who were infliximab treated and 86% who were vedolizumab treated seroconverted. As you see in these figures, some of the patients who had prior SARS-CoV-2 infection and received one dose of either of these medications also appeared to seroconvert. Another finding from Clarity IBD study was that there was an impact of combination therapy with infliximab or vedolizumab with an immunomodulator, as shown here, where patients who were on infliximab with an immunomodulator had the lowest seroconversion as shown here, and this progressively increased across the groups, with the highest seroconversion shown in those who received vedolizumab without an immunomodulator. Furthermore, another study from Clarity IBD looked at the impact of drug levels on seropositivity and magnitude of antibody response. With infliximab, they did show that those with undetectable infliximab drug levels were more likely to be seropositive for SARS-CoV-2 antibodies, and were further showed that a higher magnitude of SARS-CoV-2 antibodies were associated with undetectable drug levels. Now with adalimumab, they only showed that those with undetectable adalimumab levels were more likely to be seropositive, but did not show an association with magnitude of response. This is data from the Prevent COVID study run in combination with the Crohn's Colitis Foundation and led by Dr. Kappelman and Millie Long. Now the key takeaway points here were that overall, about 95% seroconversion was seen, with the lowest seroconversion about 88% seen in those who were on an anti-TNF with an immunomodulator. Furthermore, similar to the Coveripad study, this Prevent COVID also showed that being on corticosteroids was associated with lower mean anti-spike antibody levels as well as median anti-spike antibody levels. Now I'll show you one slide on Covaxin, which is available in India and used in autoimmune diseases. This, at the time of last check, was in a preprint status, and Dr. Padmanabha Shenoy et al. Looked at 136 consecutive patients with rheumatic diseases and without prior diagnosis of COVID-19. About 102 had autoimmune rheumatic diseases, for 34 were controls, and they measured anti-spike antibody titers 1 month after the second dose of either the Chad OX1, which is Covishield, or the BB-V152, which is Covaxin. Key things to be shown here is that in the middle you have the patients who had AIRD, and in blue you have those who received Covishield, and in orange you have those who received Covaxin. And you can see there here that antibody titers were higher in those who had the Covishield compared to Covaxin 1 month after the second dose of either of the vaccines. Do these vaccines work in terms of clinical efficacy, meaning in actual infection rates? So this was an initial study published from Israel, where they had 12,000 IBD patients and about 36,000 non-IBD matched controls, where breakthrough infection rates were quite similar in the two groups. Another study also from Israel showed that infection rates were similar in the IBD versus non-IBD, or those, while there was a clear signal for those who were treated with anti-TNF or steroids compared to other IBD patients. Now let's look briefly at the safety of these vaccines against SARS-CoV-2 in IBD. This was data from the Corel study that had about 246 subjects with IBD who had received at least one mRNA vaccine dose. About 57% had received Pfizer, 42% had received mRNA 1273 or Moderna. And overall, the adverse event frequency was 39% after one dose and 62% after dose 2. However, you'll realize that none of these were very severe or significant. Now, one of the key take-home points in this study was that the adverse event frequency was lower after the second dose, specifically in those as the patients grew older, or those who were on what was called as advanced therapy status, meaning biologics and other immunosuppressives, compared to non-immunosuppressive medications such as mesalamines. And this is further data on reactogenicity with these vaccines compared to the immunogenicity with these vaccines from the Coveripad study from our group, which looks at 441 participants, which was 322 CID patients and 119 controls. Now, the interesting finding here you'll see is that as the predicted titer increased, so did the number of symptoms as shown here in this figure. Furthermore, in a multivariable analysis, we showed that increasing first dose severity as well as number of symptoms after the second dose and certain symptoms after the first and the second dose, such as side pain, fever, and fatigue, were associated with increased likelihood of a response to the vaccine in terms of antibody titers. Finally, let's look at the role of booster doses among patients with IBD. Why do we need to have booster doses in this population? Well, this is a study from Clarity IBD that showed that in orange you have patients with vedolizumab, but focus more on the patients in green who are on infliximab, and they clearly show that there's a antibody decay after about 14 to 18 weeks after the second dose of vaccine. So this antibody decay would suggest that we likely need to consider a booster. Further data comes from specimens from our Coveripad study, which shows that at 3 months after the second dose of the vaccine, looking both at serum IgG anti-spike antibody titers, and especially concentrating on the patients who were on an anti-TNF monotherapy. Here, you'll see that those on an anti-TNF therapy, blue is bad, and the darker the shade of blue, the worse it is. And we show here that especially when it comes to the Delta virus variant, patients had poor anti-spike antibody responses. And similarly, blue being bad, patients on anti-TNF again showed poor responses after, especially to the Delta variant in terms of neutralizing antibodies. So clearly this shows that you have decay in those who are on anti-TNF, and they seem to have poor anti-spike antibody responses and neutralizing antibody responses again the more virulent newer variants, especially things like Delta. Now, at the time of this paper, we did not get a chance to test against Omicron, but that's further studies in process. So with all this, the ACIP came to the conclusion that especially for moderate and severely immunocompromised patients defined here, and especially I've put a sort of a red box around certain criteria that may be significant for our patients, which is active treatment with high-dose corticosteroids, 20 milligrams prednisone daily or higher, certain other medications such as TNF-alpha blockers, anti-metabolites. So your methotrexate, leflunomide, medications like that, which are often used in our patients, and other biologic agents that are immunosuppressive, immunomodulatory. In these patients, they do recommend that patients consider a original series as ideally 3 doses, 1, 2, and 3, and then consider a 4th shot or booster about 28 days after completion of the initial primary series. So I'd leave you with some final thoughts that certain IBD patients with COVID-19 are at an increased risk of adverse events, driven primarily by older age, comorbidities, disease activity, and steroid response, and then combination therapy may increase risk as well. But it is still important to get vaccinated in all our patients and to consider booster where they qualify depending on the country criteria. However, we should still use our medications since disease activity, of course, has a association with severe COVID outcomes. With that, I'll stop and thank you, and I welcome any questions in the Q&A.
Good afternoon, dear friends. Thank you, Yashoda.
Thank you, Deepak. So with that, we'll come to the end of the last talk. Any thoughts or comments from chairpersons, moderators?
Just a small controversial issue, sir. As we are seeing more and more variants, and our vaccine was developed 2 years back.
Do you want to comment out here? Because Zoom people won't be able to hear. People on Zoom won't be.
So as we all know, the vaccine were developed around 1.5 years back, and we have to keep on giving the booster doses every 3 to 4 months. Will they work? That is my question.
I think time will tell, Vishnu. So
Yeah.
nobody is sure. Any other points, Dr. Girna, Dr. Chalpati online?
Yeah, I think the major challenge that one of the things that we have faced during the pandemic is patient and primary care physician education. So many of them, despite the literature coming up during that time, but still majority of physicians, again not gastrophysicians, but primary care physicians at the village level and the town level, they had actually warned and made my patients stop their medications out of pure ignorance. So that was one thing which was lacking at that time. I think majority, stopped the medications out of fear, especially the azathioprine and biologicals. And in fact, considering steroid as one of the major treatment for COVID, so steroids were started or hiked up with their doses, and patients came out with a few of the adverse events and flares also as the pandemic waned off.
Yeah, you're right, Chalpati. I think we face that issue as well. So primary care physicians getting worried and patients getting worried themselves. They were stopping actually.
Yeah.
If no further comments, we'll close the conference. I would like to thank entire SAIA team and management of Yashoda for supporting this conference, and especially the people who worked on the ground, our digital team, Pavan, Ashish, Kiran, and other people who made this possible. By put a lot of efforts in. It's not easy to do a hybrid conference, live and offline and online. So I'd like to thank all my colleagues who supported the idea as well. With that, and all the chairpersons, moderators, and participants taking your Sunday off to come and participate in this conference. Thank you very much. You can have tea before you go. Thank you. Yeah.
Thank you, sir. Thank you.
Thank you, Chalpati. One group photo, please.